distinguished group of speakers. We have more than 23 non-national speakers, international experts with wide spectrum of activities and interest, as well as publications. I hope everybody will enjoy the conference, and I see you in all the activities soon. Thank you very much.
بسم الله الرحمن الرحيم. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon and welcome everyone to the 9th International Conference of the Jordanian Society of Hematology. We are so glad that you can join us in person and virtually. I am here with my colleague, Dr. Abdelmajid Arabiyat, who is a medical oncology consultant, and me, Majdi Al-Jaddai, the head of Medical Oncology Department at King Hussein Medical Center in Jordanian Real Medical Services. We are going to moderate this exciting session dedicated in breast cancer updates. Today, we are extremely fortunate to have Dr. Jose Angel Garcia, who is internationally recognized expert in the care of a breast cancer patient. Dr. Jose is a head the breast cancer unit at Medical Oncology Department Hospital, Clínico San Carlos in Madrid. He is also assistant professor of medicine at Complutense University of Madrid. He is also board member and coordinator of the Luminal Breast Cancer WG in the GCAM Spanish Breast Cancer Group. He has many publishing work exceeding 100 papers published in peer-reviewed medical or scientific journals, authors in numerous chapters and books in medical oncology. He also is investigator in multiple breast cancer clinical trials and translational research studies. I think Dr. Jose has a lot of experience to share with us, and just to ask all to keep all the questions until the end of the session. So, Dr. Jose, you have 30 minutes, you could start, please.
So, thank you very much for your kindly presentation, and it's my pleasure to share with you these minutes to share my experience and also to have your input about dealing with this breast cancer issue. So I'm sharing my screen right now. So just let me know that you can see the slides, and I will be. It's okay. Can you see the screen?
Could you please share it again?
You can see the screen, don't you?
No, actually. Would you share it again, please?
So,
yeah, just stop it and reshare it again.
Now you can see the screen, don't you?
Yes, that's fine.
It's fine.
Okay. So thank you again. Thank you very much. So it's my pleasure to introduce myself. Your colleagues have presented me. So I am a medical oncologist from Spain and the coordinator of the Luminal Working Group at HEICAN. And it's my pleasure to share my experience in the state of the art of treating and dealing with our ER positive, HER2 negative ABC breast cancer patients. So these are my disclosure for today's conference, and these are the disclaimer. So I aim to share with you that there are some changes in the treatment paradigm in treating our ER estrogen receptor positive HER2 negative breast cancer patients, and we are moving from from chemotherapy to a more target and endocrine therapy. So I will be highlighting this patient journey in treating our patients. And also I aim to try to define what are the pathways that lead to the ER resistance and how can we prevent the endocrine resistance and to restore the endocrine sensitiveness. And finally, what are the rationale behind a dual blockage treating and dealing with these patients, not only targeting the ER pathway, but also other pathways in order to improve the outcome of our patients. As you know, the innovation and the clinical investigations is due a deep knowledge about the breast cancer biology, and we know that breast cancer is a clonal expansion of a single cell that is achieving a more and more aggressive behavior due some dynamic changes in their genome. So there is a limited replicative proliferation. There is also autosufficiency of the growth signals, and insensitivity to the anti-growth signals, escaping from the apoptosis, and finally a sustained angiogenesis and metastasis. So treating and investigating all these milestones of the breast cancer, we have been developing some clinical trials, first of all preclinical and then early stage development of clinical development of new innovation, and we have achieved a good outcomes with our patients. As you know, ER, the estrogen receptor, is a nuclear protein that is involved and is overexpressed in nearly 2 out of 3 breast cancer patients. And we know that we can treat this breast cancer either inhibiting the ligand, the estradiol, or even targeting the ER with avoiding the transcriptional activity of the protein. But we know that nearly all of our ABC patients will achieve new resistance and new and there will develop new metastases. So we try to restore the endocrine sensitiveness and try to prevent endocrine resistance, targeting other pathways, as for instance knowing all oncogenes like the ER mutations, or targeting the cell cycle in the cell cycle survival pathways, or either other signaling pathways as P3K, AKT pathway. So there are 3 main points. First of all, to try to restore the mechanisms of endocrine therapy resistance, targeting the alteration survival of the cell cycle pathway, targeting other signaling pathways like P3K, AKT and other pathways, and finally trying to target the new proteins of the new ER mutation. So let's begin with all these mechanisms. So we know that cyclin D1 and cyclin D3, amongst the kinase-dependent cyclins CDK4 and 6, are very important protein that regulates the cell cycle control. And we know that these protein, these complexes, are overexpressed in the ER breast cancers. So we know that these complexes are inactivating by phosphorylation the retinoblastoma, the RV, and leading the transcriptional, leading the activation of the transcriptional activity with the releasing the E2F factor, and then moving all the cell cycle from the G1 to the synthesis of DNA. So we can prevent this signaling of the cell, inhibiting this enzyme with the CDK4 inhibitor, and then restoring the control of RB and preventing the proliferation of the cells, and so we can achieve growth control and also a loss of the replicative ability of the cells, and then with a cancer control. So let's highlight now, focus on the CDK4 and 6 inhibitor. So we are trying to describe the mechanisms of action of these CDK4s and 6 inhibitor agents. We are going to overview the main data in terms of the randomized clinical trial biomarkers and safety. And finally, we have achieved a good endpoint in terms of primary PFS, but also we are trying to see what about the overall survival data. And we have several clinical trials in different populations. One populations in a very sensitive population that includes de novo metastatic breast cancer, a less sensible population that are in the second line, and even a very heavily treated population. So I have highlighted this population, these cohorts of patients, like a traffic light in green, very sensitive, in orange, like resistance, and in red, in heavily treated. And we are going to overview these trials, Mona Lisa 2, 7, and 3 in a most sensitive population, Monarch 2 in a secondary resistant patients, and in Paloma 3 with palbociclib in really heavily pretreated population. So let's see what about the key secondary endpoint. So first of all, we know that nowadays we have 3 agents, 3 CDK4 and 6 inhibitor, palbociclib, ribociclib, and abemaciclib. And I want to highlight that the cyclin D1 amplification occurs in nearly half of these patients. And also there is a CDK4 gain in almost 1 out of 4 patients. So it's more important in terms of preclinical in preclinical data to inhibit cyclin D1 and not cyclin D3. So it's most important the inhibition of cyclin D1. So sorry. So these are the primary endpoints of PFS of the randomized clinical trial on the first line with these CDK4 and 6 inhibitors. We have 3 randomized clinical trials with ribociclib, and 1 with palbociclib, and another 1 with abemaciclib. So the most body of evidence in terms of premenopausal, postmenopausal aromatase inhibitors, partners, or fulvestrant or SERD came from the ribociclib. But anyway, all of these agents have shown to improve the PFS, almost doubling the median PFS from 14 months to nearly 25, 26 months, with a reduction of the likelihood of the event almost 50%. So we have good news for our patients, but we are trying to identify what are the cohorts of patients that can achieve more benefit from one CDK4 or 6 inhibitor or the other. We know that we are studying some biomarkers in order to try to identify whose patients should be should be treated with one or other agents, and we have made many studies, clinical studies, including cyclin D1, P16, all the pathway or the PIK3CA mutation of ER mutations. But my colleagues from the Hospital Clínico Barcelona, my colleagues Alex Prat and co-authors have studied what about the intrinsic subtypes, molecular subtypes according the PAM50, the Prosigna tool, genomic assess, and we knew that almost half of all the Mona Lisa program patients has luminal A breast cancer. Nearly 1 out of 4, 25% have luminal B. The rest, all basal-like or HER2 enriched. So we knew, we have known that these subtypes are prognosis. I mean that luminal A behave better than luminal B or HER2 or basal-like, either with placebo or with ribociclib. But we have also observed that those patients with more aggressive behavior, like luminal B or HER2 enriched populations, have a really good improvement in terms of median PFS with ribociclib. So we have learned that ribociclib can improve the outcome of the most aggressive patients. This is not the same with palbociclib. We have some data from palbociclib studies, and we saw that not luminal B or HER2 enriched, but luminal A patients achieve a highest control with palbociclib. So that showed us that maybe, because these are preclinical and hypothesis generating studies, that maybe the most aggressive patients should be treated with ribociclib. So these are the safety profile and the tolerability of the three drugs, palbociclib, ribociclib, and abemaciclib. All these drugs has a good safety profile that is very manageable and predictable and very easy to deal with. And so we have seen that there are some difference in terms of preclinical data. But what about the most important overall survival? So as I have told you, we're going to overview these Mona Lisa 273, Monarch 2 and Paloma 3 trials, and we are trying to make a whole knowledge of these trials. So let's start with the Mona Lisa 2 trial. So Mona Lisa 2 trial is a placebo-controlled phase 3 randomized placebo-controlled ribociclib plus letrozole in the first-line treatment of all these postmenopausal metastatic breast cancer patients in the first line. So the study was designed to explore the activity and the safety of ribociclib in the first line in postmenopausal women. And Professor Ortobagi, as the leader author, has shown us that the primary endpoint was met with an improvement of median PFS moving from 16 months to 24 months with a hazard ratio of 0.67. But the main key secondary endpoint was overall survival. And this slide is one of the most important slides and the most important secondary outcome clinical trial data of the last 21 century or 20 years of the last year, that we have seen that with ribociclib, these postmenopausal women with breast cancer achieve an outstanding and impressive and very exciting overall survival of more than 5 years, 64 years, with a delta, with a clear difference of more than 1 year in terms of overall survival with a hazard ratio of 0.67. So at least we meet the secondary endpoint. So we are really very happy for our patients that ribociclib has shown to improve not only the primary endpoint in terms of PFS, but also the overall survival with a delta of 1 year. So as you can see here in the slide, the improvements in terms of ribociclib contributions versus the placebo control is higher and higher with the longer follow-up, with nearly more than 10% of improvement in terms of overall survival in patients that are still alive in the 5th and the 6th year. We have reviewed the different populations in terms of overall survival from MONALEESA-2. This was presented by Dr. Usabeshi in last San Antonio conference. And as you can see here, not only the ITT population, but also the key subgroup analysis have shown an improvement in overall survival in patients in all these clinical tiers, including the only bone mets populations, the visceral mets populations, the patients with a very high burden disease, and also in those patients who received previous exposure to the adjuvant chemotherapy. We also, with ribociclib, in these postmenopausal women, we have seen that we can delay the time to the start to the chemotherapy. So these are the take-home message of the MONALEESA-2 trial. Ribociclib plus endocrine therapy in this ER-positive, HER2-negative breast cancer patient postmenopausal improve PFS, overall response rate, overall survival, has a manageable safety profile, so it deserves the first line as a therapy option in this cohort. What about the MONALEESA-2 study? I mean, MONALEESA-7. MONALEESA-7 is almost the same study of MONALEESA-2, but with perimenopausal and premenopausal women. So the median age of these patients were nearly 40 years old. So our colleague presented this data from MONALEESA-7, premenopausal women in the first line, were allocated either to suppression ovarian agents plus aromatase inhibitors and ribociclib or placebo control. So again, we have seen an improvement, an outstanding improvement in terms of overall survival in the ITT population. So we can summarize that our patients can live more and better with a larger overall survival with a delta of nearly 1 year with a hazard ratio of 0.24. So we're very happy with this result as well. Not only the primary endpoint in terms of PFS and overall survival, but also the quality of life was improved with ribociclib. So we can conclude that ribociclib plus endocrine therapy in these luminal premenopausal breast cancer patients improve PFS, outstanding improvement, nearly 1 year, improve overall survival in these otherwise very aggressive breast cancer patients, had a predictable and manageable safety profile, improve as well the quality of life. So it deserves to be considered as the first line for all our premenopausal women. What about the MONALEESA-3 patient? Okay, so when we were designing these MONALEESA studies with ribociclib, we saw that fulvestrant may be a good endocrine backbone to be combined with target therapy. We saw that from the first Falcon study, when we saw that maybe fulvestrant could be even better that aromatase inhibitor. So we decide to design these trials, including fulvestrant as a control arm, with or without ribociclib. And there were two cohorts of patients. There were a very sensitive patients, de novo patients, and were a very resistant patients in the secondary endpoint. So with this ribociclib and fulvestrant, we saw that the overall survival was also improved with ribociclib plus fulvestrant if you compare with the placebo control fulvestrant, not only for the first line but for the second line. So in both cohorts of patients with improvements of nearly 1 year. Our colleague from Italy, Professor Di Laurentiis, has presented in last San Antonio conference the overall survival data of the first line de novo and late relapses patients in the MONALISTA 3, and we have also know that ribociclib could improve the overall survival mostly in this very first line population. So to conclude, from MONALISTA 3 trial, we know now that ribociclib plus fulvestrant in this ER-positive HER2-negative ABC improve median PFS, improve overall survival with a hazard ratio of nearly 30% and with a consistent safety profile. What about other agents? We don't have any data from palbociclib or abemaciclib in the first line, so we have to explore the data in terms of overall survival in the second line, I mean in the second therapy in the resistant populations. And there are also nice data from abemaciclib in these resistant breast cancer patients coming from the MONALISTA study. So these pre and perimenopausal women endocrine therapy resistant were allocated either to abemaciclib plus fulvestrant or placebo controlled plus fulvestrant. So, and we saw also to improve overall survival from 37 to 46 months with a delta with a difference of nearly 9 months. We have seen that this improvement in overall survival was in the visceral metastases more than only bone mets, and also in these patients with primary resistant population. So we have learned that the addiction of abemaciclib to endocrine therapy significantly improve PFS, overall survival data, overall response rate, and also the exploratory subgroup analysis suggests that patients with visceral metastasis and primary resistance had a higher benefit. And what about palbociclib from Paloma 3? So Paloma 3 was a placebo-controlled phase 3 study in most heavily treated populations. I mean that these patients were treated not only with one first line of endocrine therapy, but was also allowed to be treated with 2 or 3 endocrine therapies before, and either with a chemotherapy. So they are not a so pure secondary second therapy.
Please, Dr.
So
Hussein,
we have learned.
please,
Yep.
you have 4 minutes, please.
Okay, I will want to conclude for this CDK4/6 inhibitor that ribociclib is the only CDK4/6 inhibitor that has shown to improve an overall survival in all the cohorts. Now let's see in a couple of minutes another pathway. Let's see the P3K/KT/mTOR pathway. This pathway is very important cellular pathways, including proliferation, angiogenesis, metastasis, and visceral mets. We have learned that that we can target this pathway targeting either the mTOR, the P3K, or the AKT. So we know that in the Bolero-2 trial, we can target mTOR, and we have known that we can improve PFS, but everolimus is a toxic drug, including gingival stomatitis. So let's see what about the P3K. So the P3K enzyme is a heterodimeric protein, including a regulatory subunit and a catalytic subunit, including 4 isoforms. And we know that these mutations occurs in nearly 40% of these patients. We also know that there are different hotspots in the gene that we can that can translate to a mutation and activation of this pathway. And also we know that the patients that harbors the tumor harbors these mutations have a lower response to chemotherapy and survival. So we are trying to restore the resistance targeting these biomarkers. So we have learned from the SOLAR-2 trial, that is a randomized clinical trial, that those patients that has P3K mutant tumors can achieve an improvement when combining with P3K inhibitor. So we shown that in SOLAR-1 that in these P3K mutant cohorts, the PFS was almost double with alpelisib, but not in the non-mutant cohort. So we have learned that we have at least biomarkers to identify whose patients should be treated with alpelisib. We have also new data in those patients previously exposed to the CDK4 inhibitor, and we have also learned that we can identify those patients not only in the tumor tissue but in liquid biopsy with ctDNA. With this ctDNA status of the P3K gene, we have known that the PFS can be double with alpelisib. So we have also nice data in terms of clinical significant data in overall survival with alpelisib in this cohort of patients, moreover in visceral mets patients. And finally, we have a new agent, alpelisib, that has been approved in many countries. So we are really happy to know what are the patient journey for these patients, and we can know the status of the gene not either with PCR, with NGS, in liquid biopsy and tissue. And this is my last slide. We should include the biomarker P3K mutations as the first tier in the actionable mutations in breast cancer, because we can improve the outcome of our P3K/CA mutation patient with alpelisib. So finally, just to conclude, that the presence of PIK3CA mutations may be associated with worse clinical outcome in patients with ER positive, HER2 negative, mutant PIK3CA mutant ABC, and the clinical outcome may be improved using a combination of P3K inhibitor-based therapy. So thank you for your attention. I apologize if if the conference has been a little longer, and I appreciate your comments. Thank you very much.
Thank you very much, Dr. Jose, for this nice presentation. And I will go directly to the question of the audience, which will be shared by Abdelmajid with the expert. Please, Abdel.
Thank you, Dr. Jose, for this interesting talk. And the floor is open for any questions. Please, the audience.
Yes.
Assalamu alaikum.
Yes.
Could I ask a question?
Yes, please.
Thank you, Dr. Jose. But in real practice, we didn't see that much difference between CDK4/6. I believe the CDK4/6 is all the same of the activity, and so providing the PFS, the hazard ratio between all of the trials is the same.
So I misunderstood the question. I'm very pleased if
And I believe
so,
there's no difference between the activity of CDK4/6. And I believe it's a group of the same effects, and there is no difference between like for example, between the palbociclib and ribociclib in real world practice.
Yeah, so I appreciate your comment. I know that there is an on-class effect of these CDK4/6 inhibitors, including targeting the same mechanisms of action. So someone can consider that all these agents are the same. However, in my opinion, there are some clinical data that these agents are not the same, because not only in the preclinical data, including the inhibition of the CDK4 but not the CDK6 in the clinical assays that we have performed in our institution, but also because there are some clinical data that in different cohorts of patients, some agents have achieved the primary outcomes. For instance, in PALAS and in the Penelope, in the neoadjuvant therapy, palbociclib failed to show a clinical improvement in the adjuvant setting, but not abemaciclib. Or, for instance, in terms of overall survival data from Mona Lisa 2, 3, and 7. And so we are awaited, and we will be pleased, and we are crossing fingers that, for instance, palbociclib could show an improvement in the Paloma 2 trial, but we don't have this data so far. So, in my opinion, we should treat our patients according the clinical data that we have been achieving from the randomized clinical trial. I mean, for instance, in my humble opinion, I think that for premenopausal women, I think that that ribociclib should be considered as the first options according to the data of Mona Lisa 7. I think that there are good data in resistance and high burden disease patients with abemaciclib, and also I think that we should try to make an effort to identify the clinical outcomes in the main randomized clinical trials in order to try to choose the right agent for the right cohort of patients.
One question. Triple negative metastatic breast cancer. Triple negative. Triple positive. Sorry.
So I think that the HER2 is an oncogenic driver, and we should try to blockade the HER2 at the first time with the anti-HER2 agents, including trastuzumab, pertuzumab, TDN1, or trastuzumab deruxtecan. And now we have seen that we have very nice data in targeting the HER2 populations, even in these triple positive breast cancer patients. So in my opinion, there are no chance nowadays with CDK4 inhibitions in the HER2 triple positive population. I think that there are coming new agents, including tucatinib, deruxtecan, and any others, pertuzumab, and any other anti-FRAN conjugates, and we should try to keep a continuous blockage of the HER2 pathway instead of the ER. We had some nice data in the triple positive population with neratinib as extended adjuvant therapy following the anti-HER2 inhibition in the adjuvant setting. But I think that we are not in the prime time to include the CDK4 inhibitors in the triple positive population.
I have a patient, triple positive, and PIK3 mutated. Is it beneficial?
Okay, that's a good question. In the triple population, in the PIK3CA mutated, there is a clinical trial from our side, from HEICAN, the Alphabet trial, that we are trying to include alpelisib with the anti-HER2 blockade as a second line. But these are, hypothesis generation, and we are awaiting a longer follow-up of these clinical trials. But I agree with you that these we should try to identify the right target in the triple positive population breast cancer patients.
Any further questions?
Yeah. Dr. Qadir.
I have a question regarding the ESR mutation. When you do the ESR mutation, you decide to use fulvestrant or aromatase inhibitors as first-line treatment with ribociclib. It can differentiate to you which to use in first-line setting, AI or fulvestrant with ribociclib in first-line setting.
So my dear colleague, I agree with you. I think that those patients with ER mutations should be treated with SERD, with new deregulator, but not with aromatase inhibitor. And we have learned from the PADA-1 study from Professor Vidart in last San Antonio conference, that if we are making ctDNA tracking as a liquid biopsy, we should consider to change the aromatase inhibitor for a SERD, for a fulvestrant, instead of aromatase inhibitor plus ribociclib. I agree with you. There also a very nice data from Emerald study with a new oral SERD, elacestrant, and we have learned that elacestrant can improve the PFS versus the treatment physician criteria following CDK4 and 6 inhibition in the first line. So I agree with you. We should try to look for the ER mutation status and try to include these patients with new SERDs like fulvestrant or any other SAN, caminestrant, and fenestrant, geridestrant, that are being developing instead of continuous and keep going and continuous the aromatase inhibitor plus CDK4 inhibitor inhibition. So a very nice questions, and I'm very glad that about this issue. Thank you.
Thanks.
Dr. Khossi, please. there is a special category of hormone positive HER2 negative breast cancer, which is HER2 enriched. Could you please explore more about the significance of this subgroup of breast cancer?
So you do mean the ER positive PIK3CA mutant patients? So
hormone positive.
we are hormone. So sorry. Yeah.
Should I repeat?
So
okay, a special category of hormone positive HER2 negative breast cancer, which is HER2 enriched. Could you please explore more about the significance?
So thank you. That very good question as well. Very good question. We have seen that those patients that otherwise are really luminal breast cancer patients, according to immunochemistry results, including ER HER2 negative, but with PAM50 and with a genomic size, these are HER2 enriched patients should be. There are a real high risk population with a very bad prognosis, but we have learned that these HER2 subtyping categories is not only prognosis but also predictive, because we have seen from my colleague Alex Pratt and colleagues studies that these HER2 enriched molecular subtype luminal breast cancer patient populations should be treated with ribociclib, and there is coming a very nice clinical study here from Spain, and the Harmonia study that we are trying to test what are the outcome of these patients allocated either with palbociclib or ribociclib, in order to show that not all the CDK4 and 6 inhibitors agents are the same, but there are some difference in terms of treating this very otherwise very bad prognosis population. So thank you for your query, and I'm very happy that you consider all the same concerns that you have are our concerns, and we try to, all together from our side, trying to improve the outcome of these patients with more biological features and more genomic studies. Thank you.
Thank you, Dr. Hussein. We will move to the next session now.
Thank you for your.
Thank you.
So take care, and I hope that all your fellows are well and you can overcome the COVID pandemic. And I'm I'm looking forward to see you in person next time. Thank you. See you.
Thank you once again, Dr. Jose. I think all the audience have enjoyed your presentation. Now we will go to the next session.
Thank you.
موجود السبيكر. سبيكر موجود. هذا السبيكر انا مش فاتح يا شباب. هيك شغال هذا. السلام عليكم. بسم الله الرحمن الرحيم. Good afternoon, everybody. I am glad to have the second session of JSH Symposium in Hematology and Oncology. And our talk will be on acute lymphoblastic leukemia, we are glad to have Dr. Debro Yalo. She is from King College Hospital and HS Foundation Trust, Department of Hematological Medicine, King College Hospital, Denmark, London. She is a consultant hematologist in specialist diagnostic and lymphoma and coordinator Southeast Hematological Malignancy Diagnostic Service, Southeast Genomic Laboratory, HEOB, and Hematological Malignancy. And she's a membership of KHUB Immune Effector Cell Therapy Research Group and member KHP Hematology Research Group meeting, PhD second supervisor, King College London, and PhD thesis committee member, King College. And she has a lot of research and papers. I choose few of them, like clinical and prognostic significance of small paroxysmal nocturnal hemoglobinuria in myelodysplastic syndrome and aplastic anemia, and outcome of older patients with primary central nervous system treated routine clinical practice in the UK. Methotrexate dose intensity correlate with the response and survival. And the third one, ALK positive large B-cell lymphoma with strong CD30 expression, diagnostic pitfall and resistance to brentuximab and gerizimab. And the last one, and there's a lot of papers for her, she is a known international speaker, prevalence and activating JAK2 terrorist kinase mutation V1617F in Budd-Chiari syndrome. And Dr. Deborah will update us on acute lymphoblastic leukemia. Welcome, Dr. Deborah, and the floor is yours.
Excuse me, you don't, Professor, you don't mind if we can record your presentation? Yes? Okay. Thank you.
Welcome, Dr. Deborah. You hear me, Dr. Deborah? The floor is yours.
Thank you very much. Thank you for the kind introduction. I'm just going to share my screen with you. So hopefully, can you see that? Is it correct or?
Yes, yes.
No, we didn't see your slides.
Your slides not yet. But you, yes, you are.
Okay.
On the screen, yeah.
And now?
No,
not yet. Not yet.
Okay. Right. Well, this is a tablet.
Could you please stop sharing and restart the sharing again?
Okay.
Okay, please.
Right.
That's okay.
Yeah, thank you.
We're off, are we? Great. Okay. Thank you very much. Hang on a second. Oh, right. So great. Thank you for your for this kind invitation and your introduction. So I'm going to change tack completely and talk to you about acute lymphoblastic leukemia, and particularly talking about what was new in ASH last year, and in summary to talk about how we manage ALL in adults up front, what we do in the case of relapse, and then I'll talk to you about CARS too. So as you all know, the biggest challenge with acute lymphoblastic leukemia is keeping people in remission. In children, we've had massive success. Up to 90% of children are now cured, although we do know in those small numbers of children who relapse that only up to 50% can be salvaged. So relapse in children is a big concern. But in adults, although we get them in remission, nearly all adults relapse, and the leukemia-free survival is only around 30 to 40% at 7 years. And there's probably a variety of reasons why that happens. Partly it's because they have a higher incidence of the poor prognostic subgroups. So obviously you know that they get more Philadelphia positive ALL, more likely to get the adverse complex cytogenetic karyotypes, KMT2A translocations, And even though the children get KMT2A, that tends to be in the infants, but it becomes more prevalent again in the older adult. And then when you try and give chemotherapy to the older adult, they have poor tolerance of treatment, both biologically and ability to tolerate in terms of counts. And then in ALL, we'll know the holy grail is to get a measurable residual disease negativity. We know that patients with that, as I'll come on to show you in just one slide, are the ones that have the best outcomes, but only about 30% of adults with current upfront regimens become MRD negative after induction. So, of course, we're looking at how we can improve induction regimens and how we can move targeted agents that have to date only been used in relapsed refractory leukemia into the first line. So this is data that everyone in ALL world is familiar with, which is old data now, but consistently across all the study groups have shown that molecular failure, so MRD positivity at the end of induction, is associated with a poor outcome. Probably the most important measure of all biologicals in ALL is whether you get them MRD negative. So that was shown across the large study groups of the German, Italian, French, and the British studies also. So what are we doing to try and address this? Well, one of the ways is to look at the antigenic targets in BALL that we can harness. So this is just a schema of how leukemia develops from the progenitor lymphoid cell to the mature cell. And there are some obvious targets that we could exploit. First, of course, CD20 with rituximab, which is present on most pre-BALL cells, although not universally present on BALL. Perhaps a more attractive target is CD19, which is indeed present on the vast majority of BALL cells, although we do know that the cells are not entirely dependent on it, and you can have relapse with CD19 negativity. And then there's CD22, which is present on the vast majority of ALL, or not so commonly on the KMT2A translocated patients, but this has also been utilized. So what's the data on that? Well, rituximab, the data now goes back several years over many large-scale trials looking at the addition of rituximab to the chemotherapy backbone. And the data which most international groups took on was that from the GRAL study, which was a large cohort of adult patients giving rituximab to the CD20 positive ALL cases. And this was the overall and event-free survival, a clear difference of advantage for adding rituximab in induction. Now, you may be aware that the UCAL14, which is the large randomized trial in the UK, did not show a superiority of rituximab, which may have several reasons. We only gave rituximab in 4 doses rather than the 16 to 18 doses of other groups. And also we gave it regardless of CD20 status. So even though the data didn't come out in our own trial, we have now adopted this practice in the UK of adding 16 doses of rituximab to all adult ALLs that are CD20 positive. Blinatumomab is a bispecific T engager which has anti-CD19 and anti-CD3 arms. You know, the aim is that it brings together the tumor and the T cell, leading to cell killing. And in relapsed refractory ALL, this was published a few years ago now, showed relatively good CR rates, CRI rates of about 44%, which was favourable to the alternative at the time, FLAG-IDA, but with a relatively short median duration of response, just 7 months. But it's found its use more obviously in the MRD positive situation, where patients that have more than 0.1% ALL detected by flow cytometry or molecular methods at the end of induction, blinatumomab given up to 4 cycles can have a negativity rate of approaching 76%. And although the duration of the MRD response is not long, it enables patients to get to an allograft in a position that they may have a long-term remission. Blinatumomab is quite difficult to administer if any of you do it in your centres. It's a 28-day continuous infusion, but relatively well tolerated. There's some concerns about some neurotoxicity, relatively limited CRS and tumour lysis syndrome, but usually very well managed in the outpatient setting. Just coming on to the last targeted therapy that's in routine clinical practice, inotuzumab, an anti-CD22 antibody conjugated to calicheamycin, much higher response rates than blinatumomab, up to 80% CR and CRI, again with a relatively short duration of response. And the concerns people have had about this drug is the risk of veno-occlusive disease or sinusoidal obstruction, where that seemed to be related in part to this drug, but also underlying liver conditions, fatty liver, and dual alkylators in patients that have had transplants. But this drug is being used certainly as a bridge to allograft or as a bridge to CARs in refractory patients. So what else can we do up front? Well, this has long since been known, but probably hasn't been widely worldwide adopted, which is that if you look at the same cohort of patients aged over 16 to 25 who would perhaps be treated on pediatric protocols or on adult protocols, just the intensity of the pediatric protocol alone seems to improve outcome in every study. So this is not adding any targeted agent. This is not looking at differences in modified forward therapy. It's purely about the intensification of the chemotherapy up front, which has led to lots of groups looking at whether we can combine both the chemotherapy intensity in older adults and adding novel agents. So I'm just going to share with you some of the results from ASH. This was the GMAL group, which presented their first data of their large trial looking at Philadelphia positive and negative ALL after consolidation 1, having a targeted approach depending on molecular failure. So in B-ALL, they added blinatumomab, and in T-ALL, they added nelarabine. It's quite a complex trial, but it has essentially a BFM pediatric-inspired backbone, quite intensive chemo, a lot of asparaginase and high-dose methotrexate, with a view to having a risk-stratified transplant arm. So they presented their first 770 patients from 78 centres in Germany, a mixture of subtypes, B and T ALL. Quite a few of them were had a high BMI and liver steatosis, which is obviously important with the amount of PEG asparaginase that's involved. But this is their initial results. Very impressive CR rate across the board. Not surprisingly, the CR rate falls with the high-risk groups of patients, and also the Philadelphia positive are less likely to have a molecular CR after induction. But overall, they were finding molecular response rates of approximately 75% following induction. And when you look at who they added the targeted agent to for molecular failure, 40% of those went on, 40 patients went on to have blinatumomab with a 55% molecular response. Now, that might seem relatively low compared to the data I just shared with you, and that's in part because they just got one cycle and then carried on the protocol. But when you look at the overall survival of those that are in molecular failure, now you're seeing 75 to 79% overall survival at 3 years, which is much improved on the previous molecular failure data from the same group. So really exciting that intensifying the chemo, even in molecular failure, can have long-term positive outcome. This is the whole cohort, overall survival for this group, 76% at 3 years. Clearly, age still has a factor, partly due to the ability to deliver the chemotherapy, but importantly, they were seeing similar outcomes across subtypes. So I think this is really exciting data showing the benefits of being able to extend pediatric-inspired regimens up to the age of 55. And indeed, in the UK and with consortiums across the NOFO group, we are looking at this in a trial. This is a very large trial, which is encompassing pediatric and adult ALL up to the age of 45. It asks several questions. For those that are lucky enough to be in the low-risk group, the children with low-risk ALL, we're looking at omitting the anthracycline and omitting pulses of Vincondex in maintenance. But those that are high-risk, adding INO up front, or 6-thioguanine in maintenance. Those that have the ABL class fusions, so you know this is the BCR-ABL-like ALL, which have a gene expression signature very similar to Philadelphia positive ALL, but without the BCR-ABL translocation. Those patients are being offered a TKI. And those very high risk for relapse are being stratified to a CAR T or high risk blocks and an allograft. So this is an exciting trial, which is just at the sort of early stages in the UK and Europe. So what about those older adults that just can't tolerate chemotherapy? Well, this was published a couple of years ago now, which was from the MD Anderson, looking at lowering the dose of the chemo backbone, the total opposite of what I've just described, but adding in atezolizumab up front to see whether that improves outcome in this poor risk group. And this group therefore had a hyper CVD backbone, which is no anthracycline at all, rituximab of CD20, and this was the data. So a plateau appears to arrive around 50% overall survival at 3 years, which I think is pretty impressive for the older adult with ALL. So to back that up, there was some more data at ASH coming out of the GRAL and ELN group, which was this Idh1 study, which has a very modest background of chemotherapy, Dex, Vinc, intrafecals, and some cyclophosphamide later in induction, but low dose. And low dose in atezolizumab, two inductions with 5 doses in total, no rituximab. And in consolidation, no further INO, but a very low dose chemotherapy backbone, and then POMP maintenance for 18 months. So they presented the first 90 patients, 81% managed to get all 5 doses of INO, and only 6 of this 90 went on to allograft. Very poor risk cytogenetic group, lots of them with either a low hypodiploid or near triploid phenotype, pH positive and KMT2A, so a representatively poor cytogenetic group of people. And this were the impressive results. CR induction 186%, induction 2 raising to almost 90%, with 73% MRD negative after induction 2. So extremely favourable outcomes. Quite minor toxicities in terms of the usual hematological. Liver, which obviously we worry about with INO, was at 8.8% grade 3 and 4, with sinusoidal obstruction syndrome just 3%. They had some deaths, and overall they had 13 patients that relapsed and 1 died of COVID. So this is the data graphically represented. I think there's probably a plateau appearing, although the numbers are small towards the end of this curve, but 80% almost survival at 1 year, dropping down to just around 50% after 2 years for a very poor risk group of patients who are elderly with almost no chemotherapy with an outpatient regimen, I think is very exciting. So what do we do in the UK? Well, unfortunately, we don't have access to a lot of these drugs up front. We currently treat our over 60s on a reduced intensity chemotherapy schema. Those of you that are aware, we had a trial called UCAL 60+, which has arms of intensive, non-intensive, depending on fitness. We're allowed to use imatinib for pH positive patients, and we don't transplant them, generally speaking. For a fit adult that's over 30, we use our UCAL 14 backbone. We add rituximab for the CD20 positives and imatinib for the Philadelphia positives. And then if they are MRD positive at the end of induction, we add blinatumomab as a bridge to transplant. And the children, TYAs and young adults, we try and enroll in our altogether trial. Do we transplant them? Well, yes, we do. In the UCAL 14 trial, we transplanted on the basis of age, over 40 if there was available donor, high-risk cytogenetics, your MRD status and your white count. We've slightly adapted that policy in recent years because I think older adults that go MRD negative are not considered so high risk, but we still offer a CR1 allograft, VUD or sibling to those with high-risk cytogenetics and if they are MRD after induction. If you're under 40, a TBI is the standard of care. For those over 40, an FMC transplant. But we also have an ongoing clinical study in the UK looking at FMC versus a cyclo-low-dose TBI conditioning because of the evidence from the paediatric world that TBI is a very effective conditioning in children. For adults that relapse, we have limited options, which is based upon our NHS-funded guidance, but we can use blinatumomab for MRD positive and for frank relapse for pH negative individuals. we can use Inotuzumab for any B-ALL that's CD22 positive, and for pH positive relapses, they can transfer to Ponatinib. And then coming on to the next part of the talk, we have Tisagenlecel, so our CAR T for the under 25s, whether or not they are pH negative or positive. So I'm just going to give you some quick go through some CAR data for relapsed ALL. As I said, in England, this is entirely for the under 25 population. The only CAR we have licensed in the UK is Kymriah, which is a second generation CAR 41BB construct. And it was the Eliana data, which you'll be familiar with, that led to the pivotal trial that led to its license. This was a global study over 25 centres, 11 countries on 4 continents, a massive achievement. The autologous CAR product was manufactured either in the States or in Germany and was expanded ex vivo before being shipped back to the centre. To enter this study, the time of the trial, you had to be more than 3 years old and less than 21, frank relapse, and the median age of the individuals were 11, heavily pre-treated. Many of them had had a prior allo, and most of them went into the CAR with very heavy disease burden. So this is the original results that were published about 3 years ago now in the NEGEM, showing that 66% CR rate on an intention to treat basis. And I think it is important with CARs that we do look at the data on intention to treat, because we know that there is a problem with manufacture or holding individuals to get to a CAR, and there's a significant number of individuals that don't get infused. But of the patients that were infused, 81% went on to get a CR, and the median survival was 19.1 months in this initial data set. So the ASH before last, this was updated. They talked about their first 97 patients, similarly aged and heavily pre-treated. And overall, they informed us that 82% of children or young adults got to a CAR, meaning there was an 18% drop-off rate, 8% because of manufacturing failure, and 10% because of death. So that is an important consideration with the CAR T world, is how we can either shorten the time to manufacture or even think of alternative sources of CAR T cells, such as allogeneic CAR T cell. So this was the prolonged follow-up data. 82% of those infused in CR, and of those infused, 98% became MRD negative, and at 24 months, the median duration of remission was not reached. So based on this, the Kymriah product became available for use routinely in the NHS, and it was decided that it could be for all individuals from the ages of 0 to 25, so slightly outside the Eliana study. And NICE, which is the UK's mechanism by which drugs are funded, is letting this on an early access scheme called our Cancer Drugs Fund. So the way it works in England is that we have a national CAR T panel where experts in the field will meet to discuss all potential children and young adults in the country as to whether they are eligible and where is the best approved centre for the child to travel to, therefore making sure that there's equity of access for the whole population. And showing how that worked, we presented our data at ASH the year before, looking at how many patients that we'd screened through this panel. And we had looked at 66 patients. 60 of them were that went on to have be considered for CAR, so 6 were not eligible. And in the end, 49% infused. So that similar level of dropout that I described from the original Eliana study. They were heavily pre-treated. Up to half of them had already had an allograft. Now, the practice is changing now, where we are more looking at using CARs earlier in somebody's therapy. But at this time, there was lots of children previously transplanted or young adults previously transplanted who had no other options. So the toxicity was relatively acceptable. We know that they get CRS, cytokine release syndrome, around 20%, neurotoxicity, around 10%, expected cytopenias and infection, and about 70% developed hypogammaglobulinemia. And this B-cell depletion is used sort of as a surrogate for effectivity of the CAR. And that was still present at about 50% at 12 months following the CAR therapy. So this was the data. The CR rate in the first 90 days was very good at 95%, 79% MRD negative, so in line with the data that we'd previously seen. And the 12-month overall survival, 86%. Now, patients did relapse. 4 of them relapsed with CD19 negative disease, which is a concern for the CD19 CARs, and certainly something we're looking at in the future about whether we could choose other targets or, in fact, even dual targeting CARs. And the other question, which this study didn't answer and is an open question, is whether these children, if they go in remission, or these young adults require an allograft afterwards, and that really is up for debate. So this is just a brief overview of patients that come to King's for Kymriah, how we see them in the clinic and schedule their CAR T therapy. So we review them, we assess them for fitness, we apheresis them. The apheresis that goes to central laboratory for manufacture, and then they come in for lymphodepletion and the CAR. So patients who are eligible on the NHS can undertake treatment in this manner. So very briefly to finish, I've got a couple of minutes. I wanted to talk to you about what the unmet needs are for ALL. Clearly, we do not have a CAR in the UK for adults over the age of 25. Currently, we cannot give a CAR T-cell for individuals with CNS disease. As I spoke about, some patients have CD19 negative escape, and that particularly seems to be a problem with individuals pre-treated with blinatumomab, where up to 20% of those can be CD19 negative, meaning we need to look for alternate antigens to target. As I mentioned, the CAR T manufacturing and delivery failure can't be underestimated, and there's a lot of interest in allogeneic CAR for that reason. And then the CAR itself, we know the licensed CAR is a second generation, and people are looking at newer CARs with different kinetics as to whether they could potentially help with the lack of CAR T persistence or the CAR T exhaustion that happens with the current product. And then the real concern, which everyone asks me about, which is what are we doing about TALL? And yeah, that's certainly in clinical trials. So I'm going to quickly run through a couple of things that might be coming up. So you will know that Tecartus has been licensed in mantle cell lymphoma, second generation anti-CD19 CAR, but with a CD28 construct. And the Zuma-3 led to its license just last year, licensed in the States by the FDA, not licensed in the UK yet. This was a multi-center study, 25 centers, and older adults. So this was looking at the population that's not eligible for Kymriah. 71 patients were enrolled and leukapheresed, and 77% of individuals got the CAR T-cell, the Tecartus product. Adverse events a bit more significant. Any of you that have given it for mantle cell know that they often get pyrexia, hypotension, and CRS grade 3+ in 24%, with quite a high number of neurological events, 87%, but grade 3+ only in a quarter. 2 deaths were experienced in this study. But overall, CR rates not as good as the children's data, but that's not entirely surprising, but 71% of those infused, and CR/CRa rate, and the CR rate 56% overall. Now, we're not sure whether we're seeing a plateau in this graph yet because it's very early days, but clearly the patients that didn't develop a CR have a rapid deterioration and die, but those that did experience a CR, there are some patients that are living out at many months post-treatment. So that was the data on which it was licensed in the US, and in the UK it is under review, but perhaps is going to be available later this year. But we are waiting to understand whether that will be the case. I guess in your situation, you may be able to have patients travel to the US, currently not to the UK. So I might just very briefly, I know I'm at the end of my time, but I'll just very briefly talk to you about this new CAR, which is coming out of UCLH. Which is looking at the problem of T-cell persistence, CAR T-cell persistence, and exhaustion by this particular product has a rapid on-off with the CD19, which may lower toxicity and indeed increase efficacy. So they presented their data, published the data in the JCO, just early days, 20 patients, heavily pre-treated, 85% of them that had MRD negative response, with a few travelling onto allograft. This is an ongoing trial in the UK looking at this product to see whether it has better results overall. Now, I'm just going to quickly, I'm not going to talk to you about this, I'll just draw your attention that there has been some work done looking at CAR Ts in CNS disease. Currently, you are not allowed to give it. The children have to be CNS negative, but there's been some increasing data occurring from looking back at studies saying that those that were CNS positive or had isolated CNS relapse don't do any worse after a CAR. So trying to increase the knowledge base about being able to utilize a CAR in CNS disease, which is such an unmet need, I'm sure you're aware. And then this is my final slide. So CAR T cells for TALL. Well, it is coming. There's been lots of concerns about how you could do it, how you could redirect T cell to a T cell, and would it cause T cell aplasia or T cell fratricide? And clearly those are concerns. But there are ongoing trials of both auto and allo CARs for TALL, which are certainly coming to Europe and America after initially having such promising results from the Chinese data. So this is definitely coming and would be a real boon for the patients with what is currently a terminal illness when it relapses. So the CAR T landscape is exciting. There's many trials all over the world. I hope you have access to some for your patients. And with that, I'd like to thank you for your attention, and I'm happy to take any questions.
Thank you, Dr. Deborah, for this nice talk. And I will leave the microphone for Dr. Khalid to elaborate on many questions.
Yeah, thank you very much, Professor Yal, for this comprehensive and nice presentation. We're going to open the floor for questions, please. Any questions from the audience?
May I have the first questions?
Yes, Doctor.
Regarding acute lymphoblastic leukemia, we learned that we have sometimes of Philadelphia-like acute lymphoblastic leukemia, and they have a lot of mutation, especially BCL2 mutations. Did you have any experience giving BCL2 inhibitor in such a cases?
Yeah, well, personally, we don't have any access to BCL2 inhibition in the UK for Philadelphia-like. Of course, we know that this is a really poor prognosis subgroup of which getting them, they don't go MRD negative very frequently. And the aim has always been to try and get them to allograft in our practice. But definitely there's been data on venetoclax and also, as I said, with the Abl kinase class fusions about looking for TKIs that might be used. And there's been plenty of reports on it, but it hasn't hit clinical practice, and it's not currently available in the UK. Outside of a clinical trial. There are some phase 1 data which are not just for ALL. There's some leukemia and cancer trials which are in the safety stages. So I don't have any personal experience, but most certainly we need to do better with BCR-ABL-like.
Thank you.
Is there any other questions? Yes, there is. I have a question. There is always a debate when the best time point where you do an MRD result. I mean, you depend on the MRD result to change your therapy, to escalate your therapy, or sending your patient for allogeneic bone marrow transplant. So for in regimens like hypercivad, MD Anderson regimens, and others, there is no definite time where you would rely on the MRD assessment, except in the GML protocol at week 16, as you know. So can you elaborate on what's the best time where you assess the MRD and you change your therapy upon the results, please?
Yes, so the UK data we looked at, so our first induction, which is basically a Vinc, Dex, and anthracycline induction with pegosparaginase, takes 4 weeks. And at the end of phase 1 induction, we did find that the MRD at that time point pointed to a lower overall survival, it was not till the end of phase 2 induction that we found the biggest separation. So our UK practice currently isn't intervene at the end of induction 1, regardless of MRD status. So even patients that have not been primary refractory, we go on to our second block of induction. And so we tend to use a date which is approximately, I guess it's just about 16 weeks also. So it depends how long the recovery is between the 2 inductions. But yeah, we choose quite a late time point, and that's just to sort of try and stratify out who is the highest risk. But certainly if I have an individual that's MRD positive after phase 1, I will, I'm certainly being cautious. But when we always go on to induction 2, we might then use blinatumomab after induction 2. But those patients that go MRD negative, even after induction 2, it's a small number in adult ALL, but they do exceptionally well, and they don't seem to need to have an allograft because the TRM in that age group might be up to 22-25%, and the benefit of the allograft is being outweighed by the transplant-related mortality. So our practice in the UK is we note MRD after phase 1, we act on it after phase 2, we try and get it negative before. If it was positive after phase 2, we try and get negative before an allograft. If it's negative, we will take a chemotherapy alone approach and will not allograft.
Thank you. Any other question from the audience? Yes, please.
Dr. Khalifa.
Can you open the
microphone, please?
Can I ask about a case probably related to the subject? I had a patient who presented very huge splenomegaly, very high count, more than 200,000. And when they did the bone marrow, more than 90% of the bone marrow was blast cells, but they were biphenotypic, ALL and AML and BCR-ABL positive. How can you approach this patient?
Yes, well,
he's in the late 60s.
Yes, in the late 60s. Yeah, well, clearly those individuals with a mixed phenotype acute leukemia, particularly with the BCR-ABL translocation, do exceptionally poorly. And we would always be planning that individual would, if possible, would get to an allograft. Late 60s, we would consider that's acceptable for reduced intensity FMC-based transplant from any donor source. We choose siblings first and then VUDs. But in the UK, we can only use imatinib upfront for those individuals, but we can rapidly change to ponatinib for those that don't have a BCR-ABL response. But in those cases, if they've really got a mixed phenotype blast population, we usually treat them with a FLAG-IDA chemotherapy backbone approach, a little more intensive, with a view to getting them to an allograft.
Thank you.
Could I ask a question?
Yes.
Thank you, Doctor. What's the best management in case of isolated CNS relapse in case with the patient with ALL?
Isolated CNS relapse. Is that what you said?
Yes, yes.
Yeah, I mean, it's every ALL doctor's worst nightmare, isn't it? Because currently we know that they will inevitably relapse. Anybody that relapses in the CNS will inevitably have a systemic relapse. And so if they're under 25, we can clear their CNS. If we can clear their CNS effectively with intrathecal management with triple, we use methotrexate, Aracid, steroids, then they would be considered a relapse. And if their CNS disease is CNS1, that we could go to a CAR T cell. I think that the outcome of CNS relapse overall is so dire that that any way that you can get them to a CAR product is probably the way forward. I tend to give the chemotherapy entirely directed to the CNS while they've just got an isolated relapse, and unfortunately, the way that the ability for us to sequence drugs works, that that I wouldn't give, or I can't give systemic treatment that's not funded. So we can't do a CAR T cell unless it's a systemic, unless the CNS relapse is cleared. And for Philadelphia positive, we don't have access to it, but we certainly tried compassionately that dasatinib probably has a better penetration of the CNS than either imatinib or ponatinib. So for Philadelphia positive, we try and switch to dasatinib.
Yeah, thank you. Is there another question?
Can I ask a question, please? Dr. Khaled?
Can you? Yes, please. Go on.
Yeah, this is Dr. Walid Dana. So my question regarding Philadelphia positive ALL. So I know that in UK, maybe ponatinib, it's not approved as a first line for Philadelphia positive ALL. So my question is, if ponatinib available, do you think first line better than subsequent line, like hyper-CVAD plus ponatinib?
Yeah, well, certainly the data coming out of the MD Anderson would suggest that ponatinib is a more effective TKI than imatinib. I mean, in my personal experience of using ponatinib, and I'm sure yours too, is that, I mean, it's a much more toxic drug than imatinib. And I think if patients get a molecular response on imatinib, that then keeps them in good shape. We're always planning to get our Philadelphia positives to an allograft. Then I personally am happy with imatinib 600 milligrams because it's so well tolerated, and then I reserve ponatinib for molecular failure. I think that, you know, particularly in the older adult, the cardiovascular risks of ponatinib are significant. So you know, it's easy for us because we only have these two options. It's always nice to have something in reserve. There are other, so currently in the UK, we can also get access to asciminib on a compassionate access basis, which is an ABL inhibitor, which doesn't go in the same pocket. So it can be used. In fact, there's some nice evidence about using it in combination with dasatinib without even any chemotherapy. So I think the answer to your question is no, I'd still start with imatinib if they get a very good response and because it's so well tolerated, but I quickly change to ponatinib if there's a molecular failure.
Yeah, thank you very much. We have two more questions. Is there any question from the audience? Okay. I have a question regarding the vaccination post-CAR T cells. So when you would recommend to vaccinate against COVID after the CAR T cell therapy?
Yes, do you know, I don't know if I have the answer to that on the top of my head. I might have to defer that one.
Yeah. Good. We also deferred them. Just like a phone call from one of my patients who is with a Hodgkin lymphoma, who got a CAR T cell in the US. And now he's like 3 months away from the CAR, but he's cytopenic. And he's asking me the same question. Can I get the COVID vaccines? And because of
I mean, clearly, I mean, there's no reason why you couldn't. It's just the likelihood of efficacy is, you know, particularly if you've still got complete B-cell aplasia. I have to say that I couldn't tell you our policy off the top of my head, but I can definitely forward you that information because our post-CAR T team, I'm sure, have been asked that question.
Yeah, then I would like to thank you very much for your presentation and answering questions, and hope to meet you soon. Again. Thank you.
Thank you so much.
We'll move to the next session.
احنا بنقدم دكتور عامر.
انا بحكي بقوم.
ما في مشكله. هي دكتور عامر. قوم صايد نقدر نشوف الثلاث وانت ثلاثه. مش مشكله، بيقدم دكتور احمد وبعدين بس هيك تزيد عشان ياخذ راحته. هلا بنحكي له.
بدك اقعد انا هناك؟ بسم الله الرحمن الرحيم. السلام عليكم. Good evening everybody. Our speaker now, Dr. Amr Zidan from US. Dr. Amr Zidan is an associate professor of medicine and hematology at Yale University and the medical director of hematology, early therapeutics research, and the director of CME at hematology division at Yale Cancer Center. Dr. Zidan completed a hematology oncology fellowship and the clinical research fellowship in MDS at Johns Hopkins University, where he also earned a Master of Health Science degree in clinical investigation. Dr. Zidan specialized in the management of myeloid malignancies, especially MDS and AML. The focus of Dr. Zidan clinical and translational research is the development of novel therapies for myeloid malignancies with a special focus on targeted therapies and use of immunotherapy-based approaches. Dr. Zidan is also active in health outcomes and comparative effectiveness research for blood cancers and their therapies. Dr. Zidan continues to serve as the principal investigator on many investigator-initiated cooperative groups and industry-sponsored clinical trials for myeloid malignancies, and chairs or serves on the steering or independent data review committees of several large clinical trials for myeloid malignancies. Dr. Zidan has been received several prestigious awards, including the Leukemia and Lymphoma Society Scholar in the Clinical Research, Cancer Institute Cancer Clinical Investigator Team Leadership Award, the Tito Bastigliano Young Investigator Award, the ASCO Young Investigator Award, and multiple other achievements awards. Dr. Zidan has presented his research in many meetings and has been an invited speaker nationally and internationally. He was the lead presenter of MDS review at the American Society of Hematology 2018, highlights meetings in USA and Asia Pacific. He is an author on more than 200
Good afternoon. Thank you so much for the very kind introduction. دائما باخذ أي فرصة عشان أجي على عمان وأشوف الجميع. Today my talk will be highlighting some of the major updates from the American Society of Hematology meeting in 2021. These are my disclosures. So I'll start by introducing the treatment approach for acute myeloid leukemia, which I'm sure all of you are familiar with, because it really has not changed since the 1970s for the most part. The first step is always determining whether a patient is a candidate for intensive chemo. And then after that, the patient would undergo induction, most commonly a 7+3. If the patient is able to achieve a complete remission, some patients will go to consolidation, or they will go to a bone marrow transplant, depending on their cytogenetics and their molecular and response to treatment. However, multiple studies, including some of ours, have shown that patients who undergo induction have a very high mortality rate, especially when you look at older patients. For patients who are older than 65, the mortality rate can reach 20%. And for that reason, many people have been trying to avoid induction whenever possible. So the introduction of hypomethylating agents, such as azacitidine and decitabine, was a very important improvement because you are able to treat these patients without intensive chemotherapy. The problem, as you can see in these figures, the outcomes are not great. The median survival with azacitidine or decitabine basically is around 8 to 9 months. So the survival is very limited. And we can see that the 1 year and the 2 year survival is only 34% and 13%. So most older patients with acute myeloid leukemia are dying from their leukemia within 2 years. And we understand now that a lot of that is related to the biologic heterogeneity of the disease. So there are many driver mutations that make AML very difficult to treat as one single entity. And we understand now that you have to treat patients according to their genetic profile. And also, traditionally, we have tried to achieve complete remission. But now we know that complete remission is just the tip of the iceberg. And there is still a lot of disease, even when patients are in complete remission. So similar to other malignancies like CLL, multiple myeloma, APL, ALL, we are trying to target MRD negative CR because that correlates with long-term outcomes, as I will show you in the next few slides. So starting the year 2017, how we treat AML has changed significantly. We had 9 drugs approved in the US, basically for different indications across AML. We had the FLT3 inhibitors, the Idh inhibitors. We have the liposomal combination of cytarabine and daunorubicin, as well as hedgehog inhibitors. And most recently, September 2020 was the last approval in the US, which was an oral version of azacitidine, CC486. So you can see here basically how the management of AML became more and more complicated rather than just simply trying to decide between induction or hypomethylating agent approach. So some of the abstracts from this American Society of Hematology were actually very important because they address several questions. The first question is for patients who have Idh1 mutation. So Idh1 mutation occurs in around 5% of patients with AML. And those patients are generally treated with azacitidine and venetoclax, which is the standard of care approach in the US. However, we have a drug, ivosidenib, an Idh1 inhibitor, which is also approved in the frontline setting as well as in the relapse refractory setting for AML. So the question basically became, can you combine azacitidine with ivosidenib? And there has been data, single-arm study data, one of which we participated in, showing very good outcomes with combining azacitidine with ivosidenib. In this study, the Agile study, patients who have Idh1 who were older were randomized to receive ivosidenib with azacitidine versus azacitidine alone. And you can see here the baseline characteristics of the patients, typical for patients with acute myeloid leukemia, the age in the 70s. Most of them have basically favorable or intermediate risk cytogenetics, which is typical for IDH mutated AML. You can see the overall survival was much better, basically, with the combination with ivosidenib and azacitidine compared to azacitidine alone. And it wasn't only statistically significant, but it was clinically very meaningful, 24 months compared to 8 months, so almost triple the survival. And when you look at the response rate as well, you can see the complete response rate was 34% with ivosidenib compared to 11%, or sorry, it was 47% compared to 15% with the combination. And you can see that the overall response rate was also much higher with the combination, 62% compared to 19%. The safety profile was actually quite impressive because one of the major problems we get with azacitidine with venetoclax is infections, especially febrile neutropenia, as well as with azacitidine. Here, the combination of ivosidenib with azacitidine, you can see that the febrile neutropenia was 28%, which doesn't seem higher, but even looks lower than what you get with azacitidine alone, 34%. So the toxicity profile seems very favorable. And the authors also included health quality of life assessment, which was also looking good with the combination. So basically, the study showed a complete beat of ivosidenib with azacitidine compared to azacitidine alone in every front: complete response rate, overall survival rate, progression-free survival, as well as quality of life. So the question right now becomes, in those patients, should you use azacitidine and venetoclax, which is the standard of care treatment approach for older patients with acute myeloid leukemia, based on the VIALE-A study that you can see here, where the complete response rate is 37% and the CR/CRI is 67%? Or should you use the Agile regimen, which is ivosidenib with azacitidine? Of course, the main issue here is that the Idh1 mutations only occur in 5% of patients. You have to wait, in most places, you have to wait around 2 weeks to get the IDH results. So many people argue to start with azacitidine and venetoclax and then just reserve ivosidenib for relapse. The other, I think, important theme that we have been seeing coming in recent meetings are regarding the use of MRD response as a prognostication for long-term outcomes with patients. And azacitidine venetoclax basically now is the standard of care for older patients with AML. However, there isn't much data about MRD in terms of non-intensive chemo. Most of the data with MRD assessment in the US comes from patients who have received intensive chemo, where it clearly correlates with long-term outcomes. So in this sub-analysis, this was just published in JCO, the authors looked at MRD negative CR, which was defined by flow-based parameters less than 1 in 1,000 cells, versus patients who did not achieve MRD. And what you can see here, again, is a very clear overall survival advantage, where patients who achieve MRD negative CR, basically within the four cycles of azacitidine and venetoclax, the median survival at this follow-up was not reached, while for patients who did not achieve MRD negative CR, the median survival was 18 months. And when a multivariate analysis, you can see to the right lower part of the slide, was done, the cytogenetics as well as the MRD response were independently prognostic of the survival. But you can see also on the right upper hand that even among patients with TP53 mutations and poor risk cytogenetics, it was a clear favor for patients who have MRD negativity. Why is this important? Because we have more and more data basically that suggests that we can move away from intensive chemotherapy, even for some patients who potentially can get intensive chemotherapy, because outcomes with azacitidine and venetoclax, especially among patients who are don't have poor risk cytogenetics, and for patients who achieve MRD negativity, are very good. How about the use of FLT3 inhibitors? So this is another area that has been undergoing a lot of research in acute myeloid leukemia. We have a FLT3 inhibitor, midostaurin, approved in the frontline setting with intensive chemo. We have gilteritinib, which is a FLT3 inhibitor approved in the relapsed refractory setting as monotherapy. And then we have the patients who are older and unfit, who have FLT3 mutations. And what to do with these patients remains controversial. The standard of care remains, if the patient is not fit for intensive chemo, is to give them azacitidine and venetoclax. You can see the sub-analysis from the VIALE-A trial, the landmark trial that led to approval of azacitidine and venetoclax. And what you can see is that the response rate with azacitidine and venetoclax was actually quite good, around 70%, compared to azacitidine alone, 36%. So high response rate. And you can see that the survival in the middle of the slide for FLT3 mutated patients was 13 months compared to 8 months. However, when you look at the patients who have FLT3 ITD on the right upper hand of the slide, you can see they are not deriving much benefit. the overall survival is 11 months compared to 8 months. However, for patients who have FLT3 TKD mutation in the right lower part of the slide, there was significant benefit basically with the combo. So what does that mean? That means basically that older patients who are unfit, who have FLT3 ITD mutation, don't do particularly well with azacitidine and venetoclax. And because of that, there has been a lot of interest in exploring FLT3 inhibitors in combination with azacitidine. This WING trial was randomized phase 3 trial of azacitidine and gilteritinib versus azacitidine alone. And this was a trial that was very anticipated because of the unmet need in patients who have FLT3 mutations. As you can see here, this trial included an arm originally that had gilteritinib in it, but gilteritinib was subsequently dropped, and the randomization was between azacitidine alone versus azacitidine and gilteritinib. You can see the baseline characteristics of the patients across the two arms. It was 2-to-1 randomization, so 74 patients getting gilteritinib azacitidine and 49 getting azacitidine. You can see that across the spectrum, most patients had ITD mutation. So around 80% of patients had ITD mutation. The results of this trial was disappointing compared to the Agile trial because there was no overall survival improvement. You can see you don't need a p-value really to see that there's a complete overlap between the gilteritinib azacitidine arm in blue with azacitidine alone. So basically, using gilteritinib azacitidine, which some people were using off-label, I don't think it makes a lot of sense anymore in these patients given the results of this study. The authors did a subgroup analysis trying to identify groups of patients that might benefit. And they found that patients who have ITD mutation and patients who have high allelic ratio might benefit more with this combo. You can see here, I think very interesting, that the overall response rate with the combo, the gilteritinib and azacitidine, was much better than azacitidine monotherapy. However, most of those responses are not complete remissions. You can see the complete remission is only 16% versus 14%. So part of why those patients did not have improved survival compared to azacitidine monotherapy, in my opinion, is because the CR rate was not improved. And the second reason is because there was a lot of subsequent use of salvage therapy with gilteritinib. So patients who got azacitidine could quickly switch to gilteritinib on relapse, which salvaged many of them. And that's why probably you don't have a survival advantage with this regimen. Another important update that was presented in ASH was the Quasar study. So this is the study that established oral azacitidine or CC4A6 as a standard of care therapy for maintenance after intensive chemotherapy in older patients with AML who cannot complete their curable therapy. So you can see the basic design of this trial, which was published in the New England Journal of Medicine. The patients were randomized 1-to-1. The patient had to have received intensive chemotherapy for induction, and within 4 months of achieving CR/CRi, were randomized to oral azacitidine or placebo. And the oral azacitidine was given for 14 days each cycle. Those patients were 55 years and older, so they were not younger patients. And the top-line study results were positive. However, many patients were still relapsing over time. So the lingering question was, are you curing anybody, basically, by taking those patients and giving them oral azacitidine? Are you just prolonging survival, or are you curing anybody since those patients are not going to transplant? So here we had an extended follow-up from the trial, and you can see that after a longer follow-up at 3 years, basically, that the survival advantage seems to be still maintained. AML is not likely to relapse generally after 3 years of remission, so we need longer follow-up. But it does seem that some patients might be able to skip transplant using this approach. And those patients, especially who have favorable molecular profiles, such as NPM1 positive patients, might be among those patients. So following on the same theme of what I mentioned earlier is many groups are now trying to avoid intensive chemo in older patients. So patients who are older than 60. We presented this analysis using the Flatiron data, which is a large registry-based data of patients with cancer who receive different treatments in the US across academic and community centers. And what you can see here is the top line results from this analysis, which included a propensity score matched analysis between patients who received intensive chemo and those who got venetoclax and azacitidine. And again, you can see that the overall survival completely overlaps. There is no difference, as well as when you censor at the time of transplant. Another analysis was done by a different group showing the same exact results. Basically, when you compare azacitidine with venetoclax versus intensive chemo, which was here CPX351, no difference in overall survival. However, what seems to make a difference is that whether the patients are able to go to transplant. So if the patient went to transplant, it doesn't matter whether you give them azacitidine and venetoclax or whether you give them intensive chemotherapy. So it depends really on what is the eventual goal. And I think many patients can potentially get to transplant in a better shape when they don't get intensive chemo. When you give intensive chemo, you often get into severe infections, fungal infections, and the patient cannot go to transplant. So using azacitidine and venetoclax in older patients might be an easier way to achieve remission and subsequently go to transplant in a curative intent fashion. How about TP53 mutated patients? So this is a subset of patients that is, I think, the most and the highest unmet need right now in AMI. It's very difficult to treat these patients. Their outcomes are very poor. And currently, we don't have any therapies that are particularly great for them. So in this ASH, trying to look at the benefit of azacitidine and venetoclax, what you can see here in this slide is that patients who had TP53 mutations with venetoclax and azacitidine had a response rate of 40% compared to 16% with azacitidine alone. And for patients who had intermediate risk cytogenetics, the difference was 71% compared to 31%. So there is definitely higher response rate with azacitidine and venetoclax. The problem is that this is not translating into overall survival. So you can see here at the bottom of this curve that the median overall survival with azacitidine and venetoclax, if you are TP53 mutated, is only 5 months. With azacitidine alone, is 4.9 months. So it's really not different. Basically, if you are TP53 mutated, whether you give azacitidine, whether you give azacitidine and venetoclax, or whether you give intensive chemotherapy, most of those patients are dying very quickly from their disease, and it's clear that we need newer therapies for those patients. I think two smaller studies were of particular interest also in this ASH meeting, largely because they look at the same theme of changing how we treat AML. You know, this idea of giving intensive chemo versus not intensive chemo, I think is, my prediction is many patients will not be getting intensive chemo in another 10 or 15 years. So in this study, younger patients basically who have poor risk cytogenetics or poor risk molecular features such as TP53, ACXL1, RUNX1, basically were randomized, were chosen to receive decitabine and venetoclax. So those patients are patients who are 18 to 59. Those are patients you could induce, young, healthy patients, but they just have bad risk karyotype. So those patients got decitabine and venetoclax. And this is a smaller study, single-arm study, 27 patients. You can see the median age is 40-year-old. And you can see here the baseline characteristics compared to historical control. The CR rate in those patients was 52% with venetoclax and decitabine, while the historical control, the patients who got intensive chemo, the CR rate was much lower at 27%. And the MRD negative rate was 73% compared to 43% for patients who have gotten the intensive chemotherapy. Again, very intriguing that you are seem to get better results with venetoclax and decitabine in younger patients compared to intensive chemotherapy. Of course, this is a historical control comparison, and we need additional data. And even among patients who have TP53 mutations, as you can see here, the response rate is much higher, 67% compared to 25%. At the time of presentation, the median overall survival was not reached for the patients who received venetoclax and decitabine. Many of those patients have also gone to transplant. So we are waiting to see hopefully the longer follow-up in the next years But I think many of us are going in that direction as well, where if we see a young patient, we don't automatically give them intensive chemo. If they have bad cytogenetics, if they have TP53, we often consider non-intensive approaches and trying to go to transplant. One, I think, again, very exciting study. This was a poster, but I chose to actually highlight it because, again, it's showing how quickly things are changing in leukemia. So this is patients basically who were older, who are unfit for chemo, and they received a combination of oral decitabine with venetoclax. So this is complete total oral therapy, which again is unprecedented in AML, where you are giving 2 pills to a patient with acute myeloid leukemia. And the idea here is that you are replacing azacitidine with Aztec 727, which is an oral version of decitabine. So this was an early analysis of this study. And you can see that the number of subjects basically was only 25. And they looked at pharmacokinetic equivalence between the drugs basically, and they found that there was equivalence. And you can see here that the double oral therapy responses in this swimmer's plot, basically, you can see looking at this that many patients were still responding in CR. They are doing very well. So, however, similar to many patients who receive these therapies, a lot of infections, which highlights the same point, is that while in AML we are moving in a direction where we are giving more oral therapies, those patients are still sick. They can get all kinds of complications. So I think one of the fears that many of us have is that people start giving them oral therapies and then the patient die at home. And like those patients should be monitored the same way as you are if you are giving them intravenous treatments. An exciting study building on azacitidine and venetoclax was adding magrolimab, which is an anti-CD47, the don't eat me immune checkpoint inhibitor. You can see here that the response rate was very high, 64% among patients who have TP53 mutation. So those are patients who generally, as I mentioned earlier, they don't do very well. So this was an early snapshot of this study. However, this magrolimab, the drug, the first in class anti-CD47, actually was put in a partial clinical hold by the FDA for imbalance of adverse events. So we are still waiting to see what happens with this drug, but it's currently one of the most exciting drugs for TP53 mutated patients. The last drug I'm going to talk about, or group of drugs, are menin inhibitors. Again, those are very exciting agents. They are oral drugs that seem to benefit patients who have MLL rearranged leukemia. So MLL rearranged leukemia is among the worst leukemias that you can have. It can happen in AML, it can happen in ALL. And this leads to basically a differentiation block and very poor outcomes. And these menin inhibitors, you can see here one of them, the Syndax 5613, basically blocks the interaction of menin with MLL, and that leads to differentiation and improvement on outcomes. So this drug, which is an oral pill, given as monotherapy to patients who have relapsed and refractory MLL rearranged leukemia, you can see here, resulted in CR among 8 patients out of 51 patients. 16% had CR. Many patients had other responses. So very exciting. This drug is basically going for registration expansion at this point, as well as combination-based approaches. So a lot of exciting developments coming. I think the main direction is the use of combination non-intensive chemotherapy approaches, as well as using total oral therapy approaches for patients with acute myeloid leukemia. At the end, I'd like to thank my funding organizations. I'm happy to take any questions.
Thank you, Amir, for this comprehensive and updated review from ASH 2020-21. The floor is open for any comments or questions.
Yeah, thank you very much, Dr. Isbel. Impressive update from 2021. As you know, in Jordan, we don't have all of these drugs, unfortunately. And when we're getting an acute myeloid leukemia patient 55 or 60 or older, we just start thinking about palliative care, especially I mean, when you get the bad cytogenetics, you get P53 mutation, and we're just sitting in front of the patient, we don't know what to do. And in a country like Jordan with poor resources, I don't know how you would advise to get all to do for those organ patients. For example, giving them, I don't know, short period of therapy, as a cytogenetics class, modification of doses, for example. I have the cytokine too. I mean, I don't know the cost, but probably it's like similar with the ASA. Maybe the cytokine is better than the ASA. What do you think about it? What would you advise for us to do for our unfit patient with acute leukemia?
Yeah, thank you. And great question. And giving these talks, actually, this issue is clearly not limited to Jordan. Many countries, even some countries in Europe, actually, many of these drugs are not available. As I think I heard the previous speaker saying that they only have imatinib in the UK, and ponatinib, which was surprising to me. But I think this, this is an issue that goes more into inequity. I think distribution of some of those drugs. I think the biggest message in my mind is that age in leukemia, age is really just a number for the most part. So I think it's really mostly about the fitness of the patient. So we are certainly seeing patients who are 65, 70, who can be cured because they have reasonably good cytogenetics or good molecular profile. They can go to transplant. And we are seeing patients who are younger, who have very poor cytogenetics or poor molecular profile, and they are not cured very well. In terms of what you do with patients, I think trying to move away from intensive chemo, if you can, is certainly something I would consider. So for patients who are 60 years and older, who have TP53 mutation and complex risk, basically, I usually advise against intensive chemo because you are going to be in the hospital for 6 weeks. You are going to be at risk of significant infection, fungal infection. And many times, if the patient gets very sick, they cannot go to transplant. So we try to avoid that in those patients after discussion with them about the risks and benefits. In terms of in Jordan, I think there are some drugs that are available in some countries and not others. For example, Idh inhibitors. I know some of my colleagues in Lebanon have been able to get them, and I think some people get them from Turkey or from Cyprus or other countries. So I think if there is an opportunity to try to get one of those agents, I think it would be good. Venetoclax for sure is making I think a huge difference. So I strongly recommend trying to add it to azacitidine rather than using azacitidine alone. I don't think it matters as much whether you use azacitidine or decitabine. In all honesty, I think we are beyond this kind of discussion at this point. It's more about how you can combine it and improve the outcome.
Go ahead.
Yeah, I have another question. Just yesterday, we were sitting with my colleague from pediatrics, and he got a patient with undifferentiated leukemia. So what is the concept of undifferentiated acute leukemia? So how do you treat this patient? Like bilineal, biphenotypic, or how would you advise? How would you approach this patient? Thank you.
Yeah, and again, I think very good question. Those are quite rare, and I don't think people have different approaches. I think a similar question was asked to the colleague who spoke before me, and she mentioned using FLAG-IDA with. I think that patient had a PCR able. That patient actually I would give hyper-CVAD rather. So in undifferentiated leukemia, I tend or biphenotypic, I tend to use the ALL regimens. So if the patient had Philadelphia positive, I would give hyper-CVAD or mini hyper-CVAD with the PCR-able inhibitor clearly, and then try to take the patient to transplant. However, I don't think there are clear approaches because they are so rare and you cannot really have big randomized studies. So it becomes like an institutional standard of what to use.
Any questions? Thank you, Ahmed. And This is very interesting session, and we'll move for the next session.
Thank you so much.
Dr. Marcus, good evening. Would you please share your screen, please? Could you unmute your microphone?
Hello, everybody. I'm sorry to be a little late. I hope
Okay.
you
Good
can
evening.
see.
That's fine, doctor. Please.
So I will share my screen now.
Good evening, everybody. And we are welcoming our next speaker, Dr. Marcus Müller, who is the head of the GI oncology at Mainz University Clinic. Professor Müller is the head of gastrointestinal oncology at Mainz University Clinic. He is a senior consultant in the Sonographic Research Center for Immunotherapy. He is the chair of the EORTC and the GITCG group, and we are welcoming him to talk to us this evening about new therapeutic strategies with immune therapy in advanced or metastatic esophageal-gastric cancer. We are welcoming you, Professor Müller, and please your talk.
Thank you very much. I hope you hear me. Do you hear me and see the slides well?
Yes, we can.
Okay, great. So it's really my pleasure and honor to talk to you. I would rather visit you, but unfortunately it is not possible. So hello again, and it is my great honor to present you the new data on checkpoint inhibitors to integrate them into the therapy of advanced metastatic esophagogastric adenocarcinomas. I will not focus on squamous cancers. As you see here, in the middle, this is the cycle of immune recognition, and tumors release antigens also after chemotherapy and irradiation. and these antigens are then taken up by dendritic cells, which then activate T cells and migrate in the tumor and kill the tumor. And it is now important that we know that the PD-L1, PD-1 inhibitor pathway is important for the tumor to counterattack the immune system, and we now can block this PD-1, PD-L1 signaling pathway. And on the next slide, you see the new approvals we have, and this is my declaration of interests with advisory roles, honoraria, and support of scientific projects. So nowadays, we do have quite a number of new approvals, and I think in your country, it is very similar to Europe. We do have the approval of adjuvant Nivolumab immunotherapy after chemoradiation as a neoadjuvant strategy in esophageal cancer, and this is true not only for adenocarcinomas, but also for squamous cancers. In Germany, we are a FLOT country, as you might know. We have developed the combination of taxane, oxaliplatin, and 5-FU as a perioperative therapy for esophageal and gastric cancers, particularly in adenocarcinomas. So if the patients have T3, T4, or are lymph node positive, these patients are either treated with perioperative therapy or with neoadjuvant chemoradiation. And in our 577 trial, we nicely published in New England Journal that Nivolumab is improving disease-free survival after neoadjuvant chemoradiation and operation versus placebo. And this adjuvant Nivolumab improves disease-free survival from 11 to more than 25 months. And even more, we have seen now progression-free 2 survival, and hopefully at ASCO this year, we will see the overall survival data. Additionally, I will talk now to the approvals of Nivolumab plus chemotherapy. In Europe, it is for PD-L1 positive and 5 or more. And we do have also very nice data on pembrolizumab combined with chemotherapy for esophageal cancer, for squamous cancer, or adenocarcinomas in first line when patients are PD-L1 CPS 10 or higher. Additionally, in Europe, we do have the approval for Nivolumab only for squamous cancers in second-line therapy. Now, in the next slide, you see the approvals for gastric cancer and esophagogastric adenocarcinomas. Again, Nivolumab is approved in Europe for CPS 5 or higher. Pembrolizumab plus chemotherapy is approved only for esophageal and junction cancers if the tumors are CPS 10 or higher. This is particularly important for HER2-negative patients. For the HER2-positive patients, we still have approval for trastuzumab plus chemotherapy. As you know, in the US, we have also approval for trastuzumab chemotherapy and pembrolizumab due to the excellent data of the 811 trial. Only by improvement of 25% of the response. And we see at ASCO this year again, American Cancer Meeting, we will see the combination of trastuzumab plus pembro plus chemo, hopefully overall survival data. At least for second line, we do still have the same regimens approved for more than 5 years or 10 years, ramucirumab and paclitaxel or monotherapy. And in third line, we have the approval of trifluridine, tipiracil, which is Lonsurf, also approved like in colon cancer. Unfortunately for Europe, we do not have approval of checkpoint inhibitors in third line, and we hope that will change in the future. Now I shortly would like to show you the data of Keynote 590, which is the first-line standard treatment of chemotherapy cisplatin 5-FU plus minus pembrolizumab in esophageal, squamous, or adenocarcinomas of the esophagus. And this was in a randomization 1-to-1. And in the next slide, you already see the data of survival. CPS 10 or higher means patients have the PD-L1 expression either in the tumor or in the lymphocytes or monocytes. So it's a combined positivity score. And this is important since in lung cancer, for example, we measure TPS and not CPS. And as you had discussed it earlier for breast cancer, there's also a discussion about CPS and TPS. Now you quite nicely see that after 1 year, there is a significant improvement of the overall survival, and even more after 2 years, there is an increase of more than twofold from 15 to 31%. And we have never seen such a good overall survival for squamous cancers or adenocarcinomas of the esophagus. And there's also an improvement of overall survival for all patients, meaning that here patients independent on CPS respond, but for IMA, we have the approval only for CPS 10 or higher. Now, in the next slide, you see the subgroup analyses, CPS 10 or higher for squamous cancers, or CPS lower than 10 here in the lower part, and adenocarcinomas in the middle. And you see that adenocarcinomas with CPS 10 or higher have improvement of a hazard ratio of 0.83, meaning that 17% have benefited with pembrolizumab plus chemotherapy. Now, even more, and I think this is the case for always if we combine chemotherapy plus checkpoint inhibition, independent on pembrolizumab or nivolumab, and we will see data also for other checkpoint inhibitors at ASCO this year. There is a clear increase of responses from 26 to 51%, and this is clinically clearly meaningful. And we see that patients with problems with swallowing really respond well and have a nice improvement here. Now, in the next slide, I would like to come now to nivolumab plus chemotherapy, as we have done the CheckMate 649. And you know, particularly in HER2 negative patients, we have a poor median overall survival, usually with less than 1 year. And in previous data, we already saw that combination of nivolumab plus chemotherapy has superior overall survival after 12 months in a minimum follow-up of CheckMate 649. I presented these data at ASCO 2 years ago, 2021, and also at Esmo 2020. So the data are out, are nice, published in Lancet, and we now have the longer follow-up for CheckMate 649 presented by Kohai Shitara at ASCO GI just 4 weeks ago. I would like to focus on chemotherapy, Xelox or FOLFOX plus minus nivolumab, and this was 1,581 patients, and 60% were CPS 5 or higher. Primary endpoints were overall survival or PFS, progression-free survival. And here you see the baseline characteristics for all patients, and in the next slide, you see the baseline, you see you see that most of the patients were non-Asians, and also you see that most of the patients had clearly metastatic disease, and only 3% of all patients were microsatellite unstable. Now here is the response already and overall survival. There is an excellent survival data. We have never seen such a good long-term survival in gastric cancer, HER2 negative, as you see that the Kaplan-Meier curves separate early and stay separated. Hazard ratio for primary endpoint CPS 5 or higher, 0.71, CPS 1 or higher, 23% benefited, and also in all randomized patients, again, clearly meaningful benefit for 20% who benefited in this indication. So again, Nivo plus chemo improves overall survival more or less independently of CPS. However, there is an incremental increase if you take CPS 5 or higher, and also CPS 10 or higher. And here is the updated ESMO data we presented last year. And you see on the left side a clear reduction of risk of death in 30%. And you also see that after 2 years, more than 30% of all our patients survived. We have never seen such a good signal. And I still have 5 patients surviving until after 3 years whom I included in this trial. So after 2 years, the 2 years data clearly show a sustained overall survival improvement with Nivo plus chemotherapy in patients of CPS 5 or higher and in all randomized patients. Now in the next slide, you see again the PFS, so the progression-free survival on the right side with a PFS of 7.7 months versus 6.9 months for all randomized patients. And again, the curves separate early and stay separated. Now, with the progression-free survival 2, we have the data for the PFS on subsequent therapy. And you see on the right side, patients received mostly chemotherapy or targeted therapy or also immunotherapy, but immunotherapy also very rarely. And it clearly you see that Nivolumab plus chemotherapy also favors a second chemotherapy and gives a reduction of risk of death or disease progression on this subsequent therapy in 25%. So I think that's again a supportive data for using Nivolumab plus chemotherapy in first line. And here you have the overall survival in subgroups, and this is for all randomized patients. And in the next slide, you see it in the subgroups for all patients with CPS 5 or higher. And you see on the right, there is a clear signal that Nivolumab plus chemotherapy improves overall survival in multiple pre-specified subgroups. Even more, if you look down to microsatellite unstable situation, the MSI high patients had a median overall survival of 44.8 months, which is very long compared to the MSS patients. But you also see that the MSS patients did very well, again, with 14.3 months versus 11.1 with chemotherapy alone. And now, again, the progression-free survival. Sorry, I switched it. And now comes the efficacy with regard to the CPS score. You see in the upper part the efficacy of overall survival up to CPS 10 or higher. And you see that there is an incremental increase of the hazard ratio if you take patients with better CPS. In the lower part, you see the CPS also with regard to response rates. And you see that even if the patients have CPS lower than 5 or lower than 10 or lower than 1, you always see there is an increase of up to 10% response with Nivo plus chemotherapy. So again, overall survival is, objective response is higher across all PD-L1 CPS subgroups versus chemotherapy. Now, and if you exclude MSI patients, it looks very similar. Again, overall survival in the upper part is still excellent for Nivo plus chemotherapy, highly significant, particularly for CPS 10 or higher. And the lower part, again, objective responses, and again, clearly meaningful improvement of responses up more of around 10%, even if you take CPS lower than 1, lower than 5, and lower than 10. Now, in the next slide here, you see the best percentage reduction in tumor burden. And here again, Nivo plus chemo on the left is better than chemotherapy alone. We have seen that in our outpatient clinic with many patients that they respond better and they respond faster and they have prolonged responses, and we reduced chemotherapy, and they very often kept the patients on maintenance with Nivolumab alone. Now, what about the treatment-related adverse events? And you see here, there is no new safety signals with Nivo plus chemotherapy. The most common grade 3/4 treatment-related AEs are neutropenia, low neutrophil count, and anemia, together with diarrhea in chemotherapy, also neuropathy with Volfox. However, you can also see that there is not a large increase with Nivolumab plus chemo, and taken together, it can be taken together quite well, and it is well manageable. And here you see the adverse events with potential immunologic etiology. On the left, you see the different entities: gastrointestinal, it was mostly diarrhea; hepatic, it was autoimmune hepatitis. There was some pulmonary side effects, some renal and skin toxicity, but most of these grade 3/4 were less than 5%, and therefore, again, it was well acceptable. And even more, the majority of non-endocrine events with Nivo plus chemo resolved with a median time to resolution up to 23 weeks. Now, in the next slide, you see the summary. I would like to highlight again, overall survival benefit was seen across key subgroups, and it was enriched at higher PD-L1 CPS cutoffs. And there was more and more deep and more durable responses regardless of PD-L1 CPS 5 higher or lower than 5. So at the end, it is very important to say that these data support the use of Nivolumab plus chemotherapy as standard of first line in advanced gastric cancer, gastroesophageal junction, and esophageal cancer patients. Now, how can we promote patient selection even more? We already discussed CPS 5 and 10. We discussed MSI. This is well established. However, we do not have data on tumor mutational burden. I hope that we will see that at ASCO this year. And we don't have data on Epstein-Barr virus infected positive gastric cancer patients. This is very rarely seen outside of Asia. And at the end, I would again highlight that we can really reduce chemotherapy with our trial Javelin Gastric 100. We published in JCO 1.5 years ago. We used Avelumab, another checkpoint inhibitor, versus continuation of first-line chemotherapy after induction chemotherapy. In the next slide, you nicely see that the patients with PD-L1 positivity had a better survival when Avelumab was used versus chemotherapy maintenance. And therefore, I think we can nicely reduce oxaliplatin or 5-FU in our patients according to Checkmate 649. And therefore, at the end, I would highlight again our new therapeutic strategies. We have now in first line Nivolumab plus chemotherapy. For Europe, we have approval for CPS 5 or higher. In US, we have approval for all comers. And we have also approval for pembrolizumab plus chemo for CPS 10 or higher, but only for esophageal cancer and junction cancers. And at the end, I would highlight, I really appreciate your time, and would highlight that there is new drugs coming up, like combination with targeted agents like ramucirumab or other TKIs blocking angiogenesis. And we might see also data with pembrolizumab and regorafenib or lenvatinib. So there is more trials to come in the near future. Thank you very much for your nice talk, for your nice time, and for your attendance.
Thank you, Professor Muller, for this nice and excellent presentation. And I think that if there's any questions from the audience, from our colleagues.
Professor Muller, may I start with the first question?
Yes.
Now you are endorsing immune therapy in the management of metastatic gastric cancer. In like our country, like a third world country, and instead of using so many resources, we can start immune therapy immediately without going to MSI or PDL. You know, they are costly, and in the second line, in the third line, when do you recommend us to start immune therapy in such a setting without having knowledge about MSI or PDL?
That's a very good point.
Yes.
Thank you very much for this question. I truly understand that this situation is difficult since it's very expensive to use all these drugs. On the other hand, I truly see that we do have long-term survivors when we use checkpoint inhibitors in first line. So as I said, I still have 5 patients at least from my 30 patients I included with clearly metastatic disease. So at least I would say if the patients can finance or the system can finance, I would rather go for first line instead of third line. Because in third line, it is often difficult for the immune system to fight against the cancer. And if the patients are cachectic or have a large tumor burden, they cannot, the immunotherapy is not strong enough to reduce the tumor again or to even kill the tumor. So at the end, I would say if the patients can have these checkpoint inhibitors, I would use them rather in first line. However, the time is on our side. I truly believe that there is new drugs coming and the drugs will become cheaper. And you know that Novartis has, together with Beijing, Tislelizumab, and these data will come at ASCO. So there will be a larger competition in the field, and therefore I truly hope that all these checkpoint inhibitors become much cheaper in the future and that we can use them also more widely, as you said, also independently on MSI or PD-L1 status.
Thank you.
Any questions? Professor Muller, I can make one question. We know that the role of radiochemotherapy in local advanced gastric esophageal or gastric cancer is clear. There is any study, any role for immunotherapy with radiotherapy in esophageal gastric cancer?
So as I mentioned, we have this 577 trial in which we approved Nivolumab as an adjuvant protocol. And this is clearly meaningful after neoadjuvant chemoradiation and operation. In the definitive chemoradiation, so in the situation where the patients cannot be operated, there is the 975 trial from the company MSD, and we are participating in that one, in which the immunotherapy is combined with chemotherapy, with chemoradiation, radiotherapy in the upper esophagus and the esophageal cancers, particularly if they are not operable or maybe later operable. And here there is small signal that it might work. However, it is always difficult to find patients, and this trial recruits quite slow.
Thank you. Any questions?
I have another question. Why in Checkmate 577, the PDL didn't make a difference for Nivo to work, while in the 649 Checkmate, there was a difference for PDL expression?
That's an excellent question. So in the 577, we used chemoradiation, and I believe that the chemoradiation induced PD-L1 in the tumors. And even more, in 577, we excluded patients after operation who did have complete regression. And this is very important. In 577, we included only high-risk patients and treated them with Nivolumab as an adjuvant strategy. In the palliative setting, we did not have chemoradiation before, and we could not exclude good responders in that regard. Therefore, I would say CPS is a good biomarker for the palliative setting out of the biopsies, but in the chemoradiation and operation, it's still only necessary for patients who did not have complete regression.
I have a lady at the moment, she has metastatic gastric cancer, came from another country, bordering country. just receiving chemotherapy. And I did for her MSI, and it returned back to be low, MSI low. So would I dare to give her immuno at this stage, or just leave her?
I would not give her immuno if she does not have CPS positive more than 5 or 10. Because at the end, in second line, if she is already progressing, we do not have a lot of data for immunotherapy in that regard. I
think the states, the FDA approved Nivo as a third line.
Yes.
In 2017, they approved it.
Yes, exactly. But still, I would say, I know this was because of attraction study. This was particularly mostly a Japanese and Asian trial. And at least for us, we do not have the approval because EMA said it is not good enough. And we do I mean, of course, there is a few patients who respond, but it's not a lot. I mean, if you still have chemotherapy to give, I would rather give the lady, I would give her FOLFIRI or irinotecan or docetaxel or S1, which is Taisuno, which is also well established and approved for Europe. And S1 is a good drug, makes only few side effects, and therefore I would stay on chemotherapy.
Thank you.
Can I have questions? Current questions outside? For esophageal cancer, we know that sometimes we use neoadjuvant chemotherapy. If you want to start with immunotherapy with chemotherapy as neoadjuvant, you know that response rate, or if we need rapid response, chemotherapy is better. Do you think to start with chemotherapy in neoadjuvant and keep immunotherapy post-surgery if we need it?
So we don't have any data for chemotherapy and immunotherapy in the neoadjuvant setting. There is no data yet. You have to wait until ASCO, and there we will see the data of the 585 trial using FLOT plus pembrolizumab and then operation. But until today, we do have no rationale to use immunotherapy before the operation.
Thank you. Any questions? Thank you so much, Professor Muller, for this nice presentation, and I hope that to have you in the next other meetings in Jordan, and to have you in Jordan physically here. But I hope Corona will be soon out, and we can see all of us together here in Jordan. Thank you so much.
Thank you very much. Goodbye.
Goodbye.
Bye.
Pronto?
The next speaker will join us in 20 minutes. During this time, there will be a break. Thank you.
Hello? Dr. Susan, are you with us? Hello?
Yes, I'm here.
Good. Okay. You're welcome. Good evening. You saw it? Good evening. Okay. Good evening, ladies and gentlemen. It's my pleasure to present our next distinguished speaker, who is routinely recognized on America's top doctors, super doctors for cancer. Professor Susan O'Brien is the Associate Director for Clinical Science at the Chow Family Comprehensive Cancer Center, the Medical Director of the Sue and Ralph Stearns Center for Cancer Clinic Trials and Research, Professor of Medicine in the Department of Hematology and Oncology, and the endowed Chair of Cancer Clinical Science at University of California, Irvine. She has been a principal investigator and driving force behind more than 100 funded clinical research protocols, 30 invited articles, numerous book chapters, abstracts, and has authored more than 900 articles in peer-reviewed journals. In 2020, she was named a giant of clinical care in leukemia for sustained contribution in the field. She is the hematology executive member of SWOG and the president of the Society of Hematologic Oncology. Professor O'Brien is an internationally recognized leader in the research of treatments for both acute and chronic lymphocytic leukemias, and an expert on several important therapies that are presently used as standard of care for chronic lymphocytic leukemia. Today, she will talk about the latest updates in the CLL management. You are welcome, Professor. The mic is yours.
Thank you very much for that very nice introduction. Let me share my screen and I can start giving my talk. Can you see my slides? Hopefully, yes. Okay, great. So I'm going to talk today on updates in CLL management. These are my disclosures. I'm going to discuss covalent BTK inhibitors. The topic that's probably the hottest topic at ASH this past year was combination small molecules in CLL and non-covalent BTK inhibitors. So the first presentation I want to talk about is Sequoia. This is the results of a randomized phase 3 trial comparing zanubrutinib, another covalent BTK inhibitor, to standard chemotherapy with bendamustine and rituximab in frontline CLL. What you can see is that what I'm talking about here is cohort 1. This is a group who did not have a 17p deletion. Why? Because we know we don't want to randomize such patients to chemotherapy, as they should never receive chemotherapy. So this is a group where there were no patients with 17p deletion. What you can see, I don't think very surprisingly to anyone, is that the progression-free survival was significantly better with zanubrutinib than it was with BR. And that means we now have 3 potential BTK inhibitors for CLL. Ibrutinib, the first one that was approved, acalabrutinib, and now zanubrutinib. This is the progression-free survival in patients with a deletion 17p. So these people were not randomized, they were assigned to zanubrutinib. And you can see that they're doing really well, really just as well as patients without a 17p. And that's the trend we see across all the BTK inhibitors, that in the frontline setting, patients with 17p or p53 deletion are doing just as well as patients without a 17p when treated with a BTK inhibitor up front. So are there any head-to-head comparisons of these drugs, since now we have 3 of them? There is some data. This is the data that was presented last year at EHA, comparing acalabrutinib to ibrutinib. And this is a randomized trial in relapsed CLL, comparing the standard doses. Remember that acalabrutinib is given twice a day, ibrutinib once a day. And not only were these patients all relapsed, but they were all high risk, meaning they all had a deletion 17p or deletion 11q. So the primary endpoint was non-inferiority on an independent response committee assessed progression-free survival. Here is the progression-free survival curve. Note that the curves are completely overlapping, so no difference, and that the median progression-free survival was a little over 3 years in both arms. Pretty good considering, again, this was a relapsed population with a median of 2 prior regimens, all of whom had 17p or 11q deletion. However, where we do see a difference is when we look at the most common adverse events. So what we see in red are those that are statistically significant. There's more headache with acalabrutinib, but it's generally mild. It responds to pretty much anything, including caffeine, and it usually goes away in a couple of weeks. A little bit more cough also. Whereas with ibrutinib, we see more diarrhea, more arthralgia, more hypertension, more contusions, and more atrial fibrillation. And if we look at the events of special interest, the ones we know are a problem with BTK inhibitors, we see a significant difference between acala and ibrutinib in atrial fibrillation, bleeding, and a very big difference in hypertension, which I would almost argue, as time goes on, is probably a bigger problem than AFib. We all worry about AFib because if a patient gets AFib, not that you can't treat it, it's that you probably making that patient now go on anticoagulation for life. I think that's the biggest concern of AFib. But since hypertension is one of the side effects that we know does not decrease over time with the BTK inhibitors, rather the prevalence increases because you can have hypertension occurring at 3 years, 4 years, 5 years into therapy. I think here this could be an even a bigger difference. Note that this trial was completed and the follow-up when the time it was presented was a little over 3 years. Now, we also have a head-to-head trial of zanubrutinib versus ibrutinib, although this trial is a little bit different. It's also in relapsed patients, but this is not high risk. So there was no requirement for these patients to have 17p deletion or p53. The randomization, again, was to standard dosing, zanubrutinib being given twice a day, like acala, whereas ibrutinib being given once a day. This also, as you can see from the title, is an interim analysis. So this actually analysis was done before completion of the trial. So here we're looking at an investigator assessment of the progression-free survival, showing that it appears to be somewhat better with zanubrutinib than ibrutinib, although both look very good. Median follow-up in this trial compared to the one I just showed you was just about 1 year. If we look at the difference in the key adverse events, we see a significant difference in AFib, and usually in the ZANU trials, they tend to have the lowest incidence of AFib or flutter, and you see a very low incidence here of 2.5%. Although interestingly, if you look further down the table, what you can see is that with this drug, there's no difference in hypertension, 16% in both arms. Now, is that partly because the follow-up is quite short on this trial at only 1 year, and maybe we'll see more difference as time goes on? Hard to say, but this is in contrast to what I showed you in the acala trial, where there was much less hypertension, although there was much longer follow-up in that trial. So to summarize the covalent BTK inhibitors, ibrutinib is once daily dosing. It has the longest track record. There's been no late safety signals now with 7 or 8 years of follow-up, and it clearly produces a longer PFS than every frontline chemoimmunotherapy, AFAR, BR, etc. Acalabrutinib is twice daily dosing. The efficacy was non-inferior to ibrutinib, and there was less AFib, less hypertension, diarrhea, arthralgias, contusions, but more headache. Zanubrutinib is also twice daily dosing. The efficacy appeared greater than ibrutinib, but it was an interim analysis, very short follow-up, and an investigator assessment without an IRC assessment. There was less AFib, but no difference in hypertension. So let's turn our attention now to small molecule therapy. The combination small molecule was first pioneered by MD Anderson, and this is their data with ibrutinib and venetoclax for frontline treatment. This data has actually been published, but they generally update it every year at ASH. So we generally have the longest follow-up of small molecule combinations when we look at the MD Anderson data. So notice the treatment schema. There's a lead-in with 3 months of ibrutinib before the ramp-up to venetoclax is started. And if you look at any of the small molecule trials, you're always going to see the lead-in with the BTK inhibitor plus or minus antibody, because some of the trials are triplets that also contain an antibody. Why is that lead-in? Because it debulks the patient and reduces the risk for tumor lysis by reducing the tumor lysis risk. Almost nobody after 3 months of ibrutinib would be high risk for tumor lysis. So it works very effectively at debulking. Now, in contrast to some of the other data I'm going to show you, the MD Anderson data is fixed duration, but not necessarily the same fixed duration for everyone. So the way the protocol was written was the patients could continue for up to 2 years, but if they were MRD negative at any point in time, they could stop therapy. They then amended the protocol to allow up to 3 years of continuous therapy. So this data was updated for ASH just 2 months ago. And you see that the green reflects the MRD undetectability, looking at a level of 10 to the -4th. And you can see it's quite high at 72%. And they have certainly one of the best progression-free survivals I've ever seen in the frontline setting, with a median follow-up of about 4 years. You notice how high that curve is. We also have some data from the Captivate trial. This was a pharmaceutical trial where there were 2 different cohorts, the MRD cohort, and the update that we have at ASH this year was the MRD cohort or fixed duration cohort. Note that the first 15 months is exactly the same in both cohorts. There's a 3-month lead-in with ibrutinib and then 12 months of venetoclax and ibrutinib. Obviously, in the fixed duration cohort, by definition, they stop therapy after that 12 cycles of combination. In the MRD cohort, after the 12 cycles, there's a randomization based on their MRD status. So if they were confirmed undetectable MRD, looking at 10 to the 4th, there was a randomization to further placebo or ibrutinib for 1 year. If they were not confirmed to be MRD undetectable, they were randomized to either continue ibrutinib or continue ibrutinib and venetoclax. So this is 164 patients were enrolled. On the left, you can see the best MRD response after 12 cycles was 74% in the peripheral blood, 68% in the bone marrow. Notice that the confirmed undetectable MRD was only 58%, so somewhat less, but that's because the confirmed required 2 MRD undetectable in a row, separated by several months in both the peripheral blood and the bone marrow. That's why that 74% went down a bit for the confirmed. And you see the randomization. So there were about 86 people who were undetectable, randomized to placebo or ibrutinib, and about 63 patients who were detectable, randomized to single agent or combination. Now here's something quite interesting. What you're looking at is in the confirmed undetectable MRD, again, the randomization 1-to-1, so 43 to placebo, 43 to ibrutinib. If we look at the characteristics at the time those patients were randomized, what you see is that in both groups, 70% of the confirmed MRD undetectable were unmutated. If we look at the group where they were not confirmed and randomized to further therapy, we note that 45 to 47% were undetectable. So this is really interesting because it suggests that in fact, with this combination, the unmutated have a higher likelihood of achieving MRD undetectability. And I don't think this is just a fluke because as I'll show you, this is true in another trial. Okay, so the 3-year progression-free survival rates were over 95% across all randomized arms. Sorry. Okay, with additional year of follow-up since the primary analysis, only 1 new PFS event occurred. Okay, sorry about that. So what this is looking at peripheral blood and bone marrow in the patients that continued therapy. And you notice that if you continued therapy because you were MRD detectable, I should say, you were more likely to achieve MRD undetectable with the combination than just with single agent ibrutinib. And here's a little bit of data. Now, part of the whole concept of using fixed duration therapy is the idea that when you go later on, when a patient hopefully has a long remission and then progresses, you can potentially go back to either of the single agents or the combination. So we are starting to see some data emerging on retreatment. So you see there's only 9 patients here, most of whom came off the fixed duration arm, most of whom, since they've already relapsed, were high-risk disease to begin with. And you see the response to subsequent therapy of 9 patients with an available response, 3 are pending, and 6 have responses. So small amount of data, but nice to see that it does look like we'll be able to retreat these people. Now, this is a very important trial because this is actually a registration trial. So this is a GLOW trial. And this was a randomized trial in frontline CLL for older patients or those with comorbidities and reduced renal function, where patients were randomized to, again, the same 12-month combination of ibrutinib and venetoclax with the 3-month lead-in, or chlorambucil and obinutuzumab. Primary endpoint was progression-free survival as assessed by an independent response committee, and those with progressive disease later on the chlorambucil arm could cross over to receive single-agent ibrutinib. So here's the difference in the progression-free survival now with about 3 years of follow-up. We see not even close to a median with ibrutinib and ven, much better than chlorambucil-based therapy. Here's the data for MRD at the end of therapy plus 3 months. This is again being measured at 10 to the 4th. You see significantly higher rates of MRD undetectability with ibrutinib and ven. And you notice that there's a lot of concordance between the bone marrow and the peripheral blood, which is generally something we see with this combination, whereas with chemo, also what we generally see is that it's much easier to become MRD undetectable in the blood, but much lower rates in the bone marrow. Actually, the fact that we see MRD undetectability with chlorambucil obinutuzumab is really quite impressive, and that's truly a testimony to the power of obinutuzumab as a monoclonal antibody, because certainly with single-agent chlorambucil, you would never see MRD undetectability. Now, this is interesting because here we're looking at a higher degree of MRD undetectability. This is looking at 10 to the 5th. So this is looking within the patients who achieved it at 10 to the 4th, how many were able to achieve it at 10 to the 5th. And what you can see is that most of the patients, almost 80% of those who did reach MRD undetectability at 10 to the 4th, were able to reach MRD undetectability at 10 to the 5th. So very deep remissions. And this is, again, interesting. And what I just showed you from the Captivate trial, namely on the left, you're looking at those with an unmutated IGHV gene, and on the right, mutated, the group we tend to think of as more favorable. And again, notice that the unmutated were more likely to achieve MRD undetectability. And then finally, we got the first results of the Gaia trial. So this is a very large trial, excuse me, where there are 4 randomization arms, as you can see here, again in frontline therapy. In this trial, there were no patients with 17p deletion, and that's because one of the control arms was chemotherapy. So that was either FCR or BR, depending on the age of the patient. Then the next arm was rituximab and venetoclax, but not how you saw it in the Murano trial. I'll explain that in a second. Then venetoclax and obinutuzumab, just like was used in CLL14. And then GIVE is actually 2 small molecules. So that's obinutuzumab, ibrutinib, and venetoclax. Again, all of these are fixed duration with the exception of GIVE, where if the patients were still MRD positive after 1 year, they could continue on single-agent ibrutinib. So as you can see here, FCR-BR is obviously 6 months. Now, I mentioned that RVE is not the same as in Murano. If you recall, Murano was a relapse trial where everybody started with venetoclax. After the ramp up, got 6 months of rituximab, but continued venetoclax for 2 years because it was relapse. In this trial, the antibody comes first, just like in GVE, and then the venetoclax continues for 1 year. So the only difference between RVE and GVE is the antibody. Otherwise, the regimens are identical. And then GIVE, as you heard, allows continuous ibrutinib for people who are still MRD positive. So let's look at the primary endpoint of MRD undetectable at 10 to the 4th after 12 months of the combination. So here we see that if we compare chemo, which is FCR-BR in that first bar, to GVE, venetoclax, obinutuzumab, we see a very dramatic difference in MRD undetectability, 86.5 versus 52. Notice that with GIV, it's a little bit higher at 92 with the small molecule combination, but not a lot. Much better than chemo, though. And then finally, if we look at the comparison of chemo to RVE, no difference. And remember, RVE and GVE are exactly the same regimen, except for the antibody. So again, pointing out how potent obinutuzumab is, since just by changing the antibody, you markedly increase the MRD undetectability. Okay, and in the last part of our talk now, we will talk about the non-covalent inhibitors. So there's two of them being developed. This is the first one, MK1026, which now has a name. It's called nemtabrutinib. And for those of you who knew something about this drug before, this was the Acute drug. Now, just a word about the non-covalent inhibitors. What's so attractive about being non-covalent? Actually, nothing. The key here is that these drugs bind in a different binding site than all of the first generation BTK inhibitors, ibrutinib, acalabrutinib, zanubrutinib. We know that in many patients who develop resistance to those BTK inhibitors, they have the presence of a BTK mutation, the CYS481. And so when you have that, that's what causes the cells to become resistant. By binding in a different binding site than where the CYS481 is, that allows these agents to be effective even in the setting of resistance. So this is a very big umbrella type study in various lymphomas. You can see that the recommended phase 2 dose was 65 milligrams. Note that all patients receive therapy until progression. So just as we do with the covalent BTK inhibitors, you just keep going. We're going to focus in this presentation on the patients with CLL specifically, who were treated at 65 milligrams. So these are the characteristics of the patients for the whole population. But as I said on the right, we're going to focus on 51 patients with CLL who were treated at the recommended phase 2 dose. Note this is a very heavily pretreated population. These are not just patients failing a BTK inhibitor, but they've often had prior chemo. 84% had a BTK inhibitor. We can see that the BTK CYS481 mutation was present in 63% of these patients. The overall response rate is 57.9%. Note that most of these are PRs. So just like you see with the covalent BTK inhibitors, we don't see very many CRs, although I will tell you that in this trial and in the next one I'm going to show you, the follow-up is quite short, well less than 1 year. So could those response rates improve, or could the quality of the remissions improve? Possibly. This is the duration of remission. Again, looking very good, but with very short follow-up. We don't really have a PFS curve since it's hard to assess PFS with the short follow-up, but this swimmer's plot just kind of gives you an idea of where the patients are. You see the arrows, meaning they're continuing on treatment, and some of them are out almost 2 years on therapy. Let's look at the adverse events here. If you look at all the adverse events towards the bottom of the slide, you can see that most of them are quite mild, and some of them are the same ones that we're used to seeing with BTK inhibitors, namely arthralgia, some diarrhea, some peripheral edema, hypertension, but notice not high frequencies, mostly in the 20s, and very rarely higher than grade 1 or 2. So very well tolerated. And then finally, let's look at pirtobrutinib, the second covalent inhibitor. So this is the kinome profile for this. And the reason I'm showing you this is that this is really one of the cleanest kinome profiles I've ever seen, which is probably a reason why, as you'll see, the drug has so little toxicity. So this is just showing you in the right that in xenograft models, it's effective in the wild type, but it's also highly effective in the patients with a CYS481 mutation. So again, this also started out as a trial for several different patient populations. The other big population treated with this drug was mantle cell, but we're going to focus in here on the CLL population, very large population. You can see almost 300 treated. And in this particular presentation, There were 252 patients because those were, of that total with 296, those were the patients that had had a prior BTK. So there were some patients that hadn't had a prior BTK inhibitor, but this analysis just looks at those who had had a prior BTK inhibitor. And again, this drug is dosed daily until progression. So here are the characteristics of the patients. Again, median number of prior regimens are 3. So these are patients not just failing a small molecule. In fact, if you look down the column on the left, you can see the prior therapy. And all of them, by definition, had a BTK inhibitor. Most of them had had chemo, anti-CD20. 41% of them had actually had venetoclax also. 20% had a PI3K. There were patients who had transplant, et cetera. So heavily pretreated. Note on the right, 43% of them had a BTK mutation, CYS481, and they had other high-risk characteristics, including 36% of the patients who were 17p deleted or p53 mutated. On the left, you see the progression-free survival in the biggest patient cohort, the ones that had a median of 3 prior lines of therapy. Note that there is no median progression-free survival yet, although, again, the median follow-up here is about 9 months, so relatively short. Very impressive is the group on the right who have failed chemo, failed a BTK inhibitor, and failed venetoclax, and you can see a median PFS in this population of 18 months. Interestingly, the drug is quite effective whether there's a mutation or not. So in the people that are clinically resistant but don't have a mutation, the drug was still highly effective. And here's the safety profile. So again, if you look at any grade toxicity in that left-hand table all the way to the right of that table, you can see very low rates of toxicity, even lower than what I showed you for nemtabrutinib, not much over 10% here. Note that AFib flutter was 2%, which is probably background for 618 patients treated with this drug. And one of the most important and impressive numbers is that only 1% of patients permanently discontinued due to treatment-related adverse events. So a very highly tolerated, well-tolerated drug. So to conclude my lecture, covalent BTK inhibitors are all effective agents and very well tolerated. There's pros and cons to all of the agents. Small molecule combinations are generally producing very high MRD undetectability rates. I think an important question is, will antibody be needed? As I mentioned, there are trials looking at the 2 small molecules and antibody. I didn't talk about those today. And then a very obvious question is, we can get really great results sequencing. Will combining the small molecules be better? My guess is, if you're going to ask me, yes, because the high rates of MRD undetectability allow, number one, finite therapy, which is highly attractive to everyone, patients, caregivers, the medical system in terms of costs. And hopefully, what we're really aiming to do in CLL with our trials is cure patients. And although I'm not suggesting MRD undetectability is synonymous with cure, it's most likely necessary for cure. And clearly, this is the wave of the future. There are, I can't even tell you how many combination trials ongoing now. And then the non-covalent BTK inhibitors are highly efficacious. We have very short follow-up, so no data on remission duration, but we know that they work. We know that they're very well tolerated, and I think they will be a great option for patients moving forward. And I will stop there, and I will be happy to take any questions.
Thank you very much. Thank you for this nice presentation and review of new updates in CLL. I remember that in 2005, when I wrote my first chapter about CLL in the Bethesda Handbook of Oncology, we were talking and excited about adding rituximab to chemotherapy. And 15 years later now, see how everything has changed. Now we're not using chemotherapy anymore. And all these new drugs in CLL, really, it's fascinating. Is there any question here? Question? No. I have a question for you. Do you think that there is still a role for chemoimmunotherapy in CLL?
Yeah, I think it's a really important question. And the reason it's important is because I am one of those people who believe, and many do, that there is a cure fraction with FCR. Now, that would be limited generally to younger patients who can tolerate FCR, and then it's pretty much limited to those with a mutated IGHV gene. Nevertheless, if you look at the long-term data from MD Anderson, and there's also data from the Germans and the Italians, but the MD Anderson having the longest long-term data, you know, that plateau on the mutated curve was about 55%. I think what the fear, however, is in using FCR is late MDS or AML. Now, it's not a high percentage, it's single-digit percentage. But of course, if this is a patient that you've hopefully cured of their CLL, and now you're giving them what is basically a lethal disease, namely secondary MDS or AML, you know, that's really demoralizing for everybody. So I think that that's the greatest fear moving ahead with FCR. And then I think to a large extent, the pandemic, you know, sort of made it more difficult to give chemotherapy. On the other hand, obviously, if we take into account finances, it's a very cheap, very effective therapy. So I think you could make a case for chemo in the mutated. In the older patients, you're not curing anyone with BR. I think FCR is the only regimen that has a curative fraction. You could give people BR because if they're mutated, you will get probably 3-4 years out of it, which is not, you know, not bad for 6 months of therapy. So I think given financial constraints, there probably still is a role for chemoimmunotherapy. But in my mind, I would prefer to use it in the mutated patients who have by far the best effect with chemoimmunotherapy. And it should never be used in a patient with a 17p deletion or p53 abnormality.
Yes, thank you. Dr. Muhammad Salama, I think you have a question. Dr. Muhammad?
Yeah, thank you, Salah. And thanks to Dr. Suzanne O'Brien, who is always great in her presentation. I want to ask you one personal question regarding if you have the three molecules, the BTK inhibitors, the CD20, and venetoclax. In your opinion, if you are lived in Jordan as well as you are lived in the United States, which one you consider the best combination to achieve the best outcome?
So let me just say again, the three, you said BTK or CD20 antibody.
And venetoclax.
Okay. So that is a hard question to answer because the choices are excellent. There's only really one group where I clearly prefer BTK inhibitors up front, and that's patients with 17p deletions or p53 abnormalities. If we look at the data that was published last year on the largest series of such patients treated frontline with ibrutinib, there were 89 patients, and the reason they got that many, because they're not that common in frontline CLL as a FISH abnormality, much more common in relapse patients, was because they combined data from four randomized trials that were, or 4 trials that were using ibrutinib up front. And with that combined data, they reached 89 patients with a 17p or p53 deletion. The median, the 4-year progression-free survival in that group was 78%. Really, that looks just as good as any ibrutinib frontline curve in the total population. Now, if we look at the Ven-G data from the CLL14 trial, the median PFS in the patients with a 17p deletion or p53 abnormality was 4 years. Still pretty good. They got 1 year of therapy, they were off for 3 years, and then they progressed. But that was 4 years median, whereas I just told you with ibrutinib, 4-year PFS was 78%. Now, does that mean venetoclax is an inferior agent in that subset? I don't know that. What might not be a good idea is stopping therapy. So is it the fact that it's finite therapy, or is it that the molecule is less effective than a BTK inhibitor? There's no way to know because the way the trial was done, everybody stopped after 12 months. We don't have continuous venetoclax therapy in that patient population. So, but based on the data that we have, in that group, I will always use a BTK inhibitor. In other patients, I might look at different factors. Do they have bulky disease? Do they have significant hypertension and heart disease where I might not want to use a BTKI? Do they have renal dysfunction? And I'm worried about renal problems with tumor lysis. So I think in all of the rest of the patients, other than 17,
cannot hear you.
Yeah. If anybody has a question, please raise your hand. Any more questions? I think that's it. Thank you very much, Dr. Suzanne, having
Thanks.
us with us today, and really a nice presentation. Thank you.
Thank you. Maybe next time, I hope in person.
Thank you. Yes, sure.
Bye-bye.
Bye.
Hello?
Good evening, everyone. On behalf of the Jordanian Society of Hematology, I would like to welcome our next speaker, Dr. Mark Vincent from Canada. Dr. Vincent is a medical oncologist at the London Regional Cancer Centre, a part of Cancer Care Ontario. His activities include the management of lung cancer, gastrointestinal cancer, laboratory research into the reversal of cytotoxic drug resistant by means of gene therapy. He is also associated professor at the University of Western Ontario in the Department of Medicine in the Division of Medical Oncology. Dr. Vincent, today he will talk about the updated in the management of unresectable stage 3 lung cancer. Dr. Vincent, we are glad to have you tonight. The mic is yours. Could you start your talk, please?
Yes, thank you. Are you going to show the slides from your end, or shall I put mine up? And
Can you share it again,
From
please?
your end, doctor, if you can, please.
okay, let me. Can you see my slides?
No, not yet.
So hang on a second.
Would you stop the sharing and start it again, please?
So
could you stop sharing your slide and start again, Dr. Vincent?
yeah, I'm just doing that now. So I'm going to. Can you see it now?
Yes, we can see.
And now? You should have the full view. Are you there?
Yeah, yes, it's fine. Thank you.
Okay, can I proceed?
Oh, yeah.
Yes, you can.
Please.
Okay, greetings, everybody in Jordan and the Middle East. It's a pleasure to be with you, at least virtually, hopefully in person sometime. And I'd like to thank AstraZeneca for making this possible. So I'm going to be talking about Imfinzi, a turning point in the management of unresectable non-small cell lung cancer. This is my disclosure slide. And the objectives here to just look at a quick review of the definition, incidence, and treatment history of stage 3, the immune checkpoint inhibitor concept, the 5-year update of the Pacific study, the role of the multidisciplinary team, management of pneumonitis and other immune-related adverse events briefly. So stage 3 is probably familiar to many people in the audience, and we know that this is a staging system that keeps on getting updated, and this is the 8th edition. It's the current edition. The stage 3, it consists of 3A, 3B, and now 3C. Basically, there are 39 different combinations of T and N staging, and it's impossible to summarize them all very briefly, but we know that these are not the ones that are clearly and obviously resectable, stage 1 and stage 2. They're not the distant metastatic or pleural involvement, and it's everything in between. It usually means cancers with mediastinal nodes and or supraclavicular nodes, and depending on the severity of that, it'd be categorized as stage 3A, 3B, and 3C, and you can see the diagram on the screen. The incidence of stage 3 is about 25% of non-small cell lung cancer. We know that lung cancer is either the biggest or one of the biggest cancers in every country in the world. And so non-small cell being the predominant type, this is a quarter of non-small cell. So this is a very serious public health problem everywhere in the world. And the stage 3 is a big chunk of it.
And we know that the median survival is ranging from about 15 to 25% and has been somewhat improved over radiation alone, which can cure maybe 5% of people, to about, in a meta-analysis, an additional 2 to 4% at 2 to 5 years. So the addition of chemotherapy moderately increases the cure rate and the median survival. What we know is that there's different ways to combine chemotherapy and radiation. Originally, it was done sequentially with chemotherapy first, followed by radical radiation. But more recently, we have adopted concurrent chemoradiation, which is the current standard of care. And we can see that there's an improvement from concurrent chemoradiation. But again, it's not a large effect, although it does remain the gold standard. We know that there are many patients who are not fit enough to have concurrent chemoradiation and would have a sequential instead. And so either is acceptable based on the patient profile. And so ESMO guidelines have recognized that if concurrent chemoradiation is not possible, then sequential chemoradiation is a valid alternative. What have we achieved in this? In 2010, a meta-analysis says the 5-year overall survival from concurrent is about 15%, and from sequential is about 10.6%. So we know that at 2 years, about a third of these patients are alive. So between 2 and 5 years, a lot of these patients are dying. And so there's a big unmet need here to improve the outcomes. And we have tried many, many things over the last 30 years, many things, such as consolidation platinum-based chemotherapy was of no value. Raising the dose of radiation to 74 gray was actually worse. It's actually more dangerous to do that. So that is not a way forward. And so there are many things that have been tried, including consolidation docetaxel, which didn't work. You can change chemo to pemetrexed, that is better tolerated, but doesn't really add survival. We've tried vaccination strategies that have not worked. And so until recently, we have just been doing chemoradiation followed by surveillance in these people and then trying to treat them either with a local or a systemic treatment when they relapse. And most of them will relapse and die. So this is unsatisfactory. So the surgeons have certainly tried to improve the situation here. This is the famous intergroup 0139 study, which looked at everybody got platinum etoposide and 45 gray of radiation, and then they were reassessed. There was a temporary pause and then randomized, original randomization to surgery or to complete radiation to a radical dose of 61 gray. And then if they were fit enough, some more chemo. And overall, there was really no improvement from the addition of surgery. There was an experimental or exploratory analysis looking at patients who had a lobectomy versus a pneumonectomy. The yellow is real data here. The blue is a speculative. It's not real data, but it's speculative. The people who got who were randomized to radiation only, who might have got away with a lobectomy, that's the blue, and those who would have had a pneumonectomy, that's the blue on this curve here on the right. You can see that the surgery may help those who where a lobectomy might be possible, a more limited surgery. Whereas if you're going to need a pneumonectomy, doing surgery has actually a worse survival. But bear in mind, this is a speculative, it's just an exploratory hypothetical analysis. It's not real data. But what we do know from the 0139 study is that although surgery does improve local control, for sure it does, taking it down from about 20% to about 10%, the systemic relapse is the majority of the relapses are systemic. And surgery does not make a significant difference in the systemic relapse rate. So unfortunately, although there may be a limited role for surgery, it has not solved the problem. The Japanese have looked at this in meta-analyses. Even the optimal surgical candidate, the single station N2, has a very mediocre outcome with surgery with less than 50% of people being alive at 5 years. That's really not acceptable at all. Single station in the upper mediastinum may be a little bit better, where you have about a 55% 5-year survival, but none of it is good. And I think the world has now come around to the viewpoint that surgery is maybe part of the picture in some people, but it's not a solution to this problem. So in South Korea is a very interesting series. In optimally people who are stage 3, with most of them single station N2, who did have trimodality treatment that did include surgery, and they had 570 cases. You can see that by the 5-year disease-free survival is under 30%, despite triple therapy. And in fact, 81.5% of the recurrences are in fact systemic. So unfortunately, this is a systemic disease. Even before patients present, it is a systemic disease in over 80% of people. Just trying to move my slides here. There we go. So unfortunately, like as this cartoon illustrates, surgery with all the technical expertise and the excellence of the surgeons, unfortunately, they're closing the barn door after the horse has bolted. And so the vast majority of these patients are already metastatic. Systemic therapy helps with chemotherapy, but it really only solves the problem in about 10-15% of people. Additional cytotoxic chemo doesn't work. The consolidation doesn't work any better than 2 cycles of platinum-based doublet chemotherapy given during the radiation. There's been no real, substantive progress since the early 1990s. And so there's a major unmet need to both increase the cure rate and to prolong, median survival. And so this requires a different kind of thinking. And so this has led us now down the pathway to immune checkpoint inhibitors. So this is a famous slide of the cancer immunity cycle. It shows that cancers are turning over. They release antigens. These antigens are picked up by dendritic cells. They're taken to the regional lymph nodes. Then there's a checkpoint called the CTLA-4, for which Jim Allison was given the Nobel Prize. If that's an inhibitory checkpoint, but if the cells are licensed somehow to continue, they will go into the circulation and clonal expansion, recognizing that antigen, come back down to the tumor, where there's yet another checkpoint that can hold them and block them, called the PD-1, PD-L1 system, for which Tasuku Honjo got the Nobel Prize. So there are these checkpoints that can stop the immune system from working properly, and they need to be somehow overcome. So here's a bit of a closer view as to what happens. Now, when you radiate the cancer, this actually can explode the tumor. There are more tumor antigens. The MHC complex that presents the antigens goes up. It's upregulated. There are immune cells that can pack into the tumor in a better way as a result. But the tumor will also upregulate PD-L1, which is a way that the cancer can stop the immune system from acting. Nonetheless, radiation is very effective at potentiating immunotherapy through a whole host of mechanisms that we don't have time to go into, but it does basically include the secretion of danger signals and cytokines, the induction of immunogenic cell death, and the increased homing of immune cells into tumors, so that the tumor now gets infiltrated by these immune and inflammatory cells. But unfortunately, there's upregulation of PD-L1 that can block the immune system. Now, chemotherapy also has a role to play. Chemotherapy, again, can explode the tumor, can cause antigens to be released, but also a variety of proteins, cytokines like calretinin and ATP, which influence the dendritic cells and can mature the dendritic cells so they're better able to present the antigen to the T cells in the lymph nodes. So now the question is, can the combination of chemotherapy and radiation set you up to benefit more from the immune system? But unfortunately, we have this PD-L1 here, and that has to be blocked somehow. So we fortunately have an antibody, Imfinzi, also known as durvalumab, and that can bind the PD-L1 on the tumor cell, but it can also bind the PD-L1 on the immune cell. And basically, it can take away this inhibitory signal. So now the T cell is activated. There's none of these inhibitory signals. There's activation, and the T cells are now free to attack the tumor. So as a result of that, the Pacific study was done, and I'm sure you're familiar with this. These are good performance patients who had not progressed after chemo radiation. That included concurrent chemo radiation with platinum-based chemotherapy. They were stratified by age and gender and smoking history. They were randomized 2-to-1 to durvalumab 10 milligrams per kilo every 2 weeks for a year versus placebo. So this is a a double-blind placebo-controlled trial with progression-free survival and overall survival as the co-primary endpoints. Basically, you had to have a good performance status. You had to show that you had not progressed after chemo radiation. And basically, they excluded people who were unfit medically, like an autoimmune disease, HIV, uncontrolled illness, etc. And what we had was that we had 711 of these patients. This is a very large study, over 800 patients who received only concurrent chemo, and of those, 191 patients of the 711 total had some induction chemo prior, but also had concurrent. So you can give a couple of cycles of platinum-based chemotherapy before the concurrent, but you had to have the concurrent. And 191 had a bit of extra chemo, but not chemotherapy after the end of the radiation. And these are the chemotherapy regimens that were used. This was an international study. We certainly participated, and I'm a co-author on it. And so it was either cisplatin or carboplatin, and most of these patients did receive etoposide, but vinorelbine, pemetrexed, docetaxel were permitted. Just a little word about the data that I'm going to show you. The progression-free survival is timed from the entry into the study, which is up to 6 weeks after the end of radiation. Most of the previous studies historically have started the clock from prior to the concurrent chemoradiation. And so obviously the progression-free survival is going to be shorter for the control arm when the clock starts ticking later, as opposed to when the clock starts ticking earlier in the historical studies. So people have said that the control arm PFS here is very short, and the only reason for that is because the timing is that it's from after chemoradiation, not from before. So when we now privileged to have the 5-year survival outcomes from the specific study, and this has been published in the Journal of Clinical Oncology and presented. And really what this shows here is a rather spectacular maintenance of this curve separation. The curves separate early, they don't come together, and there is about a 10% increase in absolute survival around about 5 years out. At that point, there's a lot of censoring, but we now have a full 5-year data. These curves, they separate almost immediately, and they do not come together. This is a milestone not only in medical oncology, it's a milestone in medicine and science. And so these people, there's definitely an increased proportion of people who have been cured by this. We believe these curves are flattening out, and that this is in fact a prolonged benefit now, which effectively means cure. And in terms of the progression-free survival, we can see that actually there's about 14-15% of people are increase in the progression-free from about 20 to about 33, 19, 20 to about 33. So in terms of the cure rate, because, you know, people die from other things, of course, but in terms of the cure rate, the real cure rate increase in people who are going to survive this long is probably 14%. So this is a spectacular achievement. We're curing another 1 in 6 people. And it's not just a question of prolonging the progression-free survival, which by the way is prolonged by about an additional year. There's also this very substantial increase in the cure rate. And this is an important curve out to 5 years, which basically shows the freedom from distant metastatic disease. This is the time to distant metastases. And again, it's almost immediately. There's a huge increase in here at 3 years. It's about 20% benefit. And this benefit is persisting out about, again, 14-15% out at 5 years. So this is a spectacular, because I think all of us are very aware of the morbidity and mortality from systemic relapse. It was almost certainly an incurable situation. We know that the benefit here was seen both in smokers and non-smokers. And there seems to be a tendency, although only very few people had EGFR mutation, there was not that many patients. But we can see that there appears to be now a survival benefit, although there's uncertainty because of the small numbers in these patients who are EGFR mutation positive. There is a little bit of an issue with the PD-L1 less than 1%, which we don't care about in Canada. But you know, again, the confidence interval straddle 1. But in the predefined analysis, the PD-L1 of 25% more or less shows clear evidence of benefit. And we also see that the patients with cisplatin seem to have a bit more benefit than the carboplatin patients. The Europeans do not like this restriction on PD-L1 negative that has been imposed in Europe, and this is because it was a non-pre-planned, underpowered group. We now have further updated information that this was better than we thought. And of course, the progression-free survival is positive in both the PD-L1 negative and positive. So in North America, particularly in Canada, but in the United States as well, and in other areas of the world, we're quite happy to put PD-L1 negative patients on this. And you can see here that the progression-free survival is good, whatever the PD-L1 status is by the predefined or the post-hoc analysis. Even in the less than 1%, the PD-L1, the progression-free survival is on the side of benefit from durvalumab. And if you look now at the updated data for the PD-L1 negative, it's certainly not worse, but because it's a small sample, the confidence intervals go both sides of the unity line. But we are quite happy in North America to put PD-L1 negative patients and PD-L1 positive patients on durva. In terms of the response rate, we see that the response rate is actually better for patients on durvalumab. So the tumors continue to shrink, which is very important. And the disease control rate is better by about 10% on the durva compared to placebo. And these may be the patients who may actually endure the additional survival and progression-free survival benefit. But there is a higher continuing response rate on the durvalumab. So if you look at the sites of recurrence, again, certainly there is some sort of local recurrence in the lung area, but most of the recurrence, is in the distant metastatic sites, and that is substantially reduced by the durvalumab. So what we've learned from the durvalumab in the study is that it reduces not only the lung local recurrence down from 18 to 13%, but it also reduces brain metastases from 12 down to 6%, liver metastases, bone and adrenal, and so on. So there's a massive effect, not only on local recurrence protection, but also on protection from systemic recurrence. And so if we see the old INT-0139, surgery does not have a benefit on systemic recurrence. But here in the Pacific study, there is a major benefit in reduced systemic recurrence as well as improved local recurrence rates. And so this is the graph that shows the disease progression to extrathoracic progression or death. And you can see out to 3.5 years, a massive protection from distant recurrence. And again, this point that the cisplatin is benefiting a bit more than the carboplatin, but we know that some people have to have carbo. We know that because of ototoxicity and tolerance and so on. So carboplatin remains, a very viable option here, but the benefit is a little bit more in the cisplatin. The etoposide is probably the partner chemotherapy that gets the best benefit from this. Most of these patients, or many of them, did have etoposide. But any of these, the taxanes or the vinca alkaloids is a reasonable choice if that's what your practice is. The other striking phenomenon is that if you got patients onto treatment less than 14 days from the end of radiation, they did seem to do a bit better than if you got between 14 and 42 days. So in general, if you can get people on sooner, it's better. There are ongoing studies looking at doing the durvalumab actually with the combined chemo radiation, but that's still, we don't have the good data on that yet. We don't have data. But if you can get patients on within 14 days, that is better. And so what you really need to do is get a CT scan at the end of radiation, because you want to know they're not having disease progression. So you need to pre-book that, so make sure that the radiation comes to an end, the CT is done maybe the next week. You're on the phone to the patient or whatever, and you're able to start within 2 weeks if the patient's fit enough. Some patients, of course, are not fit enough. They need a little bit of time to recover from the chemo radiation. So that, it's legitimate to start after 14 days. And for all we know, it's still beneficial after 6 weeks. But you should try, if possible, to get it started somewhat earlier. In terms of the side effects from the durvalumab, there's a small increase in the grade 1 radiation pneumonitis from about 16% to about 20%, but not the grade 3-4 pneumonitis. There's a little bit of an increase in pruritus and rash, but it's very mild. You can see the grade 3-4 is very minimal. and very similar to placebo. So this is a striking benefit for substantially low rate of toxicity. And it's not that often that we get this in oncology, but this drug is generally well tolerated and very efficacious in terms of the historical lack of progress in stage 3. And again, you see this small increase in what is effectively grade 1, grade 2 pneumonitis. A lot of the pneumonitis, of course, is from radiation, and sometimes difficult to tell. But if it's occurring within the radiation field, it's probably the radiation. If it's occurring outside the radiation field, it's probably the durva. And we'll talk a little bit about that. And you also have to watch the thyroid. Both hypo and hyperthyroid is a little bit more on the Nivolumab. So I don't want to underplay you have to watch these people carefully. You have to be able to collaborate with immunologists and so on in the event there is serious toxicity, but it is really uncommon. Patients leading to outcome of death, nobody on the Nivolumab. In the patients on more than 14 days, 1.4 compared to 1.7 on placebo. So there is no increase in the death rate as a result of this compared to placebo. It's one of the benefits of doing a placebo-controlled trial. And you do see the bit of an increase in the low-grade pneumonitis in the less than 14-day patients. So basically, we have a drug here that substantially increases the overall survival from 29.1 months up to 47.5. The PFS up from 5.6 to 16.9. That's a year increase in the PFS and more than a year increase in survival. The hazard ratio stratified is 0.72 for survival. It's 0.55 for PFS. And the 5-year overall survival rate's 43 versus 33%, and the PFS 33 versus 19. And this is the 5-year update. There is a massive program being conducted by AstraZeneca with Nivolumab in various stages of lung cancer, including resectable stage 3 and stage 4. And I don't have time to go into this today, but there's a lot of support from the academic community to take this drug forward. Just a little bit about the EGFR patients. There is another study ongoing called LAURA, and this is in stage 3. And these are the EGFR mutated patients, and they've been randomized after to either concurrent or sequential, but they were randomized subsequently to get osimertinib or placebo. We don't have the results of this study at the moment. So in the long term, there's going to be a bit of an open question as to how to treat the EGFR mutated patients. Should they get osimertinib? Should they get Nivolumab? But they should not get both, because that is dangerous to give both. They don't do that. But it should be one or the other. In terms of the quality of life on the Pacific study, there was no shortfall as a result of the Nivolumab compared to placebo with respect to the global health status or physical functioning. So there's no impairment there. And so a large group of international investigators in Europe and Australia decided to study this real-world evidence study, which has been presented at the Esmo in 2021. And they accrued a large number of patients who reasonably good performance status, concurrent chemo radiation, or sequential, no evidence of disease progression following radiation. And they accrued 1,400 patients in Europe here and in Australia. And you will see here that there's a typical kind of spread for people, including less than 1%, more than 1% PD-L1, stage 3A, 3B, 3C, smoking status, a fairly typical group of people that you would see in your clinic fairly commonly. Almost all of these patients were able to complete their Nivolumab. There was actually, compared to the Pacific study, the PFS appeared to be longer, but they do say, when it's not a formal study, the PFS maybe not so reliable, but the PFS is certainly not shorter than was seen in the Pacific study. And what we see here for real-world progression-free survival, that sequential and concurrent are almost as good as one another. Sequential is not quite as good as concurrent, but we know that there are patients who need sequential, and it seems to be a very reasonable thing to do in those patients. Stage 3A, 3B, 3C, you can see it's pretty good. The PD-L1 negatives did almost as well as the PD-L1 positive, so it's reasonable to put people with PD-L1 negativity on. And the histology, the big difference, of course, is what we expect. The squames don't do as well as the adenos, but we know that that is true throughout the squamous adeno comparisons in many, many studies. In terms of adverse events, there was about just under 10% of these people had permanent discontinuation, 5% had temporary discontinuation. Usually it's pneumonitis, and so, as I said, there's some uncertainty sometimes whether it's due to radiation or chemo. In about 2.5 months after the end of radiation, that's when the pneumonitis tends to occur. So do be on the lookout for it. But the toxicity here generally was the same as the Pacific study. So really there was I think this is a confidence building exercise that you can do this not only with concurrent, but with sequential as well. And you can do it in patients that you meet in your ordinary clinic. And many of these patients had a significant comorbidity burden, such as hypertension, such as COPD, such as diabetes, such as heart disease. There was a lot of these patients had a significant comorbidity. So I'm going to talk a little bit about the Thoracic Multidisciplinary Board. We know that the thoracic MDT is a very important component of patient management, as are MDTs throughout cancer now, because cancer is generally much more complex than it used to be. But stage 3 is particularly complicated. It's heterogeneous, it's common. It does require sophisticated staging, which sometimes is invasive. There's no single definitive approach. The management can be debated. This is a rapidly evolving field, and the stakes are high because right now we're going to increase the number of patients who are cured. So the stakes are high. The MDT concept has been endorsed by the British National Institute for Health and Care. They do make the point that you should try to discuss every patient, but it may not be possible, and you shouldn't be delaying patients just to get them on the MDT. But it's been operational in the United States since the 70s, for 20 years in the Commonwealth. It's generally required by health authorities for accreditation purposes. So the health authorities now use the MDT as a barometer as to whether hospitals and cancer centers should be accredited. There's a complex journey these patients undertake, from referral, from, they see the respirologist, they get diagnostic investigations, which may or may not be complete and may or may not be adequate. They may get discussed at the MDT around the issue of, what more to do diagnostically. What do they need? Do they need a PET? Do they need an MR brain? And how to interpret the findings. Have they only got cytology? Have they got, decent tissue? And then there's the issue about once you stage these patients and understand their performance status and comorbidities and their inclinations, how to treat them. And that, so there's a requirement here for the MDT, both at the pre-treatment decision stage, as well as the sort of post-evaluation stage where you need to make a treatment plan. And the advantage are that patients are more likely to receive guideline concordant treatment. Often it's, there's actually less delay if they can go through an MDT and everybody's aware of the urgency. There's better communication with GPs, for instance. Standards are maintained. You have an ability to discuss in a collegial way. But there is a possibility here for delays that needs to be careful. So there are some disadvantages. You do absolutely need to have high technology because sometimes it's patching in people from different parts of the country. You need pathologists patched in, you need radiologists, you need oncologists from distant centers and surgeons and elsewhere. So the technology has to work. It has to be tip top, and you should make an investment in the best technology you can afford. What I've learned is that it's a collegial experience. No one has all the answers. The technology has to work perfectly. You've got to include pathologists, radiologists, and pharmacists. Pharmacists, very important. I've learned that, different disciplines have different approaches, but everybody's trying to do their best. They're exposed to different data, and we get to learn about each other's data and inclinations at these kind of meetings. The payers have to align with the guidelines in the MDT, because if you're incentivized monetarily to do something different, that's going to be a problem. So the payers have to understand what's going on. And basically, it's a good education not only for the trainees, but for me and for everybody who's been doing this for years. You always learn something new from your colleagues. And certainly colleagues know if they're speaking in front of their peers, they're going to be more motivated to keep up to date. Now, COVID has had an impact. This is just from Italy, 2 cancer centers showing before and after COVID. There have been fewer patients discussed at the MDT. But they do make the point that, you can use telemedicine effectively, not only to talk to your colleagues, but also to talk to patients. And they studied, does patients are seen by telemedicine, even consults, is there a significant delay to treatment? The answer is for radiation treatment and systemic treatment, and this is from the United States, there's no delay. But if this is a surgical patient, there is an increased delay of about a week, and that telemedicine may not be the best way to assess patients for surgery. Now, the MDT can be more or less sophisticated. This is the core MDT, is your local MDT. It's the radiologist, the pulmonologist, the pathologist, the surgeons, the med-onc, the radiation therapy, maybe a research coordinator, a palliative specialist is important, nursing, pharmacy, and so on. That is your core MDT. But in some places that are very well resourced, you can have, in addition, specialist MDTs such as advanced radiotherapy planning, a nodule MDT, an immunotoxicity MDT, a genomic tumor advisory board. This is a kind of nice to have, but not need to have. And you can even have a supranational MDT for really difficult cases. And this has been published recently by Sanjay Popat et al. But basically, at the very least, you need to have a core simple MDT for these patients. And what are you going to discuss? You're going to discuss staging, the multimodality approach, the PD-L1 status, the borderline resectable patients, whether there's some genetic driver mutation that you need to know about for later, and what kind of systemic therapy, what kind of adverse events, what are the comorbidities, the clinical trial concepts, and so on. So it's better if patients get trafficked through academic centers, but we know that not every center is academic. We know there are rural areas, but with modern technology, you can patch them in. And so you can have a coordinated approach so that we get a good standard of care for everybody. And of course, Canada is a huge country, and we rely on telemedicine quite a lot. Other countries, it's not so important, but in Canada, it certainly is. And we know that people who do at least get an opinion in an academic center do better because they're more likely to be exposed to the option of new modern drugs and modern complicated multimodality treatment. And we know that in the United States, for example, this is the SEER data of nearly 50,000 patients, only 23% got guideline concordant treatment, but if they did better. So if you can get patients onto an MDT that can provide guideline mandated treatment and or clinical trials, they do better. So I'm just going to finish off with a couple of case reports if I have the time here. So the folks at your end, please tell me if I'm running out of time. So here's a 65-year-old man, increasing dyspnea, 75-pack year smoking, quit 20 years ago, used to work in a plastics factory with fumes, no real significant family history. He's on Covasol for hypertension. He does have bilateral hearing loss, by the way, and he wears hearing aids. He's mildly obese, but apart from that, he's not too bad. So here's his chest x-ray, and you can see there's a mass in the left upper zone. The left hilum looks a bit full and a bit convex outwards compared to the right. There's a vague haze and a little bit of loss of volume on the left, and you can see that with the left hemidiaphragm is a bit higher than it should be on the lateral. And you can see that there's maybe just a hint of a mass there. And these vertebrae are too white. They should be darker. So some subtle changes. So here is his CT scan, 30th of August 2019. You can clearly see a spiculated mass in the left upper lobe. He has some mediastinal adenopathy in the AP window and just above the tracheal bifurcation. He has a biopsy, an EBUS, and what we see here is a TTF1 positive. This is an adenocarcinoma, and he has a BRAF mutation, which is an atypical mutation. We don't really know what to do with that, so we just leave that for the time being. And he gets presented at the MDT, and what we see is that we all agree he's probably stage 3, but we think he needs an MR head and a PET CT and pulmonary function test. Here's his MR. It's normal for age. He has the PET scan showing the primary and the mediastinal adenopathy in at least 2 sites. And he's then rediscussed and referred onto medical and radiation oncology, and he's a good performance status, ECOG-1. He has a stage 3A multi-station disease, and the decision is for radical concurrent chemoradiation and curative intent radiation. But we do also make the policy to advise patients that they need to that they're probably going to be offered immunotherapy afterwards, so it's not a surprise. So here's his baseline. He has after 1 cycle of chemo and halfway through the radiation. This is carboplatin-based treatment because of the tinnitus. And you can see that it is better. This kind of mass is shrunken down. The left lobe is expanded somewhat. And this is at the end, coming to the end of radiation, or he's actually got carbopemetrexate actually towards the end of radiation. This is considerably improved on the chest X-ray. You can see the lateral is much better now. With benefit of hindsight, you can see how abnormal the lateral film was. I always make a point of going over the lateral film with my trainees because I find that it's an area of weakness, and there are many things you can learn from the lateral chest X-ray. The CT scan shows improvement. It's not gone by any means. CT, the mediastinum is better, the primary tumor is better, so there's no evidence of disease progression. And he commences durvalumab 20 mg monthly, not the 10 Q2 weeks. We're allowed to do 20 mg per kilogram monthly on the 2nd of January. The lesions continue to get smaller on the durvalumab. He tolerates it, but we do note he's coughing a little bit more. But, this is the first cycle. However, in early April, after 2 cycles of durvalumab, he's coughing a bit more. He has a little bit of a patch of something over here, a little bit of streaky something here, and is it the radiation? And later in April, it's a little bit more. We gave him some antibiotics between here and there. We decided to hold the durvalumab and keep him off treatment. But by July, he was feeling better. The chest X-ray certainly shows radiation changes in the radiation field, but the right lung is completely clear. We had taken him off the Covasil, which we know can cause cough as an ACE inhibitor. He was just feeling much better. So we just said, you know what, we're going to restart the durvalumab. We don't really know whether this was radiation pneumonitis or maybe a little bit aggravated by the durva, but you may never know. But we certainly feel there was an element of radiation pneumonitis here. He continued to complete 12 months of durvalumab. He's much less dyspneic. His lung bases have returned to normal. The CT scan is clearly, you see the radiation change. This tumor is probably dead in this area here. And there's been no evidence of disease recurrence, and he's feeling great, and we're just continuing to surveil him. So just a little bit about these side effects there. This is an immune checkpoint inhibitor. Any part of your body can become inflamed, but durvalumab and the PD-L1s, we believe the incidence is somewhat less. But you have to be prepared to treat particularly pneumonitis in people who've had radiation as well as an immune checkpoint inhibitor. So grade 1, you can probably continue. Grade 2, you kind of hold the drug, the durva, consider steroids, probably go with it. Grade 3, 4, you're certainly starting IV steroids, which might be methylprednisolone, 1 to 2 mg per kilo per day. And if necessary, infliximab. But I've never had to do that, and I've given many people with durvalumab. I've never had to go to that extent. Case number 2, briefly, here's a 7-year-old female. She smoked a pack a day forever. Her chest X-ray shows both hyperinflation and a very obvious abnormality, which you can see on the lateral is actually posterior. It looks here, you don't know on the PA what it is, but on the lateral you can clearly see, and you can also see this is the oblique fissure. He has a lined fissure. This tumor is going right through, so it is clearly going down from the superior lobule of the lower lobe across the fissure into the left upper lobe. Because she was short of breath, she had a CD pulmonary angiogram, which did not show any pulmonary emboli, but it did show this big tumor invading somewhat into the chest wall there with a little bit of rib destruction. So she had a PET scan. There's a PET scan, basically confirms that there's no distant metastatic disease, but she does have this very large tumor there with the more viable edge there. She proceeded to a biopsy. This is the tissues of fully differentiated cancer. We didn't really know. The TTF1 was negative, and the P40, which is our squamous marker, was not positive either. So we see poorly differentiated sheets of tumor cells, typical what you kind of expect in a heavy smoker. P53 mutated, which we think doesn't really affect, but she was PD-L1, by the way, strongly positive. She was strongly positive for PD-L1. Pulmonary function tests were borderline, as you can see from that chest X-ray. Her final stage was T3N2. The surgeon said this is not a surgical case for sure. She had pain, but she didn't want to have narcotics. So she decided to dose herself with Advil. We said, okay, we'll go ahead with the chemo radiation. We proceeded with cisplatin with etoposide, 1 cycle of induction, so we were able to get GCSF. It was somewhat of an improvement. And then we went cycle 2 concurrent with radiation. We changed to carboplatin because she had tinnitus, and she commenced radical intent radiation. She was halfway through the radiation when she had an episode. As you can see here, there's free air under the diaphragm. She'd perforated a duodenal ulcer. She was not in good shape. She was malnourished at this point. She was taken to the intensive care unit. She was, not really neutropenic, but her albumin was down to 20. She had atrial fibrillation, which had to be controlled, and she was anticoagulated. She had a left pleural effusion drained, but it was cytology negative. She had broad spectrum antibiotics, and she received completion radiotherapy when she started to recover, and she was discharged from the intensive care unit after 3 weeks. So when I saw her, she was ECOG 3. We said no more chemotherapy. We decided just to complete the radiation, but this woman definitely wanted to survive. And subsequently, we said the radiation was completed. There's no evidence of disease progression. This was her, this tumor had definitely shrunk down. The free air was gone. There was no pleural effusion left. So we said, you know what, we're okay to think about durvalumab. The performance status had improved. And she commenced durvalumab, and she was able to complete 12 months of durvalumab, despite being over 70 years old, despite being somewhat frail initially. We were able to do it and get through it. And she remains well. She's now post-durvalumab, a year post. She's well without evidence of recurrence. So just to show that this is a drug that's generally well tolerated, and you can give it to older people and people who are somewhat frail, although you have to be careful, of course. So we now have several, pillars of cancer management: surgery, radiation, chemo, targeted therapy, and immunotherapy. And so basically, the standard of care now is curative intent chemoradiation.
Excuse me, Dr. Vincent. We have only three minutes left.
Okay, so this is now the standard of care. There's an improvement, especially on the 14 days. The side effects are well tolerated. You can give it every 4 weeks, and you need to understand the management of serious disease, of serious immunotherapy, which is rare in Imfinzi. This is a new gold standard, and I thank you for that. Thank you.
Thank you, Dr. Mark, for a valuable, informative presentation. The session is open to any question, and any questions may raise your hand.
I will start with a question, Dr. Vincent, if you excuse me.
Sure.
Yes, actually, it's great to have such a progress in the management of stage 3 unresectable lung cancer. As we know, those patients having poor outcome, as you showed in your slide, and as we know, most of those patients relapse within the 5 years. So it's actually great to have such progress in the management of those patients. My question is, suppose you have a patient with stage 3 unresectable lung cancer, and the patient underwent concurrent chemoradiotherapy. And after evaluation of the patient is progressed. He is not responding to the concurrent chemoradiotherapy, but he is still in stage 3. There is no distant metastasis. What's your recommendation for such patient?
So what I might do is I might consider a rebiopsy, because sometimes you get the radiation change and there can be a little bit of confusion. The PET scan's not so reliable. Is the patient symptomatically worse or symptomatically better? So sometimes there can be a little bit of confusion because the scarring and so on from the radiation, you can be a little bit uncertain as to this real disease progression or not. So sometimes I'd refer a patient back to surgeon to say, you have a lesion here. Can you biopsy this just to tell us what's going on? And sometimes, it's not so much as progression as you thought. If I'm a bit uncertain, sometimes I'll watch the patient for another month or two. And what I like to do is I like to measure tumor markers like CEA, CA199, CA125, even at baseline. And then this helped me to see if I'm uncertain is the real progress or not, to remeasure the tumor markers after the chemoradiation. If the tumor markers are going up, we know that generally this means genuine disease progression and treatment failure. If the tumor markers are going down, then maybe you can wait and watch for a little bit. But if the PD-L1 is good, or not, you can use drugs like pembrolizumab, or change to a different chemotherapy, or nivolumab, pembrolizumab. If this is genuine disease progression, the patient hasn't had immune treatment yet. And the other thing you got to ask is there a driver mutation? So now we have a KRAS G12C. This is now druggable. We have, of course, the EGFR and ALK. These are druggable. So the other thing to get is make sure you get next generation sequencing. So if there's disease progression, maybe there's a druggable oncogene.
Yes, thank you. Another question, please. If you have a patient with a stage 3A and the patient is marginally resectable, do you recommend to go for neoadjuvant treatment, then surgery, or for we will deal as unresectable stage 3 lung cancer? What do you recommend in such situation?
We have discussions about these patients all the time in the tumor board. And I think at the end of the day, what we do is that we present the alternatives to the patient. We can say, you can go to surgery and have this tumor taken out. The local control is better. But in our system of funding, we cannot give you the durvalumab. If you have money, you can pay yourself for the durvalumab. I think durvalumab is perfectly safe after surgery. It's just that there's no data. So in the Canadian system, if they have the surgery, we cannot fund the durvalumab. If we go with the durvalumab, we cannot have the initial surgery, but sometimes what we do, we give 2 or 3 months durvalumab, tumor continues to shrink. The patient says, I want surgery. I say, right, you go to surgeon want to take out, and we complete the durvalumab afterwards. So we try to play it both ways sometimes, yeah. But I think there is a role for surgery, but I think we should not do it at the expense of immunotherapy.
Yes.
I have a question, Dr. Mark. In case of EGFR mutation positive, post-concurrent chemoradiotherapy, what best way to give durvalumab or osimertinib?
Yeah, so we again don't have the data yet from the LAURA study for the osimertinib. We don't have the data, so we don't have funding for stage 3. We have funding for stage 4 for osimertinib. They're very easy to get for stage 4. So right now we are giving EGFR mutation positive the durvalumab. We believe there is some benefit in patients, and we are keeping the osimertinib for later recurrence if they have it. Now the LAURA study will read out, that is a control arm of placebo, so it's not osimertinib versus durvalumab. So we will see what is the benefit from the osimertinib, but it is quite good in the ADORA study. So we will see how that turns out in the long run. I think it's still an open question.
Yes.
So, Dr. Vincent, let me ask this question, please. If you plan to consolidate your patient with durvalumab, when is your first time to evaluate him? Like you finished your concurrent chemoradiotherapy, when will you do the CT scan to evaluate the patient? As you know, in the PACIFIC study, patient who started durvalumab yearly, less than 2 weeks, they did better than the other patients.
Yeah, we try to do it in the week after the end of radiation. So, we try to do it the next week of radiation, and then we make sure that the patient can be seen, and we book a durvalumab appointment, slot in the chemo unit so that we don't have to say, oh, the chemo is full, we have to do it in 3 weeks. So we pre-book everything. We get the CAT scan 1 week after. We evaluate the patient at 2 weeks, ready to go with the immune therapy as long as there's no progression. So but if the patient's unfit and very weak and needs a rest and that kind of stuff, then, we push it out a bit longer because we know the patient won't be fit to start. But if the patient's fit and ready to go, we pre-book it and just get it moving quickly.
I have another question, please. If we give durvalumab as maintenance after finishing concurrent chemoradiotherapy, and later on patient presented with metastasis, and PD-L1 showed more than 50%, can I give immunotherapy like pembrolizumab in case of my patient in a previous durvalumab?
Yeah, so the way we've dealt with that is that if the relapse is more than 6 months from the end of durvalumab, if they relapse more than 6 months when the durvalumab is finished after durvalumab, then we are allowed to treat them like a new phase, a new stage 4, and we will give Pembro or Nivo, Ipi, so we have no restrictions. But if it's on the durvalumab, they're progressing on durvalumab or within the 6 months, we cannot retreat them. Now, is that the right thing to do or the wrong thing to do? We don't have a lot of data on this yet, but that is our policy that we've adopted. At an early relapse, we don't treat them with immune therapy, at least not immediately. We might give them second-line nivolumab after chemo. We can still do that, but we would not lead off with an immune if they are within 6 months of DERVA.
Thank you. Before finishing, I would like again to thank Dr. Mark for brilliant presentation, and we hope see you again. And I would like to thank all audience, and we move to other sessions.
Thank you very much.
Thank you.
To all my colleagues, hope to see you in person at some time. Keep safe. Thank you.
Thank you.
واحد يصلح الكون. مرة هاي المفرد الكتلة والمحاربة الكتلة والظهر كل واحد شطار حتى أعضاء المركزية 4 2 2
اضطريت اوقف السياره بالطريق وصلت.
مش بديل ما في بديل.
معي كرسي مو خايف من احد.
سبيكر موجودين؟
8 كان سنتين صارت 4.
سليمان دكتور سليمان.
دكتور سليمان اول شيء.
السلام عليكم دكتور موسى والدكتور قاسم موجود انا.
السلام عليكم، كيف حالك دكتور سليمان؟
الحمد لله الله يسلمك.
اهلا وسهلا فيكم جميعا في هذا السيشن والسيشن الاخير. الله يعطي العافيه لكل اللي جهزوا وقاموا على هذا المؤتمر الناجح ان شاء الله. دكتور سليمان استاذنا كبير، خريج الجوردان يونيفرسيتي Faculty of Medicine. Suleiman complete residency in the pediatric from Michigan State University والامريكان بورد in pediatric وjoined the University of the Minnesota USA في pediatric hematology oncology و PMT ماستر ديجري والبورد امريكان بورد. والدكتور سليمان speak in many local and regional international meeting and conference. طبعا راح يحكي اليوم مع دكتور سليمان سويدان على congenital hemophilia with inhibitor, introduction in acquired hemophilia والفاكتور 7. تفضل دكتور سليمان.
اوكي شكرا دكتور قاسم على تخدم من لطفك هذا دكتور قاسم، أنت أستاذنا ومعلمنا يعني. Thank you very much for the invitation. I'm trying to share the slide.
دار لورا شوف بالشارع
دكتور قاسم لو تسمحوا لي أعمل شير السلايد، ما مسموح لي. Permission to share my slides. دكتور قاسم لو يعطوني permission to share my slides. ما في permission.
دكتور سليمان مش طالع الصوت ومش عامل شيرنج.
لا أنا الصوت سامعه، بس إنه بدي permission عشان أعمل sharing to my slides.
يلا سطل الصوت.
بس إنه ما في sharing to my slides يعني permission. بدي permission من الهوست to share my slides.
يلا دقيقة. تفضل دكتور سليمان اعمل شير.
تحاول تعمل شير دكتور غلبك.
والله بحاول مش ظابط، ما في بيرميشن يعني.
معلش دكتور بس كمان مره غلبك لو سمحت والله.
طيب هاي بعمل شير، بيطلع ايش؟ شير كونتنت، وات دو يو ونت تو شير.
مجرد ما طلع لك انه الله يعني بعطيك انه شير كونتنت، معناته انه انت عندك يعني اكتف السيرفيس، بس غلبك اختار اللي بدك اياه ورن ان شاء الله دكتور.
طيب دقيقه شوف. بينت السلايد الان. واضحه السلايد؟ في سلايدز؟
الو دكتور بس انت كل اللي بتحتاجه تختار اللي بدك اياه وتعطيه شير بعدها، يعني توافق على الشير اخر شيء في الكبسه تحت. يعني الخدمه عندك شغاله اكتف، بس كل موضوع انه اكتيفيتد بس فقط ان شاء الله.
طيب انا وين هاي في شير، بحط شير، يعني دائما نحط شير بيطلع بندخل شو اللي بدنا نعمله شير بزبط، بس ما في هون في تكست ايمج. what do you want to share optimize for text and images، بس هذا الموجود.
هلا انت مشغل الباوربوينت دكتور عفوا عندك بدايه؟
موجوده
عفوا اكتف شغاله ولا مش شغاله بس عفوا دكتور؟
لا موجوده على موجوده مفتوحه.
مفتوحه، المفروض انه ياخذ لك اياها مباشره.
ما هي المشكله، ليش ما بعرف
طيب
ليش ما
طيب الغي الشغل دكتور واعملها كمان مره من اول جديد اغلبك.
طيب
يعني ستارت البروسيس كامل من جديد.
هاي شير ما بيطلع شيء، المفروض تيجي مباشره يعني ما بتيجي.
ثواني ابدا من شير.
هاي بلش.
لا بس
بلش
الشير. جرب دكتور هلا من عندك قلبك.
يلا دقيقه. هاي شير كونتنت what do you want to share بيطلع نفس الشيء يعني.
ما في شيء جنب. طب شو بيعطيك على اليمين، على يمين الشاشه ايش بيعطيك؟
ما في شيء.
طب انت هل في عندك شير سكرين 1 اللي على الشمال صح؟ في عندك شيء زي هيك؟
انا بيطلع عندي كلمه شير موجوده تحت، مش في عندنا ميوت ستوب فيديو شير.
هلا
بضغط على
هلا لحظه، بيطلع لك انت زي مربعات هيك جنب بعض. هلا في على الشمال شير سكرين 1. سكرين 1 طالع عندك كلمه شير سكرين 1؟
لا، في عندنا سكرين، بس لما احط بالمربع بيطلع سكرين.
لما دخلت دكتور سالك على البرميشن تبعك انه allow استخدم الشاشه، استخدم الكاميرا، استخدم كل شيء؟
كتبت يس.
طيب اغلبك دكتور تعمل ساين اوت وساين ان كمان مره، لانه واضح انه في شيء مش شغال كان عندك. ساين اوت يعني عفوا خروج بالاكس اللي تحت، الاكس اللي على اليمين تحت الاحمر، ايوه وادخل. حدا مني شغله من عنده بس.
استرازينيكا.
انا بقدر في صعوبه يخليه يظبطوها، بس بده حد حل ثاني. تبقى حسن خلينا صورة انا وقاسم كمان ما شفت قاسم.
ست سهير خلينا نرجع على التليفون نتاكد شو صار معه.
يسلم.
والدكتور ماهر معنا؟ دكتور ماهر. يبعثها ايميل.
تليفون هلا ببعث يعطوني الرقم. الو. عليكم السلام. تفضل سيدي تفضل. انا اي نعم. انا طيب هلا بس اشوفهم بكتب لك، لاني الان في المؤتمر. انا هلا في
اسف جاهز تطلع. طيب شيلوا عن الدكتور ماهر الميوت. دخلوا الدكتور ماهر. هاي شير لمين؟ هاي شير تعال. مشيت مع الدكتور سليمان. خلص مشيت.
بس انا مشكلتنا الشير نفس الشيء ما هو ظابط.
انا سامع قاسم.
اوكي هي
ماهر. تفضل دكتور سليمان.
اوكي sorry يعني for the technical problem. Thank you Dr. Qasim and Dr. Musa, and I would like to thank GSS for the invitation and Novo 7.
Precision.
So today I will talk something we see every now and then, not common, but still we have patients we see in our clinics. Like today I saw factor 7, factor 10 in my clinic, although are rare, but we have to know something about these patients, because I think these patients they don't get the appropriate management because they are not so common disease. Next slide. So when we are talking about rare bleeding disorders, so it could be clotting protein disorders, as we have fibrinogen, factor 1, prothrombin, factor 2, factor 5, factor 7, factor 10, factor 11, 13, and we have combined factor deficiency like factor 5 and 8, and sometimes we have combined factor deficiency, vitamin K dependent factors, and we have the plasminogen activator inhibitor deficiency. I saw today a patient with this disease. So, but they are very, very rare. And of course, we have platelet defects, like we have the Glasman thrombocythemia, and we have the Bernard-Solé syndrome, and we have the storage pool disease. Most common of them, Glasman thrombocythemia, especially this one in northern part of Jordan. Of course, sometimes you do all the screening for the clotting and platelet defect, quantitative and quantitative. You don't find any clue for the bleeding in your patient. Then, but by simple physical exam, you can see the connective tissue disease, the collagen defect. Next, please. Next. So as you see here from the slide, this is some diseases of the collagen defects. We have many of them, although they are very rare, but every now and then maybe you see a patient in your clinic, they come with multiple bruises, recurrent bruises, then you do all the screening for the bleeding disorders like for factors and for platelet, quantitative and qualitative. So all of them will be normal. Then just by the physical exam, you see elasticity of the skin. And there are many types of these diseases. Next. So when we are talking about the rare clotting protein disorders, prevalence is very rare. Unfortunately, we don't have a registry in Jordan, and even neighboring countries, the Arab countries, like registry for the rare bleeding disorder. So I think these the forgotten diseases. We don't have interested too much from our physicians to have registry or recording for these patients to get the appropriate management. Prevalence, as you see, is very rare, from 1 in 500 to 1 in million. And we have maybe the Iranian registry 0.3 to 6.6%, and we have the UK registry is 0.02 to 3.3%, and the Italian registry 0.2 to 1.3%. But unfortunately, we don't have the registry for rare bleeding disorder in Jordan, or even from the surrounding countries like the Gulf area or other neighbors. They don't have registry for rare bleeding disorder. Next, please. So these heterogeneous group of disorders, it's account for 3 to 5% of all inherited coagulation factor deficiency. Is not common, as you see here. So it could be defect in one or more coagulation factors. So as here, it could be a deficiency of one factor, or it could be combined deficiency, like we have the combined deficiency of factor 5 and factor 8 deficiency. And it could be deficiency of the vitamin K dependent factor deficiency, or we have the factor 13 deficiency. It's In comparison to hemophilia A and B, all of them are inheritance autosomal recessive manner. Is not like the hemophilia A and B. They are X-linked recessive inheritance. Next, please. So the distribution, as we mentioned, is varies from 1 in 500 to 1 in 2 million in general population. It's very rare. The most common is factor 7 and factor 11 deficiency. It's account for 37% for factor 7 deficiency and 23% for all the cases for factor 11 deficiency. We have fibrinogen deficiency 10%. Prothrombin is very rare 2%. Factor 5 deficiency around 10%. So sometimes factor 5 in combined with factor 8 deficiency around 3%. Factor 10 deficiency close to factor 5 around 9%, and factor 13 deficiency around 6%. Is it applicable for Jordan? We don't know because we don't have registry in Jordan for rare bleeding disorder. Rare bleeding disorder is like present in more in the Middle Eastern countries because of the consanguineous marriage. So inshallah, in the near future, we will have registry for these patients. I am sure we will have many patients of these were missing, and sometimes they died from bleeding during surgery or trauma with undiagnosed. Next, please. So as you see here, this is the word distribution of the rare bleeding disorder. As you see here, like we have the top factor 7 deficiency around 40%, followed by factor 11 deficiency around 1/4 of all of them, and the other distributed between fibrinogen factor 10 and factor 5 around 10% of each. And the other rare factor 13, we have 6.5%, and we have the combined deficiency factor 5 and 8 around 3%. So as you see here, is like almost most of the country, they have factor 7 is the most common factor deficiency, followed by factor 11 deficiency. Next, please. So the inheritance, as I mentioned, is like autosomal recessive. So it's like mutation irrelevant coagulation factor gene. So there is a mutation in the gene that's responsible for the synthesis of the factor. Sometimes we see why we see factor 5 and factor 8 deficiency together or defect in these particular two factors together. Why factor 5 and 8? Because the amino acid sequence for both factor 5 and factor 8 almost similar. There is less, maybe just different in a few amino acids. So that's why there is defect in one, maybe you see the defect in the other factor. So we have the co-inheritance between factor 5 and factor 8. This is the only two factors because they are sharing a lot of amino acid sequence between the two factors. Next, please. So the classification of these rare bleeding disorder, so it could be quantitative, or it could be qualitative, or it could be both. So it could be qualitative or both. That's why the presentation for these factor deficiencies varies from patient to patient, because depend what kind of the defect they have. Is it quantitative or qualitative, or it could be both. So the severity of these factor deficiencies varies from 1 to 1, but the one that's most likely to have an odd presentation or unusual presentation or no correlation between the factor level and the severity of this phenotype is factor 11. There is no correlation between factor 11 deficiency and the severity of the bleeding. It could be sometimes they present with minor bleed with very low level, or it could be major bleed or severe bleed with a high level. So there is correlation, no correlation between factor 11 deficiency or level and the severity of the bleeding. Next, please. So as you see here, how much we need from this factor for hemostatic level. We have the fibrinogen 50 milligram, prothrombin 20 to 30. As you see here, most of the factor is higher than hemophilia. It's not like as in hemophilia B and A, we have 5%, 1 to 5%. The moderate is lower than what we see here in the rare clotting factors. Fibrinogen 50 and the rest of them varies from 15 to 20%, except factor 13 may be similar to hemophilia. But the good thing about these factors, they have the half-life is long, is like days, not hours like factor 8 and factor 9, except for factor 7, with the shortest half-life in all factors, 4 to 6 hours. But fibrinogen 2 to 4 days, prothrombin 3 to 4 days, factor 5, 36 hours. The longest one, or the longest half-life for factor 13 is varies from 11 to 14 days. There is also sometimes we have the vitamin K dependent multiple deficiency. It's like 15 to 20%. And this one is dependent the half-life of the factor vitamin K deficiency, because there are too many factors to the half-life for each factor different from the other factor. Next, please. So here we can classify the rare bleeding disorder based on the factor activity. Fibrinogen if severe is like undetectable clot. Moderate is like from 100 to 1000. Moderate, mild, more than 1000. Factor 2, the same. If we have severe undetectable clot, you go down, factor 7 less than 10%, factor 10 less than 10%, factor 13 undetectable activity. For the moderate is like most of them less than 10%, except for factor 13 less than 30%, and more than the moderate, it will be the mild type. Here, this is table. It compares the bleeding disorder of these factor in comparison to factor 8 or hemophilia A. If you look for the nose bleeding or superficial bleeding, it's not common in factor 8, around 15%. But the rare bleeding disorder is more, as here fibrinogen especially, 70%. Factor 2 is 60%. Factor 5, 57%. And 5 and 8, you see increase from 15% for factor 8, and for 2 factor deficiency, around 77%. Factor 11 is 34, and factor 13 is 32. Uterine bleeding is 0% in factor 8, is not common, but the rest of the factor, I see the commonest in factor 2 deficiency and factor 7 deficiency. They have postmortem hemorrhage. Hematuria, 25% in hemophilia. It's closed in factor 10. By the way, is factor 10 similar to what you see in hemophilia A and B. GI bleeding, factor 10, 38%, and the rest of the factor is similar to hemophilia A or less. Joint bleed, as here, factor 10 closely, and muscle bleeding, deep bleed, factor 10 deficiency close, what you see in hemophilia A and B, and also factor 13 almost close to factor 10, but is uncommon in the other factor. Here, the most important one is CNS bleed is 16% in factor deficiency, but the most common factor that lead to CNS bleed is factor 13, around 25% of patients Cord blood, as you see here, one of the history you have to take if you have a patient suspected fibrogen deficiency or dysproteinemia or factor 13, you have to ask about delayed separation of the cord because these patients have for cord bleeding, fibrogen factor 1 and factor 13. Postpartum hemorrhage operating, as you see here, more common in factor 13 and factor 8. Oral cavity bleeding, especially in the infantile age during the first year of life, as you see here, factor 10-0. But the other factor, factor 7, and fibrinogen almost close to the factor 8 deficiency. Next, please. Next, okay. So as you see here from the previous slide, we compared the bleeding of factor deficiency in comparison to hemophilia A. As you saw, it was like heterogeneous group presentation is not the same. So if we have fibrinogen, it's like, you know, the gene mutation chromosomal to diagnose these patients. Because of course they have prolonged PT and PDT. And these patients, these you have, when you are taking care of these patients, they are at risk for spleen rupture, fibrinogenemia or hypophosphatemia or dysphosphatemia. They are at risk for splenic rupture. We don't know why. And for the treatment available for these patients, of course, we have the FFP, cryoprostate, or fibrinogen concentrate if available. For factor 2 deficiency, we have, this is a vitamin K dependent factor, so can be given the PCC, and we have the FFP. Factor 5 deficiency, we have the FFP and anti-fibrotic agent. Factor 5 and 8, you have to replace for both. Factor 7 deficiency is the commonest factor deficiency in the rare bleeding disorder. So this patient recombinant factor 7, and we have the PCC and FFP, but most commonly we use the factor 7 deficiency in recombinant factor 7 in Jordan. Factor 10, we have, this is vitamin K dependent, similar to factor 2. Factor 11, of course, in Jordan, we don't have the factor concentrate. The only thing we have the FFP. Factor 13, until now, we don't have the factor 13 concentrate. Recombinant or plasma derived is not available in Jordan. So we use the FFP and the cryoprostate. Next. Next, please. So from summary for what for the treatment, as you see, it's like a replacement therapy for the factor. So it could be FFP, cryoprostate, or prothrombin complex concentrate, or single factor concentrate. This is the best replacement. The only factor in Jordan present here is like 7 concentrate. The other factor we don't have, not available in Jordan yet. Of course, we use non-transfusional treatment like antifibrinolytic amino acid. We have the fibrin glue and this sometimes in some of the factors. Other rare bleeding disorder, we mentioned very rare. We have the Glasman disease or thrombocythemia. This is an autosomal recessive disorder. This one associated usually with superficial bleed or cutaneous bleed, not deep bleed. And this patient, I saw many patients with Glasman disease. None of them they have the same presentation. Each patient they have presentation different from the other patient, and each patient sometimes they need surgery or after trauma they come to bleeding. Treatment for these patients Platelets good, but the problem with the platelets, sometimes these patients, they develop antibody against the platelet. So we tried not to use the platelet transfusion for these patients to save it for emergency, but we can use the recombinant factor 7 for Glasman disease, and alhamdulillah, it's approved now, recombinant factor 7 for the treatment of Glasman disease. Hemophilia with inhibitor in Jordan, we have around maybe 20 to 25 patients. It varies from mild to severe inhibitors. And this is a nightmare for the physician and the patient, for the patient with hemophilia with inhibitors. And this one is like factor 8 is not a choice for these patients, especially when they have high titer inhibitors. Then you have to use the alternative or bypassing agent, like we have the recombinant factor 7, and we have now the Isiluzumab as a treatment also for hemophilia with inhibitor. I think I'll stop here. Thank you very much. If you have any question, please, I am available.
Thank you دكتور سليمان على هاي المحاضرة الرائعة. الأسئلة راح نخليها بآخر السيشن. دكتور علي موجود معنا. تفضل. طيب يلا نجهز. معنا نعم. أهلا وسهلا بالدكتور علي من لبنان.
مساء الخير دكتور علي، تسمعنا كويس؟ احنا مستمعينك.
شيل الميوت، شيل الميوت.
صار كانوا عاملين لي ميوت من اللي عندكم من هلا شالوها.
مساء الخير دكتور علي. احنا الحقيقه
خير.
انا الدكتور موسى برقاوي، بنعرف بعض مليح.
بعرفك اكيد.
انا مسرور جدا ان نلتقي فيك اليوم. كنا حابين نشوفك بالاردن معنا زي العاده، لكن الظروف ان شاء الله بتتحسن الظروف للجميع وبنشوفك معنا دائما. دكتور علي، ان شاء الله. He is a professor of medicine at the Division of Hematology Oncology Department of Internal Medicine, director of the NKBCI, and associate vice president for medical advancement and communication at the American University of Beirut Medical Center. He is currently occupied the position of the vice chair for research at the Department of Internal Medicine, AUB-MC. In May 2018, Professor Taher was granted tenure in the current rank as full-time professor in the Department of Internal Medicine, Faculty of Medicine at AUB-MC. Today, Dr. Ali will speak about will speak about the Iptacoc alpha, what we call it Novodisc also, in the treatment of bleeding. Dr. Ali, you will come, and we are happy to hear you.
Thank you very much, Dr. Berkawi. It was a pleasure to be speaking in this meeting, and I was hoping that I will be available face-to-face. So inshallah, soon I will be in Amman and we will meet again. So I think they are sharing my slide. Today I will be talking about the use of recombinant factor 7 in bleeding disorders. Next. And the presentation is divided into the use of recombinant factor 7 in congenital hemophilia with inhibitors, the use of recombinant factor 7 in acquired hemophilia, the use of recombinant factor 7 in congenital factor 7 deficiency and at the end in Glansham thrombasthenia. And we will be having some slides on the safety of recombinant factor 7. Next. So first of all, I will be starting to talk about the use of recombinant factor 7 in congenital hemophilia with inhibitors. I think the first presenter made it easy for me to move into this part. Next. So as you know, inhibitors are alloantibodies directed against the replacement factor 8 and 9 that typically neutralize the activity of that factor. And the development of inhibitor is one of the most severe complications of hemophilia, as you have heard, and remain to be an important challenge with limited availabilities and treatment options. Now, patients with high titers of inhibitors require individualized therapy by bypassing agent, as was mentioned before, either recombinant factor 7 or activated plasma prothrombin complex concentrate. Next. Now, early treatment of an acute bleed is very well known to all of us that it is essential. And the World Federation of Hemophilia guidelines recommend early treatment of bleeds. Rapid treatment of bleed control is very essential to limit the potential abnormalities and the joint damage. The inhibitor patients are at a higher risk, particularly of developing long-term joint damage following hemarthrosis. So treating them is really very important to avoid this major damage in the joint of the patients. Next. What are the benefits of early treatment? Reduced joint damage, reduced complication, fast pain relief, reduced need for hospital visits, early mobilization, improved quality of life, which is really very important. And a very important health economic factor is reduce the cost of treatment. Next. Recombinant factor 7 is not derived from human plasma, so no transmission of human virus. The mechanism of action, recombinant factor 7, as you know, directly activates factor 10 on the surface of locally activated platelets. The activated 10 binds to activated 5, and you will get the 10-5 complex, which will convert prothrombin to large amount of thrombin, which we call the thrombin blast. And you'll see that this is a burst. And this is really important in all the 4 diseases that we will call. So the thrombin burst occurs independently on factor 8 and 9. Next. The dose in mild to moderate bleeding, 2 to 3 injections of 90 microgram per kilogram per weight administered 2 to 3 hours, or sometimes a single injection of 270 microgram. However, in serious bleeding, the initial dose of 90 microgram per kilogram is recommended. Dosing frequency should initially be every second hour until the bleeding stops. So you would see the difference between mild to moderate to serious. Since the action is really very quick, 2 to 5 minutes, so this is really very important to start early. And we all know that the stability is at room temperature, so you do not need a fridge. Next. It has proven the efficacy in the treatment of bleeding episodes with patients with inhibitors, and around 90% of 9 or 12-hour time points using 90 microgram per kilogram of factor 7. Next. These are several studies, 5 studies, ranging between 1998, 2006, 7, 8, and 2014. And you would see we have the dosing regimen, the types of bleed, mild to moderate, most of them mild to moderate. The dosing is 90 microgram per kilogram, 3 doses. The number of bleeds are mentioned, but the most important thing is to see that the efficacy ranges in all of these studies, whether in the 98 study or 2014, ranges from 86% to around 93%, which is a very good efficacy. And now we would look specifically if it is given as primary or if it's given as a salvage. Next. So NOVO7 is an effective treatment for controlling bleeds. Early treatment is really very important because you will have rapid recovery with fewer injection. And it is the treatment is effective regardless of the severity of the bleed, if it's mild, moderate, or severe. Home treatment also is very important, and this is what we teach our patients and their family because it reduces the time to treatment initiation and cost related to bleed. Next. What about the adverse events? I mean, the few adverse events and serious adverse events documented, as one would expect, is to think of thrombotic events. So there is a low incidence of treatment-related adverse events, bleeds, new bleeds, mild side effect, transient increase in pain, and low incidence, as I've said, of thromboembolic events. Next. Now, we don't only talk nowadays about clinical trials or randomized trials. It is really very important to look into real-world data. And as you know now, in modern medicine, we are all the time talking about real-world data. So not only in clinical trials, but also in the real-world data, the established efficacy of recombinant factor 7 as a first-line home treatment. These are several real-world from the US Diary, International One Registry, the HTRS, which is very well known to all of you, Hemophilia and Thrombosis Research Society, and from the Hemorec Registry from the Czech Republic. All of these showed that it is really efficacious as a first-line home treatment. Next. So when we look into some post-hoc analysis, it was clear that it controls the bleeding in adult and pediatric. Over 61,000 doses were administered in 481 patients. No arterial and thrombotic events were seen. And this is all real-world data. Next. So the first part, I reviewed the use of recombinant factor 7 in congenital hemophilia with inhibitors. Now, a very interesting topic, at least very interesting for me as an adult hematologist, a topic which is really underestimated, and we need to increase the awareness of all physicians, even hematologists, about acquired hemophilia. It's a fatal disease, very high mortality, as said in the beginning, if we don't look at it. So let us look at the data of recombinant factor 7 in acquired hemophilia. Next. So, what is the purpose in treating patients with acquired hemophilia? We have two strategies. The most important thing is to stop the bleeding because the life-threatening is secondary usually. So we need to stop the bleed, but at the same time, we need to eradicate the inhibitor because there is an inhibitor against factor 8 mostly. So we need to eradicate the inhibitor. And the very important thing is we need to treat the underlying disease. For example, a patient with small cell lung cancer, developing inhibitors against factor 8 and bleeding. So stop the bleeding, eradicate the inhibitor, and treat the underlying disease. Also, it is very important in these patients to avoid invasive procedures because sometimes you lose the patients because of procedures done in the emergency room because the emergency doctor is not really aware of the acquired hemophilia. Next. So as I said, the first line is recombinant factor 7, activated prothrombin complex concentrate for those who have it in their country. For example, in Lebanon, we have recombinant factor 7. And the third is the recombinant porcine factor 8, Obizur, which we don't have currently. So these are the three first-line management for patients with acute bleeds secondary to acquired hemophilia. Next. 80 to 100% efficacy as a first line, up to 90% efficacy as a salvage therapy. And we all know, for those of you, for adult hematologists who used to see acquired hemophilia or still witness, we know how the mortality has changed from the 70s, 80s till now because of the presence of recombinant factor 7. Efficacy is very important. It is independent on the inhibitor, so you need to treat the bleed itself, unrelated to the value of the inhibitor. And the treatment regimen is usually by a bolus injection of 90 microgram per kilo every 2 to 3 hours until hemostasis is achieved. Next. I will not go through the model, but I have already talked about it, where you will have the thrombin burst and you will be bypassing the factors. Next. So the benefit of 7 in this patient, it's flexible dosing, safety profile, as I've shown you. Recombinant may be more appropriate than APCC, specifically in postpartum women where it might be a cause of acquired hemophilia. Not contraindicated in with using antifibrinolytic agent with it, and no amenistic response to factor 8 in hemophilia patients with inhibitors. Next. These are some of the studies on acquired hemophilia, and as you see, the number of patients differs from 38, 15 to 139, the last study. Recently, last year, there was an excellent paper in Hematologica on acquired hemophilia, where all the treatment modalities were reviewed. And as you see, the efficacy when used as a first-line therapy ranges between 90 to 100, and when used as second line also ranges between 80 to 90%. Next. Now, those studies were early studies that I have shown you in the 2008, 4, 8 now. But if you continue to look into these studies, 2012, 13, 2020, several studies with a much larger number of patients as registries are done, you, once again, these are around 500 patients, you would see that the efficacy of recombinant factor 7 ranges up to 100% from the 90s to 100%. So acquired hemophilia is really treatable, and salvaging the stopping the bleeding is really very important if you do it quickly, and it is independent on the inhibitors, and the results are excellent in all studies done. Next. Now, also, it is worth mentioning, although that my talk is about recombinant factor 7, that we also have plasma-derived activated prothrombin complex. It is not present in Lebanon currently, but also it is part of the first-line protocol to stop bleeding in all the new guidelines on acquired hemophilia. So I thought it is worth mentioning it, and it is called FIBA. Next. It induces hemostasis in the presence of inhibitor. Also, the efficacy is independent on the inhibitor. Complete response ranges sometimes up to 100% in moderate bleeding and 80% in severe bleeding. And the efficacy in the first line is up to 100%, similar to recombinant factor 7. Next. The treatment, a bolus of 50 to 100 every 8 to 12 hours to a maximum of 200. It is very important to mention here that we should not use it in DIC. Neither recombinant factor 7 should be used in DIC, and the results are really loss of time and economically using recombinant or APCC in DIC patient. Next. So the first two that I have discussed with you is the recombinant factor 7 in congenital hemophilia with inhibitors and the acquired. Now, factor 7 deficiency. Now, this is the easiest because we know that recombinant factor 7 is used for factor 7 deficiency. So it will be very quick. Next. What are the available modalities? As you know, factor 7 is common, and we see a lot of patients. Not all of them need treatment. So we can use recombinant factor 7, plasma-derived factor 7, and prothrombin complex concentrate that includes the vitamin K dependent factors. Next. Recombinant factor 7 is indicated in the treatment of bleeding episodes and for the prevention of bleeding if somebody with factor 7 deficiency, a bleeder, or moderate to severe needs a surgery. And the dose here is different from the Others where it was 90, the dose here is 15 to 30 microgram per kilogram every 4 to 6 hours until hemostasis is achieved. Next. The mode of action is the same. I'm showing it in a different way. Next. And one should always keep in mind that recombinant factor 7 in factor 7 deficiency is different from in hemophilia with inhibitors. In factor 7 deficiency, the purpose is to normalize factor 7. And the dose is, as I said, from 15 to 30. And you need at least 3 to 4 international units. While in hemophilia with inhibitors, as I told you, the dose is 90 microgram per kilogram. You need a much higher dose in order to ensure hemostasis and to bypass the inhibitors of factor 8. Next. So 7 treatment evaluation registry. This is from the real life, and it's called STER. It describes the bleeding episodes, surgery, prophylaxis, and it evaluates the presence or absence of inhibitors or appearance of inhibitors. Next. So the STER evaluation of the recombinant factor 7 shows you that at 6 hours, you will have around 70% of excellent response and 90% of effective response. So it is really, hemostasis is considered to be excellent and effective in around 90% of the treatments at hour 6, patients with factor 7 deficiency. Next. Number of doses needed. If you look at this, the red is 1, the blue is 2, the turquoise is 3. You would see that excluding CNS bleeds in the treatment is considered excellent or effective in around 70% of the patients from 1 to 3 doses. So we don't need a lot of doses to stop the bleeding. Once again, I did not talk about CNS bleed, but as you know, we do not use any more recombinant factor 7 for these patients. Next. The last one, which I'm sure in Jordan you know much better than me, as Glanzham thrombasthenia is more common, and we have very good data from Dr. Abdallah Al-Abbadi. I would briefly review the use of recombinant factor 7 in Glanzham thrombasthenia. Next. So what we can do for these patients when they bleed, either conservative local treatment or platelet transfusion, which most of us does, or recombinant factor 7. Next. Recombinant factor 7 represents a very good alternative therapy for patients with Glanzham thrombasthenia with antibodies against glycoprotein, as you know, glycoprotein 2B3A and the HLA. It is manufactured as a recombinant, and the dose would be here 90 microgram per kilogram every 2 hours. Next. I will not go through the mechanism of action. Next. So what source of data we have for Glanzham thrombocythemia? Some of them are from international studies, around 60 patients, 37 hospitals. We have a very large data comes from Iran, the Iranian open label study. A bulk are case reports. And from what I've described before, the HTRS registry, the Hemostasis Thrombosis Research Society registry, they have 20 patients. So you see, and the GTR have around 45. So you see that the number is not really a large number in Glanzham thrombasthenia. Next. But as you know, the GTR is a prospective observational study, and the registry was closed in 2011, and the data was published in 2012. Next. And the objective was to look into non-surgical bleeding episodes and surgical interventions when you give it for patients with the Glanzham thrombasthenia during surgical interventions. And this is once again the real life data. Next. So around 40% bleeding episodes were managed with recombinant. And what's interesting is around 80% surgeries were managed by the use of recombinant factor 7. Next. This shows you the non-surgical bleed, where the efficacy is really from the 80 to the 90s. When you use recombinant factor 7 alone, and when you combine it with platelets and other. Next. Efficacy profile in minor bleed and major bleed, it's really good. But as you see, the number of patients is not a very large number of patients. Next. So recombinant factor 7 was effective in controlling around 90% of non-surgical bleeds, and was effective in controlling around 95% with surgical bleed. As you know, we used to lose some of these patients because of massive bleeding and refractoriness to platelets. Recombinant factor 7 has a favorable safety profile and very low frequency of adverse event. And now I will end with the next. 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 So recombinant factor 7A has a continuing favorable safety profile, and it is approved in its approved indication, the 4 indications that I have described to you, with a very low overall. What we need to talk always about a thromboembolic event. And if you look into larger study and more than 20 years use, the thromboembolic events is really very low. So as I said, there are several review studies now on all of these 4 diseases that I have described for the use of recombinant factor 7. Next. These are the takeaway messages. I will not go through them, but it is well tolerated, efficacious, and safe product for congenital with inhibitors, acquired hemophilia, glandsam thrombocythemia, and factor 7 deficiency. Thank you.
Thank you دكتور علي. شكرا لك وشكرا لحضورك الدائم المتواجد في كل المواضيع اللي بتخص البناين هيماتولوجي. نخلي الأسئلة للأخير ونبلش مع الدكتور ماهر. دكتور ماهر معنا؟
معكم نعم إن شاء الله. قاسم.
صديقي الدكتور ماهر خضر راح يحكي اليوم في الرير بليدنج ديس اوردر كيسز. الدكتور ماهر consultant pediatric hematology oncology, head of the pediatric hematology oncology division in the Queen Rania Al Abdallah Children's Hospital, chief of bone marrow transplant of the hematology oncology, member of the pediatric hematology and oncology advisory committee in Jordan Medical Counseling, editorial board at Jordan as journal of the Royal Medical Service, and teaching بالهاشم University medical student, وteaching في University Jordan medical student, secretary of the Jordanian Society of the Pediatric Oncology, ومember of the Jordanian Association for Thalassemia and Hemophilia. تفضل دكتور ماهر.
شكرا لك دكتور قاسم. ما بعرف I shared my slides. Can you
جودي نعم.
see my slides? إن شاء الله إن شاء الله. I will talk about rare bleeding disorder, and I will present some cases regarding this issue. Now I changed my slides. You can see that I have now the first slide, rare bleeding disorder. They include non-von Willebrand disease, non-hemophilia A, non-hemophilia B cases, so that any factor deficiency other than these is considered one of the rare bleeding disorder. In contrast with what we know about hemophilias, this is not X-linked in inheritance. It is something autosomal, but still it is predominantly recessive, but still we are facing some cases with autosomal dominant inheritance, like some cases of factor 11 even deficiency and dysfibrinogenemia. And we can see here from the WFHY when they started after 2004 to make more and more global registry, and we can see after 2004 how this trend is increasing and how more and more cases are registered because of more and more interest after that, and early detection and easier identification and awareness. And as my colleagues said, still the most commonly encountered rare bleeding disorder is still factor 7 deficiency, and the second is factor 11. This is according to the European network of rare bleeding disorder. But I guess what we have here in Jordan is some mimicry, but I guess what we have is some more and more prevalence regarding what they have. And we can, if we compare the prevalence, while the factor 7 deficiency is 1.5 million, it is 1 in 2 million in factor 12 deficiency. This change in range, this is the European registry. It is not the Middle East registry. And because of the autosomal recessive inheritance, I guess what we have is much more common compared to the European countries. And here I showed to you the symptomatology difference between hemophilias A and B and the rare bleeding disorder. The dense bars, they include hemophilias where the most characteristic type of bleeding is muscle and joint bleed, while the white bar is something for the rare bleeding disorder. And the rare bleeding disorder, they are presenting predominantly with something mimicking the platelet type of bleeding, which is the mucocutaneous. So that don't it is not strange if they present with epistaxis, with menorrhagia, something mimicking what the platelet disorder have. This is the characteristic type for hemophilia A, but for rare bleeding disorder, we anticipate some bleeding after invasive procedure, some possible bleeding of mucous membrane bleeding after delivery or after circumcision still. And still there is some associations between some specific factor deficiencies and some specific sites with bleeding predominance, like factor 10 deficiency with GI bleed. They have some associations and some possibility of more abortion and more umbilical cord also bleeding between afibrinogenemia with afibrinogenemia and factor 13 deficiency. And still CNS hemorrhage can be encountered not only in factor 13 deficiency, but still in factor 7 deficiency. This shows us how heterogeneous is the disease if we compare it with what we know about hemophilias. The symptomatology is very wide in different rare bleeding disorders. This is compared to the hemophilias. Now, if we talk about hemophilia A and B and compare it with the rare bleeding disorder, we can see in hemophilias any mild derangement and mild change in the factor level will be reflected predominantly and largely on the symptomatology in these patients. If the patient is have just below 1%, is something different from 1%. This mild derangement will affect a lot on the symptomatology in these patients. This does not happen in rare bleeding disorder with heterogeneity. There is a poor correlation in factor 11 deficiency between the factor level and the symptoms, the bleeding profile, and intermediate correlation with factor 7 and the bleeding profile, but a strong correlation between factor 13 and fibrinogen and bleeding profile. So that it is not appropriate by any means to use a single criterion for classification in all types of rare bleeding disorder, because it is heterogeneous, not only with correlation with the bleeding, but also for the level, when to label the patient as mild, moderate, or severe. It is severe in hemophilias if it is less than 1%, while it is severe in factor 10 deficiency if it is less than 10%. It is severe in factor 13 if it is nearly negligible. Now I will jump rapidly and quickly with some cases to make this issue more clear for the audience. If we encounter a case, and actually this is a case of a patient, female patient whose age is 15 years, presented to your clinic for elective surgery. Upon further questioning, what the patient have is a history of easy bleeding and recurrent epistaxis, and the patient went to the emergency room more than one time, and she requested some nasal packing. There is also a personal history of heavy menses, oozing after dental extraction for 2 days, despite pressure with gauze and eyes. This is for the personal history, but still there is a strong family history for this patient, for heavy menses, for her mother and grandmother. She has a brother whose age is 4 years and he has episodes of nosebleed. They also needs every now and then some emergency visits. Keeping in mind that the parents are first-degree cousins. Are we treating in this very strong personal and very strong family history of possibility of bleeding? Are we treating a bleeding intensive? On examination, the patient is normal size, not dysmorphic, vitally normal, some pallor, but she has some extensive scattered, different sized bruising over the lower limbs and upper limbs. Where to go in this patient when you suspect a bleeding disorder? You perform some blood testing and you refer to the hematology for opinion, keeping in mind some differential diagnosis, keeping in mind the physiology and the mechanism of the bleeding pattern and the hemostasis regarding primary or secondary, so that the differential diagnosis will be wide from platelet dysfunction or platelet thrombocytopenia number or function or coagulation factor abnormalities. After doing some blood tests for the patient was mildly anemic, and her hemoglobin was close to 10, and PT was prolonged, while PTT was normal, which means most likely we are talking to some extent about extrinsic pathway. After mixing study, the PT was corrected, which makes the possibility of deficiency rather than inhibitor. Doing more and more blood testing, coagulation factor 7 was revealed to be 14%. This is the factor that is associated more consistently with the prolongation of PT. This is the factor 7, which when combined with tissue factor after tissue injury, it will activate the factor 10 to propagate and induce downstream formation of a stable fibrin clot, so that it is highly needed. This is the factor 7, which is the most common of the ultra-rare bleeding disorder. And the factor 7, it happens in females because it is autosomally inherited. It is more in our area because of consanguinity. It has a different pattern of bleeding in contrast to what we know in hemophilia A or hemophilia B. So that this Alexander disease is one of the most the most common of what you know about rare bleeding disorder. This factor 7, it can be either quantitatively deficient or qualitatively, and anyhow, it will result in some form of coagulopathy. Now the clinical picture is wide. It can range from asymptomatic to severe life-threatening condition, and the severity, you label the patient as severe when the factor is less than 10%. And we can see here the weak correlation between the factor level and the bleeding profile in these patients. And this is the very heterogeneous presentation for this bleeding disorder, keeping in mind the mucus type of bleeding is still the predominant in this factor deficiency. And as Pivandi said, from the European registry, still more than 50%, they may be asymptomatic, these factor 7 deficiency, and 17% they bleed after a trauma, and 20% they have some spontaneous minor bleed, while the minority, only 7%, they may have some major bleed, but still this major bleed may reach the brain or other internal organs. Still the symptoms for the factor 7 deficiency is predominantly mucocutaneous type of bleed, with the epistaxis may predominate, gingival bleeding is process. But again and again, 10 to 15% of these patients may have CNS, GI, and hem arthrosis. And still, and where to think in this patient, with some correlation, but it is not a strong correlation between the factor level deficiency and the symptomatology. What is the hemostatic level? There is some agreement about 20% as a hemostatic level in factor 17, factor 7 deficiency. But even in asymptomatic patients who may undergo major surgery, you may anticipate that they may have some bleeding, so that some prophylaxis and some therapeutic measures, they may be needed. And this is what you can give for your patient. These are some options regarding the recombinant factor 7, PCC, and the possibility in some poor countries for only fresh frozen plasma. Some talk about, is there any correlation between the factors? Some agreement that if it is lower than 2%, more likely to have severe bleeding, and more than 20%, most likely they have asymptomatic. But interestingly, there are some patients who have a factor level between 20 and 50%, and they have some bleed. And there are some patients who have level less than 1%, and they are unexpectedly asymptomatic, so that you can't say there is strong correlation between the factor 7 deficiency and the bleeding profile. These are the options: factor 7, prothrombin complex, and fresh frozen plasma still is there, even is rarely used. And these are the products that you can supply to your patient. Now, for surgical procedure, recombinant factor 7 is given in a low dose rather than in a high dose to achieve this hemostatic level, something close to 20%. It is repeated every 4 to 6 hours for the duration of the surgery and the duration of the anticipated time for possible wound healing. And still it can be used even in patients with higher level, but with a strong personal history of significant bleed. You can supply this drug. This is the United Kingdom recommendation guideline in factor 7 deficiency. When they consider these patients at higher risk when they have a factor 7 less than 10%, the definition of severe. And if they are at a higher risk, if they have also concomitant coagulopathy or a personal history of some bleed. For mild, moderate, for mild bleeding or minor surgery, you can use non-replacement type of therapy, just adjunctive type for strengthening of the fibrinogen clot using tranexamic acid as antifibrinolytic. This is a good choice in some patients. But for severe bleeding or anticipated severe bleeding, if they will undergo for major surgery, consider recombinant factor 7A in this low dose rather than high dose, and it can be repeated for 3 or so doses. Now, this is regarding case 1. I have only other 2 cases. I will talk in a brief about them. This is a 13-year-old male patient who presented with a prolonged bleeding after wisdom tooth extraction. There was no prior history of unexplained spontaneous type bleeding, but there is a family history of heavy menses in his sister, and his sister, she had excessive bleeding after tonsillectomy surgery. This is after surgery, and the parents are first-degree relatives. Upon examination, the patient is normal size, vitally normal, but he has continuously and continued oozing from the side of tooth extraction. Where to go in this patient? Some blood test and consider the expert opinion. This is your differential, not only for the primary, but also possibly for the secondary homeostasis regarding the platelet and the coagulation factor deficiency. CBC was normal for this patient, while the PT is normal, PTT was a problem. Thinking of the intrinsic pathway, doing more coagulation factor assay. After mixing study, it was corrected. It is a factor deficiency. You did some more factor. Factor 11 was revealed to be 10%. Where to go in this patient? This is a factor deficiency with a prolongation of PTT. You can anticipate it there after excluding hemophilus. This is the second in common of these rare bleeding disorder. It is activated not only by factor 12, but also by thrombin after generation to continue the cascade by activating factor 9. Then the tinase complex, which will activate factor 10. This is the half-life, which is close to 48 or 2 days. But here, in this factor element deficiency, there is a very weak correlation, even weaker with what the factor 7 has between the factor deficiency and the bleeding profile. In homozygosity of factor element deficiency, when the factor level less than 15% and heterozygous, they may have it above 15%, but still this classification, this stratification does not reflect the actual bleeding risk in these patients because of poor correlation between the factor level and the bleeding pattern, so that the personal history is very important. So that all level of factor element deficiency can present with a bleed, usually after surgery. Spontaneous bleed is very rare. They are detected usually after surgery, especially in sites with high fibrinolytic activity like the mouth, nose, or genitourinary tract. Now, your options other than the factor element concentrate, what we don't have, we give actually the fresh frozen plasma for these patients. This is the United Kingdom experience. For factor element should be identified as at a higher risk for bleeding if the factor element is less than 10%, but still the personal history of a bleeding is very important. And if you go for surgery, like dental extraction or oropharyngeal or genitourinary mucosa, you consider your patient at special risk for bleeding. And when the factor is less than 10% and the patient was exposed before for this factor, you have to do factor 11 inhibitor even before surgery, and this is actually mandatory. For minor bleed, they consider antifibrinolytic agents like tranexamic acid in this dose. But for severe bleeding, you can give, other than the factor 11 concentrate, what we don't have, fresh frozen is a good option. And we used it in these patients with a dose of close to 15 ml or even 20 ml per kg. But concomitantly, it is preferable with tranexamic acid as alternative and to factor 11 deficiency concentration. And I will talk briefly, only a few minutes, about the last case. This is a patient, male patient, whose age is 3 days. He's a product of full-term normal vaginal delivery. But the patient is having some umbilical bleeding with umbilical cord hematoma, and still the patient has more and more oozing, and vitally, he is normal. What you did do for this patient, you did some blood testing. Apart from the CBC, also you did PT-PTT for this patient, and keeping this differential in your mind, the CBC was close to normal apart from the hemoglobin, which is considered low at this age within 3 days, but both PT and PTT, both of them, they are prolonged. Why? And when you did the fibrinogen level, it was revealed to be 0.15 gram per liter, which is low. Now, regarding fibrinogen disorders, we have the quantitative afibrinogenemia or hypofibrinogenemia and the qualitative dysfibrinogenemia or hypodysfibrinogenemia. And fibrinogen deficiency, fibrinogen disorders, they constitute 8% of these rare bleeding disorders, and these rare bleeding disorders are 3 to 5% of all inherited bleeding disorders. And regarding the severity, if it is less than 0.1 gram per liter, actually, in other labs, it is less than 10 milligram per deciliter, then it is severe. 0.1 to 1 is moderate, and above 1 is mild, so that you can use the definition of afibrinogenemia on those below 0.1. Those above 0.1, they are hypofibrinogenemia. But when the fibrinogen is above 1.5 gram per liter, and the patient has some abnormality regarding this, the abnormal TT, you may consider this is dysfibrinogenemia. And the fibrinogen is needed not only to form the fibrin clot, but also it is important for aggregation at the glycoprotein 2B3A. And the half-life is close to 4 days, and this is what we need. These are the definitions, the quantitative and the qualitative. This shows us how it's heterogeneous, even the fibrinogen defect, as part of the very heterogeneous category of the rare bleeding disorders. This patient, more than 85%, they present with umbilical stump bleed, but they may have other types of bleed, platelet type of bleed, like mucosal epistaxis or menstrual type of bleeding, but also deep-seated bleeding. They are there even more rare than others. Now the inheritance, we know about the inheritance, and the important part in this slide is the strong correlation, something mimicking hemophilia. Strong correlation between the factor level and the bleeding pattern. This is important to remember in a fibrinogenemia, so that if you rise the factor up, you anticipate good hemostatic control in these patients. The treatment, either you give the fibrinogen, what we don't have, but still we are using the cryoprecipitate, which has a good percentage or a good constituent of this fibrinogen. In mild micronucleus bleeding or minor surgical, you can use the adjunctive type of a treatment. And the last two slides, the United Kingdom recommendation in this: for mild bleed, use the antifibrinolytic; for severe bleed, fibrinogen. If you don't have, you can have the alternative. The alternative is a cryoprecipitate. You can use it safely in these patients, and thank you.
شكرا دكتور ماهر، شكرا.
شكرا دكتور ماهر، يعطيك العافية وللجميع. I think we have some time for some questions for all the. We have some time for some questions, and we will open the questions. For Dr. Maher, Dr. Suleiman, and Dr. Ali, not for only Dr. Maher.
دكتور باسم برقاوي. الو
سامعينك يا
دكتور نبيل علوش معك.
تفضل.
بدي اسال الدكتور ماهر، اول شيء بدي اشكره على المحاضرات، بالفعل انها اب تو ديت. بدي اسال الدكتور ماهر بالنسبه للديسفاجورجينيميا، هل هي علاقه بس في البليدنج ولا في ريسك اوف ثرومبوزز اولسو؟ لانه نون انه الديسفاجورجينيميا كان انديوس ابورشنز. بدي الكومنت تبع والله.
اوكي، هيك سامعيني ان شاء الله؟
نعم.
شكرا على thank you for this very good question. Now regarding this fibrinogenemia, it is not only associated with the bleed, but also with the thrombosis. And in the literature, you can see something described as bleeding dysfibrinogenemia and sometimes a thrombotic dysfibrinogenemia. And they are talking now about the pathogenesis, and there is very much debate why this fibrinogenemia, they have more thrombosis, some thrombosis. And one of the theories, and the strong theories, now when the fibrinogen is not functioning well, the thrombin will be more and more. It will be more excess thrombin. So this thrombin actually, when we have fibrinogen, normal fibrinogen, it will be consumed because it will convert the fibrinogen into fibrin, which means it will be consumed. If it is not consumed, may make more thrombin burst. This is the mechanism, the most likely mechanism, but there is not much consensus. Another question, if the patient with this dysfibrinogenemia developed thrombosis, where to go on this patient? And still, this is a very debatable issue. Shall we give this patient who has a problem with the fibrinogen and he has some thrombosis, shall we give him heparin? And we anticipate them to bleed if they have some fibrinogen. And because of this debate, they are now talking, yes, you can give not only heparin, but also concomitantly fibrinogen with the heparin to consume the thrombin as the anticipated theory. And there are many talk and many case reports regarding this issue. Yes.
Thank you.
Dr. Abdullah.
excellent presentations. My question is to Dr. Ali Tahir Abdullah Abadi concerning the acquired hemophilia A. I don't know what
لا مش عم بسمع الصوت أنا.
شو أسوي؟ هلا سامعني هيك؟
إيه هلا سامعك.
Okay, I'm saying we're concerning the acquired hemophilia A. I'm noticing it's more and more in clinical practice than years before. The management is rather difficult. Can you just work out through the management of a classic case with hemophilia A, please? With acquired hemophilia A?
كان عم بقطع الخط بس عم تسألني إذا what is the classical management of a patient with hemophilia A bleeding?
Acquired hemophilia A with bleeding. Can you just sum it up for us? Take us in the journey of
According to the summary of the last paper 2021 end of the year by Hematologica, which was by Giangrande and the team, it was very clear that the first line treatment is recombinant factor 7 to stop the bleeding of those patients. I mean, this is the first line management, and even if not, even in the salvage, it is the line of treatment. هلا ما عم بحكي عن الانهبيتور لانه I didn't consider the inhibitor as part, but in parallel then one would treat the inhibitor, as you know, by steroids plus or minus cyclophosphamide, using rituximab as a second line. This is in the last review, although a lot of the physicians use it as a first line, and at the same time treating the underlying disease. إذا كان في underlying disease, but we know that in 50% of acquired hemophilia there's no underlying disease.
Question to Dr. Steman. Steman, are you first?
بسمع بدهم.
Steman.
تفضل دكتور عبد الله.
Concerning bleeding, so in your practice, which one?
الصوت مش واضح دكتور عبد الله.
عم نسمع عبد الله ابدا.
الصوت مش واضح نهائيا يعني ما.
I'm asking about the intracranial bleeding and rare bleeding disorders. In your practice, which ones are mostly the CNS bleeding is seen in which ones of those rare bleeding disorders?
From my experience in the state and Jordan and Saudi Arabia, like CNS bleeding mainly in factor 13 deficiency. We collected around 20 patients in King Faisal in Riyadh, and around 30% of the patients they present with CNS bleeding. And not only that, some of these patients, the first presentation for them, intracranial bleed. So that's why most of the recommendation now to give prophylaxis in patients with rare bleeding disorder, you put one of them factor 13 and one of the top to give prophylactic for them as early as soon as possible. The second one is factor 7 and factor 10. Factor 7, as Dr. Maher mentioned, is not consistent in all the patients, but I saw a family in the northern part of Jordan, 3 siblings, and all of them, they have intracranial bleed. One of them died from the intracranial bleed. Factor 10, yes, can present with CNS bleed, but because of the rarity of factor 10 deficiency, so it's you don't see a lot of patients with this presentation. But the top of them is factor 13 deficiency. I strongly recommend for factor 13 prophylaxis for these patients to prevent the CNS bleed, as the prevalence is very high, 25 to 30%.
Dr. Sulaiman, can I ask you a question?
اتفضل دكتور موسى.
Have you any statistic about the incidence of disorders in north of Jordan? Because in our experience, we haven't a lot of
No, we don't have any registry or actual numbers like that. Qatar patients, and the problem with the patients, they are traveling or from one institution to another. So sometimes the patient, depending on the referral insurance. So sometimes you see the patient, same patient, in the Ministry of Health, maybe in the Royal Medical Service, sometimes in the university. We don't have registry and we don't have actual number.
Hello.
Hello. الصوت مش واضح، الصوت مش واضح ما
سامعني دكتور هيك تمام؟
اوكي.
بس قرب على الميكروفون دكتور سليمان وعيد آخر شيء.
بالنسبة ما سمعت السؤال، يعني ما سمعت السؤال.
السؤال any statistic about your about the rare bleeding disorders in north of Jordan?
لا, we don't have. Even in Jordan, we don't have. Even in the neighboring country, as I mentioned at the beginning, we don't have any statistic number. It's like a scatter number. You see patients in your clinics, but we don't have registry. We don't have the number.
Most of the cases you have seen, what was?
Most of the cases, factor 13 in Saudi Arabia, factor 10 and 7. In Jordan, in my clinic, most of them factor 7. You see maybe one patient, factor 10 I have, but most of them factor 7 deficiency. And factor 1 fibrogenemia. We have a cluster of patients with a fibrogenemia, especially from Josh. We have, I think, 5 patients from fibrogenemia or hypofibrogenemia.
شكرا للجميع، شكرا للسبيكر. دكتور عبد الله حاب تيجي بس تنهي اليوم الأول خلاص؟ تفضل.
Thank you all for our speakers. Thank you all for the audience for enduring a very hectic day. And I think we had an excellent presenters. We had excellent topics. And I'm sure everybody made use of the shared with our colleagues. And I look forward to seeing you tomorrow. Tomorrow we will be starting at 2 o'clock. Again, our program will be just as busy, just as rich as it is today. Thank you all and have a nice night. Good night.